अलग से आ गया, 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 अलग से आ गया 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 अलग से आ गया
हेलो
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 अलग से आ गया
Good morning, ladies and gentlemen. It's a great pleasure and honor to welcome you all for this academic feast, Hemonet 2026, the global advances in hematological malignancies and the key insights from the recently concluded ASCO. Good morning, ladies and gentlemen. This is done under the It's a great pleasure and honor to welcome you all for this academic feast with the great Hemonet 2026. I would like to invite the global advances for the welcome and set in the context for today. Dr. Nitin Sood, Vice Chairman, Medical Oncology. Good morning, ladies and gentlemen. This is done under the It's a great pleasure and honor to welcome you all for this feast with the great Hemonet 2026. I would like for his wife, the global advances for the welcome and set in the context for today. Dr. Nitin Sood, Vice Chairman, Medical. Good morning, ladies and gentlemen. This is done under the it's a great pleasure and honor to welcome you all for this series of the great Hemonet 2026 for his wife, the global advances for the welcome and set in the context for today. Dr. Nitin Sood, Vice Chairman, Medical. Good morning, ladies and gentlemen. This is done under the it's a great pleasure and honor to welcome you all for this series of the great Hemonet 2026 for his wife, the global advances for the welcome and set in the context for today. Dr. Nitin Sood,
strengthening our
Vice Chairman,
commitment to our
morning,
patients.
ladies and
Hematology has
gentlemen.
always been a fascinating field. The presence here really bridges the gap between diagnosis and clinical patient care and advanced knowledge. Although the pace of progress in hematology in the past decade has been great, there are still challenges that we have to address. We've witnessed remarkable advances in next generation sequencing. Although the pace of progress in hematology, precision medicine, allowing us to classify there are still diseases that we have in a much better way and to witness remarkable treat them in a much more precise way than we used to. Turning diseases which were deadly in the past, allowing us to more manageable chronic diseases. There are cellular therapies which are changing outcomes now. Treat them in therapies which are changing outcomes in precise way than inherited disorders. Turning diseases at the same time advances in the past. Supportive care have manageable outcomes by several dimensions. Cellular therapies. Yet these achievements leave many challenges in outcomes to be addressed. Inherited disorders, especially challenges that are at the same time advances in terms of supportive care, health distribution, and in terms of several dimensions. Financial constraints that are many patients might leave many challenges. So really, we have to find our own solutions to our own problems. Challenges that are and over the next 2 days, we will address supportive care, health distribution. Really, I don't want you to treat this meeting as a series of lectures. I want you to participate. Leave many challenges. So really, we have to find our own solutions to our own problems. Challenges that are and over the next 2 days, finally, I hope these 2 days will be very useful and you can take some practice. Really, I don't want you to take learning from this meeting as a series of lectures. I want you to participate on these lectures. We have to find our own solutions. With that, I extend a very warm and thanks to you. I hope these will be very useful and you can take some practice. So, with that, learning from this, I shall introduce our first speaker, Dr. Tejaswini. Lectures. She's my colleague, and with that, I extend a very warm and thanks to you. I hope these will be very useful and you can take some practice. So, with that, learning from this, I shall.
So, thank you, Dr. Nitin sir, and now we set the ball rolling. So we have the first session which is dedicated on AML, and to chair this session, may I have a pleasure to welcome and invite Dr. Amit Bhargav sir on the dais. Dr. Amit sir, can we request you to please come forward and we request you to start the proceedings. So we have the first session which is dedicated on AML, and to chair this session, may I have a pleasure to welcome and invite Dr. Amit Bhargav sir on the dais.
Thank Dr. Nitin and the organizers. So it's an honor to start this meeting.
So we have the
Without
first
any
session
delay, I
which is
would invite
dedicated
Dr.
on
Tejaswini.
AML,
I know
and to chair this
Tejaswini
session
for a very long
on
time,
AML,
and it's a
and to
pleasure
chair
to
this
listen to
session
her.
on AML,
And it's a
and to
pleasure
chair
to
this
listen to
session
her.
on
Newer developments in management of AML that is beyond 7 plus management of AML been doing for beyond 7 Dr. Management of AML been doing for beyond 7 Dr. Management of AML been doing for beyond 7 Dr.
Thank you, sir. So, thank you, sir. The topic that's been given to me is new frontline paradigms. The topic that's been given to me is new frontline paradigms. So this is the ELN risk stratification for patients who receive ELN risk stratification. And as we can see in the graph on the right, that the long-term survival probability for the favorable risk falls just under 50%. For the favorable and for the intermediate risk and for adverse for the intermediate risk and for similarly for patients who receive who are similarly ineligible for intensive chemotherapy and receive azacitidine or ineligible for intensive chemotherapy and receive the outcomes have significantly improved with azaven. However, long-term cures still do not happen in men. However, and most patients, as we know, relapse around the 1.5 years. And most patients, so in our patients with adverse risk, in our patients with pediatrics with patients who are intensive chemotherapy ineligible, patients also favorable risk patients who are MRD positive. Transplant still offers a potential for cure. Transplant still. The most important question is, what do we give our patients to bring them into remission? What do we give our patients to bring them into? So one of the most important studies in the recent times covering this topic is the paradigm trial, in which azacitidine and venetoclax for the first time in which azacitidine and venetoclax trial was tried in patients who were fit for intensive trial. So these were patients who were newly diagnosed AML, greater than 18 years of age, and were intensive chemotherapy eligible. Very important to note is that they did not include patients with binding factors mutated. FLT3 AMLs were excluded. NPM mutations were excluded when the patients were young. NPM and BCR variants were excluded when the patients were young. Patients were either given standard of care, which was C+7 or CPX followed by reinduction with or without consolidation, depending on how well they were doing. With or without consolidation, depending on how well they were doing. And they were all allowed to bridge to transplant. The primary endpoint was EFS. Secondary endpoints were allowed EFS. Secondary endpoints. So the baseline characteristics: 12% patients had favorable risk. 12% were in favorable category. 15% were in the intermediate risk, and 72% were in the adverse risk category. There were equal proportions of TP53 and PM1 IDH1 mutations of TP53 and PM1 IDH1. So the distribution was quite balanced. The median number of cycles was 4 for azaven and 2 for median number of cycles was 4 for azaven and 2 for median number of. The results are extremely interesting. The CCR rate, the results are 81% with azaven versus 55% with 1% with azaven. Very promising results for azaven. Similarly, CR rates 59% for azaven. Similarly, CR rates 59% for azaven. 61% patients who received azaven were able to bridge to transplant as compared to 40% able to bridge to transplant as compared to. And the 1-year EFS was 53% for azaven, and the 1-year EFS. So azaven outperformed and the 1-year intensive chemotherapy. So azaven in these patients, intensive chemotherapy, all your response in these patients, intensive chemotherapy, all your. Looking at the safety profile, patients who received azaven were less likely to need ICU. Patients who received 0% for azaven, 9.8% ICU admissions. 0% for azaven, 9.8% ICU admissions. Azaven patients had fewer IPD days for the primary admission as well as during the first IPD days, which is quite a admission as well as during sepsis occurred only in 7% patients who received azaven as compared to 11% patients who received sepsis occurred. 60-day mortality was 0 in azaven and 2.7 in intensive. 60-day mortality was 0 in azaven. Quality of life, again, a very important thing for our patients. Quality of life better for azaven, and there were less depressions for azaven, and there were less depressions for azaven outperformed intensive chemotherapy for EFS. Azaven outperformed for ORR, for quality of life, and most importantly, almost 20% more patients were able to receive a transplant in the azaven as compared to receive a transplant in the azaven intensive chemotherapy. This is just a repetition of the numbers. Intensive chemotherapy. However, one thing to keep in mind is that the patients with binding factor FLT3 were not included. So that this is not something we want to give to patients. That this is not something we want to give to. The next important trial, which is quite practice changing, next important trial, which is agile trial, which is the use of azacitidine with ivosidenib in IDH1 mutated AMLs who are ivosidenib therapy in IDH1 mutated AMLs. So in this trial, newly diagnosed IDH1 mutated this trial, newly diagnosed 18 years or 1 and ineligible for intensive chemotherapy primarily because of ineligible performance status or because of their comorbidities were selected, or because they either received ivosidenib with azacitidine or because as a 28-day ivosidenib or placebo with azacitidine. As a primary endpoint was EFS, secondary endpoint was response. Secondary endpoint was response. So the primary endpoint, which was EFS, at a median follow-up of 12.4 months, the hazard ratio for an event occurring was 0.32 in favor of the ivosidenib, and the difference was statistically significant. Among the secondary endpoints, the median time to CR was slightly higher in the ivosidenib arm as compared to placebo. The difference was not significant as compared very different. Probably the reason for this is because ivosidenib is differentiating. reason for this is it takes a little longer to the patient probably the reason for this. But the CR rates per se were significantly better. 47% per the ivosidenib and 57% per the ivosidenib. The median duration of CR was not reached for the ivosidenib and was 11.2 months. And was 11.3 was not reached. Among the secondary endpoints, overall survival, again at a median follow-up of 15.1 survival, the hazard ratio for death was 0.44 in favor of the ivosidenib. Coming to the side effects, febrile neutropenia not very different in the two arms. 28%, 34% patients had grade 3 or higher febrile neutropenia in ivosidenib versus the placebo arm. Some of the side effects that are unique to ivosidenib are the prolongation The third important study I would like to cover today is the Viceroy study. Us have tried triple drug combination for patients in some capacity. However, we all have at some point faced significant side effects. I think most of us have tried significant relapsing therapies. The Viceroy study was a study conducted in the newly diagnosed AML patients who received newly diagnosed and they were given azacitidine, venetoclax, and they were given. Now this was a multi-center open-label randomized phase 1 dose finding expansion study. In this newly diagnosed with 3 AML patients who were ineligible for newly diagnosed with 3 AML patients who were ineligible, they either received venetoclax 200 mg or venetoclax 400 mg, and the dose chosen for giltertinib is not your 120 mg here, it is 80 mg because is not of the anticipation of severe cytopenias in such patients. The endpoints were being a phase 1 and 2 trial, they were efficacy. The endpoints were being a phase 1 and 2 trial, they were efficacy. Very important in a phase 1 and 2 trial. Across the board in some of these triple drug combination trials is because we are anticipating severe cytopenias with venetoclax and giltertinib together. Almost all these trials perform a bone marrow biopsy on day 14 and if the blast count is less than 5%, they stop both venetoclax as well as giltertinib, not just one. Similarly in this trial, this was followed, not just one. And similarly in this trial, further exposure of venetoclax and giltertinib was tapered depending on the patient's toxicity in the subsequent tapered. GCSF was given to patients even in the first cycle if the bone marrow was in remission and they had not recovered their counts beyond the ANC of 500 by day 42. Baseline characteristics in the two doses. The 400 mg venetoclax had slightly higher FLT3 ITD patients. This was not a randomized control trial, so that can happen. And the 400 mg patient dosing also had slightly older patients, 77 being the age for the 400 and 73 in the 200 mg age group dosing. And FLT3 ITD 83% versus 65%. The average time to hematological recovery was 38 days in the venetoclax 200 mg arm, and in the 400 mg arm it was 42 days. The blood levels of giltertinib were not different in the two arms, so there is no worry of the interaction of giltertinib with venetoclax. The results in terms of CR and composite CRs were quite similar. In the Ven 200 arm, it was 70% CR versus 65 in the Ven 400 arm, and about 90-91% of composite CRs in the two arms. Now, naturally, we look at this data and we think that if 200 mg of Ven is doing as good as, if not slightly better than the 400 mg, we can probably give the 200 mg. But when they saw the long-term data, there was a different picture. Patients who received 400 mg of venetoclax actually demonstrated an overall survival over the patients who received the 200 mg dose. So the 12-month OS was 77% in the 400 mg arm versus 64% in the 200 mg arm, which is why the final dose with giltertinib 80 mg for venetoclax is 400 mg. So coming to the next category of drugs, which are again, really upcoming in hematology, are the menin inhibitors. They work by physically binding to the menin protein, preventing it from interacting with the KMT2A fusion protein. So here we can see, basically what happens is that menin and KMT2A, they form a complex and bind with the promoter and prevent it from working. leading to a differentiation block by upregulation of genes such as HOXA9 and MEIS1. When the revumenib binds to this complex, it does not let it bind to the promoter region. As a result, the differentiation block is lifted and cells can then differentiate from primitive cells into more mature, normal myeloid series. Historically, these patients have a very dismal prognosis. Less than 10% achieve remission even after 3 lines of treatment. So definitely a case for, more research in terms of drug development. A lot of menin inhibitors have, been tried, and there are a lot of menin inhibitors in trials right now. The one we are going to focus on today is revumenib, which is a potent oral selective inhibitor of the menin-KMT2A interaction. It's currently FDA approved in the relapse refractory setting based on the results of the Augment 101 trial, wherein monotherapy with revumenib led to overall response rates of about 43 to 60% and CR rates of about 30%. However, today we're talking of the role in the first line. So there is data of revumenib in the first line setting in a phase 1 and 2 trial, which is the SAVE trial. These are newly diagnosed intensive chemotherapy ineligible patients. This trial also had relapsed refractory patients. So the age cutoff was 21 and above, and AML or MPALS with KMT2A or NPM1 mutation or NUP98 rearrangements were taken. This received revumenib. 2 different doses were tried with CYP inhibitors in combination with decitabine and cedazuridine and venetoclax. Again, similar to the previous triple drug combination, a bone marrow was done on day 14, and if the blast percentage was less than 5%, the oral drugs were stopped. Patient characteristics: this is a small trial, being a phase 1-2 trial. 17 patients treated. The mean number of cycles given were 3, and 65% patients had NPM1 mutations, 35% had KMT2A mutation, and the median age was 68. 24% had secondary or therapy-related AML, so not very good, genetic milieu. And significant number of patients had FLT3 KIT, KRAS, NRAS KIT co-mutations. The numbers are small, but the numbers are very impressive again in this trial. The overall response rate was 94%. Mind you, this is a group that usually does not respond to therapy. Among evaluated patients, CR rates was 88%. All patients were MRD negative by flow cytometry, and all KMT2A patients were negative by FISH. The MRD negativity in the NPM1 group by NGS was only 44% though. And at 6 months, the median OS and EFS was not reached. And 5 patients could also be bridged to transplant. Relapse occurred in 2 patients who had not undergone a transplant in CR1, and both had detectable MEN1 mutation at relapse. 2 patients also resumed revumenib as maintenance post-transplant, and 1 patient had a detectable FLT3 ITD and NPM1 mutation at day 60 post-transplant, which actually became negative later on. Again, very small numbers, but the numbers do appear promising. Coming to the safety profile of this drug, the median cycle length was 41 days. Again, significant cytopenias do occur with these triple drug combination. The most common adverse effect was infection, which was in 53%, and all were grade 3. There were patients who also had QTc prolongation and differentiation syndrome. So coming back to what is standard of care and seeing how much of the newer things have been incorporated. Patients, this is a usual graph for patients who received high intensity chemotherapy. As we know, patients who have co-binding factor should receive your standard intensive chemotherapy with the addition of ideally gemtuzumab ozogamicin. We know that from the individual patient random meta-analysis that it is helpful in overall survival for your favorable risk patients. FLT3 mutation, again, Ratify has set the standards of intensive chemotherapy with midostaurin. For patients who have AML, MRC, or therapy-related AML, we can use CPX-351 because it does give about a 10% to 15% both advantage in CR rates as well as overall survival. But I think an important question to ask today is that with the presence of azaven, would we really go for intensive chemotherapy in such patients? For TP53, even CPX-351 does not do very well. The trials with magrolimab have not done well either, so azaven remains our usual strategy. Most important is to put these patients into a remission, preferably an MRD negative remission, and then take them up for transplant in terms of if they are favorable risk or intermediate risk. For AMLs who are high risk and intermediate risk, for patients who are favorable risk, we can no longer just consider the baseline genetics and act. We have to look at the MRD. We'll be covering that shortly. For the patients who receive non-intensive chemotherapy, if they have an IDH1 mutation, your AZA with ivosidenib is one of the good options. Slightly, although not comparable not compared yet in a head-to-head trial, but the outcomes are slightly better than with venetoclax. With FLT3, again, azaven remains the standard of care, but there are triple drug protocols that are being tried. Again, very important to put them into a remission, and for high risk and intermediate risk, if the patient is fit enough, should be transplanted. Those who have favorable risk can continue therapy. A very quick look at the MRD. Nothing has changed dramatically. I think there is just more data in support of the existing evidence. For RUNX1 patients, we know that if they are MRD positive at the end of 2 cycles of intensive chemotherapy, they should be taken up for transplant. They benefit significantly. And for patients who are NPN1 positive, again, if the MRD is positive, preferably done at the end of 2 consolidations, the overall survival is 61% as compared to 24% who did not receive a transplant. That's all. Thank you.
Thank you, Tejaswini, for maintaining the time. I think so we have time for one question, and then we can move on. Yeah.
So, excellent talk. The trial about azaven followed by transplant. The
paradigm study.
Yeah, the paradigm study. So, the number of patients that can undergo transplant is extremely small. The Hematology Consortium, it says about 1.8% of total patients underwent transplant. So what would you do for those who are not undergoing transplant, azaven or standard 7+3? Because that is a definitive therapy versus azaven just kind of continues, and how long to continue we don't know.
I think that's a very important question in the Indian context, because while a lot of patients may be eligible for a transplant, financially many patients still can't receive one. In that case, I would still say for young fit patients, I would still consider intensive chemotherapy. Yes.
Thank you, Tejaswini.
Thank you, sir.
Now I'd like to invite our second speaker, Dr. Chaitanya, who would talk on high-risk AMLs. We often face situations where we get these kind of patients. So over to Dr. Chaitanya, please.
Good morning, everyone. At the outset, I'd like to thank Nitin sir and the Hemonet team for giving me this opportunity. So today I was given the unenviable task of talking about high-risk AML, which keeps most of us awake at night. What has changed in the last year or so? And there are 3 main overlapping biologies that we talk about: TP53 AML, secondary AML, and MDS-related AML. I'll talk about each one. So I'd like to start off by saying that what ICC and WHO reclassifications taught us is that no longer do we look at a blast count. High-risk AML is defined by biology. And this has shifted from looking at complex karyotypes and monosomies to looking at NGS-based gene-related mutations, which tell you that they have a secondary biology or an MDS-related biology. And this is extremely important in our Indian context because, as we know, our Indian patients who have MDS type biology present at least a decade or two younger than the Western counterparts. Hockman's analysis showed that if you apply the ELN 2022 risk stratification, especially with TP53, it gives you a better perspective on treatment rather than just a prior history of therapy. So label them based on history of prior therapy or MDS is not as important as doing the gene mutations. So these three high-risk AMLs are actually not very distinct. There's a lot of overlap, and there are three overlapping phases of the same problem, which is three things: clonal complexity, inherent chemo resistance, and a natural history to relapse. And this is the biggest game or the biggest challenge that we often face. And the AML 19 trial showed that in their data population, TP53 was present in almost 43% of their adverse complex karyotype or high-risk AMLs. The ELN 2022 risk stratification added secondary type mutations, and the 9 mutations in addition to TP53 and your adverse risk karyotype and BCR-ABL became the ones that showed you that the patient has an MDS type biology at presentation even in a de novo AML, and these made it adverse risk, and this is the classification that we all follow now. But the same group, Donner et al. In 2024 said that the criticism on 2022 was that all those risk categories were used for patients who received intensive therapy. And have we all moved away from intensive therapy to AZA-ven? Absolutely. And in that context, the 2024 risk stratification said that if you've decided to give an elderly or unfit patient AZA-ven, you need to use a repeat or a reclassification to stratify them. And that said, NPN1, IDH1 or 2 with DDX41 without TP53 or FLT3 or RAS becomes favorable in an AZA-ven cohort. FLT3 and or NRAS or KRAS becomes intermediate. But at the end of the day, our biggest unmet need is on the right side of your screen, which is TP53. It is irrespective of what you use, that is the one that we are really not able to fight. What is common? I mentioned chemo resistance as one of the common overlaps. And if you look at this data, you'll see that patients with favorable risk AML have a median OS of more than 60 months. We know this. But you look at the 3 high-risk AMLs, which I'm going to talk about today, all 3 of them are in the matter of less than 12 months, and maybe MDS related, you can push them to 14.7 months. So at the end of the day, having high-risk AML, your median overall survival is extremely poor, and this is where the biggest challenge lies for all of us in the room. So what is the framework to approach them before I attack each one? The framework is that we have to understand that the fitness of the patient at diagnosis determines what choice of therapy you give. But the ultimate outcome, whether you have a 30-year-old with a TP53 mutation or you have a 75-year-old with a TP53, the biology determines the ceiling and thereby the outcome. So fitness only allows you to what regimen you can deliver safely, but it's ultimately the biology which decides it. Sorry, there's something on the screen. Yeah, got it. Sorry, thank you. Right, so we'll talk about each high-risk AML, and the first one is TP53. So as we know, this is the guardian of the genome, and TP53 loss of P53 dismantles the cell's entire stress response program. Now, when you lose TP53 or when you have TP53, the apoptosis machinery that you're hoping to target with chemotherapy or venetoclax is disabled. So whatever therapy you give hoping to induce apoptosis is unfortunately going to fail. And 80% of patients have mutations in the DNA binding genome, which can be of 3 types. The most common is a loss of function, but you can also have a dominant negative where you lose the TP53 has a negative effect on the intact or the wild type of TP53 coallele, or you can have an oncogenic gain of function. So in this paper by Grob, he said there's something called the Grob criteria. I mean, this is not accepted all over, but this was well published. And Grob said it's not just the mutation that makes a difference, it is the allelic state. And he found that if you have monoallelic TP53, WAF less than 10%, a normal chromosome 17, that small minority of patients with TP53 are not all bad. You can still get away with intensive chemotherapy and decent median overall survival. But if you have more than 2 TP53 mutations, a complex karyotype, and 17p loss, with a VAF of 50 to 55%, then you are looking at dismal outcomes. And this was done in data over 400 TP53 patients where they looked at this. Where does venetoclax come in TP53 AML? And venetoclax is not a game changer like other adverse risk AMLs. It may, as this is the YLA trial, which looked at TP53 and poorest cytogenetics. And you can see while it gives you 41% CR versus AZA alone, which is why we've all adapted to it, the median overall survival doesn't change much. So irrespective of what backbone you use in TP53, you're not looking at great median overall survival. And this was again published in a Command Real World Consortium, where they looked at close to 300 patients, where they did again HMA, Ven versus HMA, and they found while you get a better CR rate, your overall survival didn't change much. And in a real world setting, which is what we all encounter on a day-to-day basis, a 30-day mortality is actually higher with AZA-Ven than AZA alone, again, because of the cytopenias and the risk of infections. So if Ven is not going to work, will your intensive therapy with DA or FLAG work? Again, that small percentage of TP53 who are monoallelic with intensive induction may get you a median OS of 18 months. But if you have a multi-hit TP53, whether you use AZA-Ven or intensive chemotherapy, your cohort median overall survival is about 6 months at best. And this is the biggest challenge in TP53 that we face. So this particular data was published in ASH from the Northwell series. It looked at 104 patients, and they clearly said that you're looking at 6 months unless you're that small percentage, which is about 8 to 10% of TP53s. So then, okay, do we go in for transplant? And the CIBM TR registry looked at 700 TP53 patients and long-term follow-up. And again, it's a very humbling data that you look at, where adverse risk TP53 wild, 46% survival. But if you have a TP53 mutation with a normal 17p chromosome, your overall survival 5 years post-transplant, 35%. And half of that if you have a TP53 deletion. And the 5-year cumulative incidence of relapse is 66%, which means TRM doesn't lose the patient, relapse does. And again, this is going in with the theme of high-risk AML, where relapse is in the natural history. So is it all dismal in TP53? Magrolimab was supposed to be, as Dr. Tejaswini mentioned, was supposed to be a game changer, but unfortunately the ENHANCE-2 trial didn't work out. Iprinatopop, which is a P53 reactivator, again did not work out. So what they've decided is, if your P53 is defective, don't keep attacking it. Look elsewhere. And that's where immunotherapy and checkpoint inhibitors have started to come up. And CD123, so as we know, tagroxofos, which is used for your BPCDNs, has been combined with AZA-Ven, and they found some decent responses with them. There's also a CD123, CD3 bispecific called flotetuzumab, and that has shown a CR of 47% in relapsed refractory TP53 at 6 months. Anti-TIM3 antibody, sabatolimab with or without AZA, has also shown some promising data. But again, they have found that whether you use checkpoint inhibitors or whether you use any of these bispecifics, where do you use them? And their answer is to use them when the disease burden is least, and that's in the post-transplant MRD setting. So not upfront, in post-transplant MRD, and I'll be coming to the implications of that subsequently. The second high-risk AML after TP53, which gives us a little more hope, is secondary AML. And secondary AML, again, as I said, is a biology. Either you have a previous therapy-related, chemotherapy-related, or you have an antecedent MDS-MPN. Till many years ago, again, this had a dismal outcome. But CPX351 changed that. So liposomal cytarabine and daunorubicin co-encapsulated in a 5:1 molar ratio versus 7+3 was a phase 3 trial in patients between 60 to 75 with AML was published, and it showed that you got a median OS of 9.6 months, CRI of 48%, and a bridge to allo transplant, which improved from 25 to 34%. And this was across the board. And this was done in about 100 patients, which showed that CPX351 did allow you to bridge to allo transplant. What about younger patients? Are we going to give in younger patients? Yes. And the head-to-head was with FLAG-IDA. And this trial showed when they went FLAG-IDA versus CPX351, your overall survival didn't change much. But where CPX351 scored was one in a relapse-free survival, which was longer, 22 months versus 8.4. But more than that, they found that if you had secondary AML with myelodysplasia-related gene mutations, your your overall survival was more than double. So the CPX has equal survival overall, but in a specific subgroup, it does give you a survival advantage. And I think that is important in this particular study. And again, this was again the AML-19 trial. And again here, TP53 was the dominant mutation. This was real-world data. This was Peruzini's multi-center propensity match analysis, where they looked at 43 matched pairs of patients getting CPX versus FLAG. And again, you look at it, the CR rate may be slightly higher than FLAG-IDA. But where FLAG-IDA causes issues to us is invasive fungal infections. You have more than double the rate of IFIs, and thereby taking this patient to transplant is often challenging post-FLAG-IDA. There's also real-world data where they've compared CPX versus HMA-VEN, and they found that the median OS is the same. So, as we know in secondary AML, the only thing that defines cure is transplant. And if you look at the non-transplanted versus the transplant of 38 versus 75%, the obvious data says that you need to transplant these patients. CPX351 helps you get there. Right? So whatever chemotherapy regimen you use, you need to get them to transplant, because transplant is the only thing that has a 61% reduction in the overall mortality in secondary AMLs. Where does VEN come in? I haven't spoken about VEN in secondary AMLs. And VEN, again, in patients who are probably unfit, then AZA-VEN is a very, very good approach. Younger patient, we would still possibly think of FLAG-IDA. The caveat trial is something I'll come to later. It's an interesting trial published last year from Australia, where they've used a semi-intensive therapy, and they've defined something called a semi-fit AML, something which may be controversial, but I'll come to that later. And they found that induce with whatever therapy regimen, but your ultimate goal is transplant. The last high-risk AML I'm going to talk about is AML-MR, myelodysplasia related, which you can have if you have cytogenetics which have MDS, type karyotype, AML, myelodysplasia related gene mutations, or a prior history of MDS or MDS-MPN. As we know, the WHO and ICC release close together. There are a lot of, or not a lot of, but a few things which they both disagree on, especially RUNX1 and the TP53 WAF. But ultimately, as per the YLA trial, we know that in patients who have AML with MR, AZA-VEN is the backbone when you cannot give intensive therapy, with an obvious median OS, CR/CRI, and a 3-year overall survival advantage. But this is not the destination. This is a platform for you to take this patient to transplant, because like with secondary AML, myelodysplasia MDS related AMLs have to be transplanted, because that's the only one which has a definitive overall survival. So using AZA-VEN as a bridge to transplant is critical in this particular group. MRD again has been alluded to and will be spoken about, but as we know, MRD has become the common currency in AML. And in the last 1 year, we found that MRD negativity at transplant has the best overall survival. So again, you look at the 5-year ORS, and this is 34 versus 68%. This was in a group of 500 patients transplanted, and they found that having MRD negative gave you a 5-year overall survival of 58%. A recent abstract presented at EHA did something called the pre-transplant MRD and a chimerism score at day 28 and day 60 post-transplant. And they came up to a C-index of close to 0.8, which means that your pre-transplant MRD plays a very important role. Another important publication which came out in transplant cellular therapy and also presented at EHA was post-transplant HMA maintenance. And this trial looked at 3-year outcomes of HMA maintenance versus no HMA maintenance. And they found that you have an obvious reduction in cumulative relapse, a higher event-free survival, and a slightly higher overall survival. But when they did a subgroup analysis, they found that patients who had MRD at transplant and had MR-related gene mutations did best, which means that HMA maintenance need not be for all. If you're in MRD in CR1, you don't have an MDS-related gene mutation, possibly you can get away without HMA maintenance, but the best benefit is in patients who have MRD at transplant or an MR gene mutation. The AHA paper said that patients who had secondary AML post-transplant, the biggest risk factor was having MDS-related cytogenetics and not gene mutations. And in fact, they reclassified, saying in adverse risk AML should have something called adverse plus, which is MDS-related karyotyping. So to expand the framework I put up one, that fitness determines what regimen you're going to give, but the lesion determines the outcome and the ceiling. And the third thing is looking at MRD and consolidating. And I think this post-transplant HMA maintenance is something that the last 1 year has changed a little bit. My last couple of slides. One, this is the therapeutic armamentarium that we have. No longer is it just 7+3 or flag. We have Azaven, you have FLT3 inhibitors, you have IDH1 and 2 inhibitors, menin inhibitors. But what I'd like to point out is bispecific and checkpoints. I'm sure somebody will allude to that in the next few talks, is something that's coming up in AML, CAR-T as well. But all of that in the screen boils down to the blue in the right corner. That irrespective of what you do, your goal is to take them to an allo-HSCT. So this is from the Nasima Ganga et al. Paper published in 26, which has a simplified treatment algorithm. Not fit for intensive therapy when an HMA becomes your backbone, and if you have any of those genetic mutations, you can add the specific inhibitors if available. And again, some of the practical points we know, using posaconazole or voriconazole with when to adjust the dose. I'm not going to go into that. If you find that they have very poor ECOG status, you cannot give HMA when, but they're able to take single agents, then you have a bunch of inhibitors that we can use, which can be used as single agent therapy and can be given deliverable to patients. Of course, with supportive therapy in terms of transfusion, antimicrobial prophylaxis, watching for drug interactions and differentiation syndrome, which is something you see especially with the IDH inhibitors. Small box on the top right says if you cannot give any therapy, then it is just palliation. My last slide is, this is an interesting paper out of Australia, which said 85 older patients who are deemed semi-fit, not unfit enough to deliver some type of chemotherapy, but not fit enough to give intensive. They've given them, and they have multiple cohorts where they use venetoclax from doses of 50 to 600 with or without POSA. They've given 5 days of cytosine and 2 days of idarubicin induction with ven of 14 days, 4 cycles of consolidation with with cytosine on day 1 to with or without IDA and ven for 14 days, and maintenance venetoclax for 7 months at 14 days. And if you look at the data on the top right, I mean, this is 85 patients, they found that 88% CR/CRI, 33 months of overall survival, and 17.9 months of median treatment-free remission. So this is, again, phase 1B trial published last year. This is a space I'd like to look out for. So my final 4 take-home messages. High-risk AML is a biology. It's not the blast count or the morphology, it's the biology which determines how we treat. TP53 unfortunately still remains unsolved, and transplant helps a minority. Venetoclax only deepens the response. In secondary and MDS related, your target is allo. Use a clean induction like CPX351 to get there with minimal risk of infectious toxicity. And using MRD-guided transplant and targeted maintenance, either with HMA or checkpoint inhibitors, is where our 2026 data lets us add real value in this otherwise dismal space. Thank you so much.
Thank you, Dr. Chaitanya. I think so we are moving on to the panel discussion so we can keep all the questions for the same. I would like to invite my next moderator, whom I'm really keen to see because he was introduced to me by an AI. You put any query in hematology on an AI platform, it'll say refer to Dr. Riaz Ahmed. So I invite Dr. Riaz Ahmed to moderate the panel session. It's a pleasure to see you, Dr. Riaz.
Good morning, sir. Nice to see you, and thanks for the compliment. It was nice listening to Dr. Chaitanya. Actually, I learned a lot. Anas, it was very nice presentation. Okay, so I have been given a task of doing a moderation with relapsed refractory AML. We know AML is a bad disease. Relapsed refractory is even bad. So I'll call my panelist here, Dr. Rajan Kapoor, dear friend. If you can come, Dr. Chaitanya, you are again, and Dr. Vishnu Sharma, Dr. Gitanjali Uppal, and Dr. Shibal Mukherjee, if they are here. No, okay. Okay, next. Okay. Sure. So, anyway, so let's start. So AML, we know it's, we have been discussing good risk, intermediate risk, high risk, but we know it's a bad disease to start with. In India, we are still struggling with AML being the landmark for any hematologist, whether you can keep the patient alive for another 5 years. That's what we feel struggle. Lot of improvement. Gone are the days where only 7-3 was there and followed by transplant. Lot of new molecules, but still AML remains because one of the tough disease to treat, and even the new molecules are quite costly. So in Indian perspective, we are still struggling with AML, what to do, basic therapies. So what we are discussing is day-to-day practice, nothing big step, what the data says, how we are doing, how we are actually seeing in our day-to-day cases. So with this rate, I will go to a very simple case. Okay, now we know the 22-year-old male AML NPM positive, normal cytogenetics, treated with 7+3 regimen followed by 3 cycles of HIDEC chemotherapy, and achieved at the end of the chemotherapy have achieved MRD negativity. It was on regular RQ-PCR based testing for NPM, and after 15 months they showed more than 500 mutated NPM values per ABL copies into 10^4. Sure, this we see normal cytogenetics, AML, good risk, and we tell them, okay, 30-40% chance you have a long-term cure. There was the days when we never had this MRD testing. So the few questions, Dr. Vishnu, if you can take, if you are doing testing, before, I have not written that question, just if you are having this NPM, good risk AML, do you prefer doing the MRD testing? And if you are doing it, you are doing the bone marrow or the blood? He received chemotherapy 7-3, he received HIDEC, MRD negative has been documented, and now you are having a marker, NPM is there, is a good marker. So you are following, are you following this PCR based or NGS based? Are you doing from blood? Are you doing bone marrow? How do you do it? Or you say, no, let's see, when they relapse, we'll see.
I am not doing MRD. So you're talking about MRD after
consolidation, 3 cycles of
consolidation.
3 cycles of consolidation.
I am not doing, sir.
You are not doing. Okay, fair enough. Lot of many. Rajan.
I think this category does need MRD monitoring because, as you said, this is so-called a favorable risk, and we want to capitalize on whatever maximum we can do. So MRD, I feel, is a must in an NPM. We have a marker. Now the question is between bone marrow and peripheral blood. I think peripheral blood is the one which is recommended for NPM. I feel that we should do MRD and NPM positive.
Chaitanya, your case.
I agree with sir. I think we advocated to do it for the first 2 years at least.
Now, there is a question we should be doing or we are doing. So how many percentage actually we are telling and doing it means?
Yes.
Whatever. We are doing everyone?
We advise all our patients, but the rough numbers from the data from my hospital, only about 20-30% of NPM ones actually come back and do it. And we usually do it on peripheral blood. Sir.
Peripheral blood.
Yes.
So bone marrow, it's very tough to make patient go for bone marrow, even if they are very aggressively by NGS, even if you are doing the NGS based. So do we see any difference between PCR based or NGS based NPM1 testing? Does it differ in NPM?
In NPM, I think PCR is good enough.
Yeah. Good enough. So this is the where PCR based is better. NGS may not be. Otherwise, NGS MRD is the way to go. But in this case, Rajan, suppose this patient had FLT3 also positive. So which marker you would have chosen, FLT3 or NPM?
NPM, generally, NPM, I'm sorry. Yeah. So NPM is the one which we generally follow.
So generally what we see is you can have a loss of, means may not be positive always FLT3, but NPN is the more common. It keeps on repeating. So now coming to the question, okay, you have got now positive, how you will see? We see commonly, this is I can say one of the most common cases. Patient comes, sits, okay, now you have been asked me to track, while it is negative, we are happy, very good. The moment it start coming positive, maybe a month down the line, 2 months down the line, you may repeat, but the moment it positive, you know something is going wrong. How do you proceed? Is young guy.
One is, yes, if it is coming positive and there is no overt relapse, I suppose.
Just positive.
Yeah, so this is one you have to counsel that maybe we have to change tack and we start looking for donors, get an HLA typing done and other things. So we prepare for BMT. And yes, in this case, we would start a chemotherapy. And
sure. So the moment it starts coming positive, that we are going to, okay, Dr. Vishnu, your take. So, which chemotherapy you are going to choose?
So NPN1 and only molecular relapse.
Yeah,
there is no
relapse.
overt relapse.
No overt relapse.
So I would go for Ajavan followed by transplant. No intensive chemotherapy.
No
considering very good response with NPM1 mutated.
He has received and cytarabine. So you said Azavan and
Ajavan followed by transplant.
Transplant. Any difference in opinion?
So one thing at relapse, we tend to again just repeat the NGS just to see if there are any additional mutations that we have, just in case. But again, as Sir said, NPM1 trumps all, more or less. We usually, if they're younger, fitter, and normally a more intensive therapy with transplant, but otherwise Azavan followed by transplant.
Of late, we've got like instead of ESA when young, so we're using a flag or a clagven. So that has given very good results. And the advantage of FLAG1 is that the recovery of the neutrophil count is also much better than 3+7 because we know we have to go for BMT. And the depth of response, especially in NPM, does make a difference. ESA when it's difficult to know how late or early you are going to take up for transplant, how many cycles to give, what is the, as she had brought up Dr. Tejaswini, how many days of when, and all those things. Giving a FLAG1 one shot take up for transplant, I feel that is the way for a 22-year-old.
So, and does your type of relapse change the option, like overt relapse or only molecular relapse? Suppose he is having overt relapse or molecular relapse. Options are same.
Because this is going to tolerate much better than if he has an overt relapse. I feel that options would remain same. I would still go for not a 3+7. I would like to give an advantage of an venetoclax in this. I would go for a FLAG1.
FLAG1. Yeah. Anybody from the house, if they want to comment on this? Molecular relapse, NPN positive, relapsed AML. Somebody can give? Yeah, thank you. Yeah, Tejaswini, yes.
There is no perfect answer here. But my worry in this patient with just molecular relapse, giving a flag IDA or a FLAG1 would be the possibility of losing the patient also while bridging them to transplant.
Yes, fully agreed. Even as a when we can lose. How do you practice Tejaswini? You are there, 22-year-old, are you going for Azavan? So we means in your setup, Vedanta, when we are sitting there, I can understand if anybody from AIMS or PGI says, I will give Azavan because it's easy for them to administer Azavan in public domain. But when you are sitting in when the patient have finance, we are not talking finances, just we are saying, okay, we can afford everything. So how do you proceed?
Sir, I think we've very honestly done both things depending on the patient. We have patients who we've given high intensity chemotherapy and bridged to transplant. I also remember a case who was multiply relapsed outside, like he achieved a CR2, did not undergo a transplant, then came to us, and then we gave Azavan because he had already, relapsed twice. So I don't think there's a perfect answer here. It depends on the case, I would say.
So once you have given flag and he has not responded, it becomes easy for us. Okay, that he has to give Azavan. But once you are in the first molecular relapse, to choose between FLAG1 or flag IDA1 versus Azavan, I think so this is still debatable. We don't have that. Yeah. If it is upfront, we still can debate, yeah. But in relapse cases, it's still.
And other thing is, Azavan is not that innocuous. I mean, if you compare, it's almost 30. have cytopenias. In fact, I think Dr. Vikram Matthews is doing a very fascinating and a novel study where they are using anti-mitochondrial agents, artesunate and arsenic. So when they had to choose the agent to combine with artesunate and arsenic, they did not choose ESA. They chose CLAG when artesunate and arsenic. And means obviously the results will come. It's a 100% CR rate.
Yeah, that's very.
So when you have to select an agent, and especially supposing there is a requirement of a third agent, supposing say we have a revumenib or say gilteritinib, it's always better to use intensive chemotherapy backbone and add a third agent rather than aza-ven and a third agent. Aza-ven third agent, though the data is coming, it's still not a very smooth this thing.
Sure. So this is still debatable whether somebody goes for aza-ven. I'm just saying, just molecular relapse. We know it is going. We have some time. We can go for testing. We can go, but the giving aza-ven, sometimes we also get flagged. It's not easy decision for anyone. Giving aza-ven, or you can have the either way experience. You gave aza-ven, nothing happened, still relapsed. Then you know that okay, we may have to go for intensive chemotherapy. So this is the one paper, what we are saying, flag with idarubicin with or without venetoclax. So if you say flag ida with venetoclax and with flag ida in the relapsed AML. Now this is not the molecular positive, it's overt relapse. So if you can see, the overall response rate in the intensive was 78%. So CR, ICR, okay, and here it was 47% in only flag. So addition of venetoclax did made a change. So this is one paper when had it, but once you go to the overall survival, you see not much of a difference. And if you can see, the PFS coming is little better for the venetoclax when he has gone. The graphs are. So maybe survival that they are relapsing again, but the relapsed AML still have a lot of work to be done. Maybe now if you were saying that in the flag IDA versus flag when IDA, those who are MRD negative versus MRD positivity, this cohort had those who had received venetoclax and MRD negative, they did better as compared to who had MRD positive. And in the flag IDA MRD positive, whether it was negative, they didn't have much of a difference. Now I came across a very interesting, so whether this when a patient is naive when you are giving, so bringing disease under control is the one we say MRD negative, bring the disease morphological resolution, go for consolidation by giving IDAC or go for bone marrow transplant. But there is no clear-cut consensus on what should be the intensity in relapsed refractory AML, whether they should be in morphological remission, what is the intensity, whether they should be in MRD negative. Some papers will say, okay, this is better, this is better. We don't have how much intensity. So this paper was quite good in patient with relapsed refractory AML, sequential conditioning with immediate allogenic stem cell transplant result in similar overall and leukemia-free survival compared to intensive remission induction chemotherapy followed by allo transplant. So this was randomized phase 3 ASAP trial. And if you can say here, they have used the cytarabine and mitoxantrone. And in the other arm, the low dose cytarabine was used. There are two arms, very beautifully. One intensive, but not much intensive. They went ahead, did the transplant. And if you can see the overall survival, not much difference. So they didn't wait it for the remission to happen. They just give the chemotherapy day 14. They took them for transplant. And if you see the overall survival, not much difference in both the arms. So both ways you can say. So relapsed refractory AML still needs much. These were the days when the molecular, nowadays the molecular is not there. So we cannot say intensity only matters. Now the new, as we have new mutations, going by the other data, we know that now AML is not a single disease, it's a multiple disease. The whatever mutations, you have to go by that. And new drugs are coming, we are going for that. Now this was another case. I'll just, a fit 35-year-old male, 22, treated with 3+7 plus midostaurin, followed by match sibling donor, 100% match allogenic BMT, relapsed after 18 months. Basically it was FLT3 AML. And it relapsed after 18 months. Repeat evaluation reconfirmed that a patient has FLT3. So, question is, do we test for FLT3 positivity in our relapse setting? Which sample, methods, treatment options? I'll go with a similar case, just little. Elderly with AML, TKD-AML, that was ITD-AML, this was TKD-AML, treated with azavan, relapsed after 3 years. Again, what are the options? Monotherapy, azav plus gilteritinib, or triplet therapy. So in the both cases, we have one scenario, young guy with an ITD-AML, post-transplant relapsing, and when we have an elderly guy, the TKD we are saying, so again it is relapsing after azavan. So I will just go. Any Dr. Vishnu?
I monitor FLT3 in all patients post-transplant. And treatment option for this patient is azacitidine plus gilteritinib.
You will go for it as a gilteritinib as a azacitidine, then it's a FLT3 positive. Sure. And Dr. Rajan, your take?
See, we do marrows for post-transplant one, and the PCR is the one which we are doing. I'm not sure NGS is it established or not, so we are doing that. Yeah, we have to do a reinduction and probably take up for transplant again.
So monotherapy versus combination or triplet?
Yeah, triplet.
You will go.
Sorry, sir. I am also favoring triplet.
Same thing. We
Young
have
patient
gilteritinib,
triplet.
azacitidine,
Azavan plus gilteritinib.
Sure.
Yeah.
He's a young guy.
Young guy, I would go for intensive plus gilteritinib. Rather than azavan, maybe a clag.
So here is the FLT3, we all agree, azavan plus gilteritinib.
No.
Chaitanya, you also?
Yes, sir. We generally do as marrows for our FLT3 monitoring post-transplant. Again, NGS, we use PCR. Treatment options, I think because he's young, probably intensive chemo and that. Azavan and gilteritinib I would probably keep for the other gentleman. I would probably take 2 flag and then take him up for transplant.
Post-transplant, there is always a confusion. I mean, I'm just saying, even before relapse, we put them on maintenance.
So this was all that time gilteritinib was not there.
We were using sorafenib and other things. The only option what comes is whether to give DLI in these patients or not if they don't have GVHD. What is your take? Do you use DLI in your practice?
No, at present no. DLI, I'm really, only for CML I have taken this.
If supposing doesn't have a GVHD, you taper off by day 60, you taper off your immunosuppression, no GVHD at all. Is there any role for prophylactic or preemptive DLI?
AML I don't use, but in CML, yes. CML is the way we are using.
I don't know, Nitin, I think all of us have probably gone down with the availability of these drugs.
Availability of these drugs, yeah. So in this, everyone is, as of when it was treated, then again relapsed, you are again the same combination.
Probably 75-year-old, I'll try a single agent
Single agent.
Here it is.
Is not going to tolerate.
It may not tolerate. Any chance of changing azacitidine to decitabine? We do have our own, we think, when the patient comes, okay, he has received azavan, now I will change to decitabine. Does it change the outcome?
We have used it, but I don't think so it does.
Anybody from the house? Since we do, this is common practice, we see. When the azavan given, when they come, we'll add gilteritinib and we use decitabine. Does it make a difference, or aza again will do the same thing? It's the same, we don't know. People has been doing all this. So this is a common practice. Here I will also go for gilteritinib and will take the case. So this is the single monotherapy. This is the Commodore trial. This is the Asian where the gilteritinib with standard of care was better. This is the NAGM paper for Admiral trial. Again, gilteritinib monotherapy was better than the standard of care. And here is a newly diagnosed case versus when it was compared with the relapsed refractory case. Again, this triplet therapy, the relapsed refractory case again showed much better response. Just this is one of where many papers are there. So triplet in young case did have a better chance of getting you into the remission. So last case I will just take. This is Chaitanya was talking, I was listening with him. We have seen AMLs, elderly AML, we don't think too much. We have done the NGS. By the time NGS come, most of us have patient we have started on azavan. They respond also. Although TP53, AZA is the one which works. I don't know how much venetoclax work, but in this, if it was wild type or monoallelic, it would have responded. He responded and again relapsed. So Chaitanya, you just did presentation. This is common scenario. It happens. What you would do in this case?
So again, I mean, like you said, this is quite a common scenario, sir. So at this point, 75-year-old, especially TP53 relapse, he's got a few weeks at best. Something that we've used, but I mean, it just prolonged the life is LDAC-Ven. So we've used low-dose cytarabine with Ven, especially the relapsed after AZA-Ven, just buys us a few more weeks. But unless you put them in a trial, or I think the outcomes are dismal, sir. There has been people who, as you mentioned earlier, shifted
Dr.
AZA
Riaz,
to
you have just 1
Decitabine,
minute
but
left.
No. Shifting to Decitabine at this point, though we know HMA works in TP53, I don't think it's going to do much when it's relapsed.
Much better. So this is common scenario. TP53 relapse. It's a bad scenario. We know a few weeks. So we do same thing, Decitabine, but we are just playing around with it. The only thing is the more drugs needs to come before we take. These were all common cases. It's not like we do day-to-day AML practice when we see this is the all. So with this, I think so. The time is over. I think so. With this, I will end the talk. Thank you all my panelists. Thank you very much.
Thank you all the speakers. And a good discussion we had, and takeaway from my side that we should not hurry in treating AMLs unless we have the correct biology with us. So that is more important, and we should get all the time to get the biology right before we start treating. Thank you very much, and I hand the mic to the organizers.
Thanks to the chairperson, moderator and panelist. Moving forward for the next session, I would like to invite the chairpersons, Dr. Gitanjali Uppal, Medical Lead Research and Clinical Studies, Medanta Gurugram, on the dais, and Dr. Shoaibal Mukherjee, Director Medical Research, Medanta Hospital. Thank you, ma'am, to chair the next session.
Am I audible? Yeah. A very warm welcome. First, I'll just say a special thank you to the organizers and Dr. Nitin Sood for having a completely research-focused translational topic as a part of the hematology conference. It does show that we are gradually moving into a phase where translational research is now entering into our clinicians' conversations. So that's a very warm welcome change that is happening. This session is focused on advances in CAR T therapy. Especially the focus is going to be on the indigenous CAR T therapy development and what is happening in the domain. So I would like to welcome a researcher from Translational Health Science Technology Institute of India, Faridabad, Dr. Atul Roy. He is actually pioneering the development of indigenous CAR T therapy, and the focus is on next generation CAR T cell therapies and also on how to make them cost effective so that they are there for all the vast Indian population and they're not so prohibitively expensive. So Dr. Atul, please take the lead.
Thank you, ma'am, for calling me here. So good afternoon, everyone. I am Atul. I am from THSTI. It is a research organization under Department of Biotechnology, Government of India. I am working with Dr. Amit Awasthi from last 4 years. We are working on CAR T cell therapy. And we are not only working on the liquid malignancies, but also on the solid tumors and the next generation CAR T cell, especially for the off-the-shelf targets. Today I will be discussing about the CAR T cell landscape in India, the challenges, opportunity and future directions. So to understand why CAR T cell therapy is getting so much of attention, we need to understand the burden of hematological malignancies in India, the B-cell acute lymphocytic leukemia, diffuse large B-cell lymphoma multiple myeloma, continues to contribute significantly to the cancer-related morbidity and mortality in the cancer. The limitations in the conventional therapies like limitation in the conventional therapy like limited efficacy in the relapse and refractory diseases, high toxicity and long-term complication has given the opportunity of CAR T cell to look beyond the conventional treatment. If we see the overall process of CAR T cell treatment, the T cell dividers, which is then ex vivo expanded and then transfused back to the patient after quality control. So this overall vein-to-vein process takes around 14 days of time. This is why the CAR T cell manufacturing is one of the bottleneck in the Indian scenario, and we are constantly working on this development, whether we can reduce the vein-to-vein transfusion time, can we develop indigenously lentivirus vector. So the global success of CAR T cell therapy started back in 2017 when Kymriah given the first CAR T cell to the world targeted against CD19. The high response rate like CR rate of 70 to 90% in relapse and refractory BALL patient and a strong response rate or the overall response rate of 60 to 80% in aggressive B-cell lymphomas gives the paradigm shift of CAR T cell in personalized cancer immunotherapy. So how does this CAR T cell work? Let me overview. So CAR T cell is the specialized T cells where the CAR part is exogenously inserted in the T cells. It has the two arms. One arm is the binding arm and another arm is the signaling domain. The binder is specific to the antigen. Once the antigen is recognized by the T cells, it will activate the killing machinery and it will kill the cancers in the body. So the global success of CAR T cell therapy, is it translational in India? What we are doing in India? So current status of CAR T cell therapy in India, for that we have to look at the Hemonet. Hemonet is the one of the India's first endogenously developed CAR T cell therapy, and Immunil is also working in the same line of development of next generation CAR T cell therapies for hematological malignancies especially. We have also the academic initiatives in IIT Bombay, IIT Delhi, my own institution Faridabad, where I especially work on the liquid tumors, and industrial initiatives like Immunoact, Immunil, and you name it. There are many centers conducting trials. Medanta is one of them, and AIIMS Delhi is our collaborating partner as well. The regulatory landscape is also strengthening the ecosystem for GMP manufacturing and quality standards. So India has demonstrated strong scientific capabilities and growing indigenous innovation, but the access of CAR T cell therapy is remained limited. So one of the major challenge accessing the limit is the high cost. So if we look at the cost of CAR T cell treatment, it is around 5 CR in the West, and the therapy what is currently available is around 50 to 60 lakhs in India. And limited GMP infrastructure as well as the skilled workforce, logistics and toxicity management are some of the key factors which is limiting the access of CAR T cell therapy. Here we stand and we present our expertise that fits strongly in lentivirus production, vector optimization and scale-up manufacturing. So there is challenges, then there will be the opportunities. We have to have local manufacturing of the CAR T cell as well as the lentivirus production. The lentivirus production itself is the major cost driven in the whole process of CAR T cell. Automation and process innovation will reduce the labor cost and further roll down the cost to 10 to 20%. And next, moving forward to the allogenic therapies will be the one of the next frontier in the landscape of CAR T cell therapy, where the healthy donor can give their cells that can be engineered outside and will have a blood bank kind of thing, and then we can give to the any patient which comes with the therapy. That will reduce the cost to the 1/10 of the existing cost. It is still in the development phase worldwide, and we are also working on that. But if it works, then we can reduce the cost of the CAR T cell to the 5 to 6 lakhs. So for the next part, I will be discussing what we are doing at THSTI. So as my work is focused on CAR T cell, and we are actively working on the construct designing, optimization, and virus vector production. These are the three domains where the major costs are involved. And also we have developed the pipeline for the in vitro validation assays like phenotype characterization, cytotoxic assays, cytokine profiling, and many more like apoptosis and specific killing. We have also the humanized mice model, which can see the interplay of your CAR T cell with the tumor in the real-time scenario. Beyond CAR T cell, we are also working on the CAR NK cells. CAR NK cells are the future of CAR T cell, what we can call it, because it doesn't have the HLA. So it will not be recognized by the other our immune cells, and it can given as a off-the-shelf therapy. Same with the gamma delta cells, and we are also working on the autoimmune disorders. So we have recently published this paper, optimized high titer lentivirus production and efficient CAR T cell generation. This bottleneck is addressed in our setting. And I will also talk about one of the product what we are developing at THSTI. This is the fully indigenous product what we are developing at THSTI. So if we see the red one, it is the standard care, but this is the murine origin. So we cannot use this as such. So we have humanized it, and we have seen the cytotoxicity is almost maintained in dose dependent manner. At 1:5 effector to target ratio, we have seen that a cytotoxicity is achieved to the level of where the murine domains are binding. We have seen in the both NALM6 and Raji cell line, which is the disease which is giving the disease mortality, and we have the target negative cell line where we don't see any binding. So this specifically tell us that our CAR T cell is specifically binding to the target cells, not specifically binding to anywhere else, and it is also giving the very good cytotoxicity profile. We are not only characterizing the cytotoxicity, but also looking for the co-culture supernatant. Why this is important? Because the major problem in the CAR T cell therapy is the CRS what we have. The CRS is driven by one of the factor, which is IL-6 cytokine level. So in the red one, you can see that there is drastically increase of IL-6, which is the murine origin. But our product, which is in the green, you see the significantly decrease in the release of cytokine, which is IL-6. Apart from that, we have seen the different cytokines, which is interferon gamma, IL-2, TNF alpha. These are the cytokines which mediates the cytotoxicity, which also reduce, which will gives the advantage of using this construct. The overall, this result confirms that our CAR T cells are functionally active and capable of mediating effective cytotoxic response. So we have not only checked our construct in the Petri plates, but also in the mice model. This is the special mice, which is NSG mice. We call it humanized mice because it doesn't have the B cell, T cell of mice origin, but it can be humanized one. So we have given the tumors. You can see there is a very beautiful tumor progression at day 28. But upon treatment with the CAR T cell, which is H2 CAR here, we have seen that drastically reduce in the tumor burden at day 28. Also, same with the standard care, which we chosen as a control. So our CAR T cell is as good as the standard care, and this FMC63 based CAR T cell is the first CAR T cell therapy which was approved by the FDA, that is Kymriah. So this was what we were doing, and this is one of the targets. We are also working on BCMA and others targets. What we have at THSTI is we are coming up with MRC Center, the Medical Research Center, which is having the clean room facility, the GMP facility for the production of CAR T cell as well as lentivirus vectors. These two are the whole and soul of the CAR T cell therapy, where the most of the costs are decided. And we are also building the capacity for the CAR T cell therapy in designing and development of novel CAR vectors, production of high titer lentivirus particles, in vitro assays to skin CAR T cells, specialized preclinical models for testing CAR T cells. We have also clinical partners for phase 1, phase 2 trials, AIMS Delhi and other NCR hospitals nearby. So key take home message is, together we can transform scientific capabilities into accessible, affordable CAR T cell therapy for every patient in India and beyond. That's all from my side. I will be happy to take questions.
Thank you, Dr. Atul, for giving us a very nice overview of how THSTI is progressing in this area. The reason why THSTI's advent into this field is so very welcome is obviously what you pointed out, that the cost, we are looking at the possibility of the cost coming down very significantly. Obviously, at present, the reason why the hurdles with CAR T therapy, the primary one is probably cost here. Now, my question to you is, what are the components of cost? You said that once we come to allogenic CAR Ts, it'll come down to about 5 to 6 lakhs, where
Yes.
Where at present it is maybe 10 times that amount. So what is it that brings that cost down, and how do we understand this?
So if you see the biology of it, then the off-the-shelf therapies will be like blood bank. You take the donor cells from the healthy volunteers, you engineer them and produce the CAR cells. Here we talk about CAR NK or gamma delta. So these two will not react with the other's body. So my CAR NK cells can given to you and the others in the audience. So if I voluntarily give my blood for like 4 and 5 times, and I produce it the level that 100 patient can be given. So from one donor, you can give it to the 100 patient. The cost of production will be for the one only, per se 60 lakhs you expend for the treatment or for the production of CAR T cells or CAR NK cells. But from that you can use 100 patients. So the per patient cost will be reduced to 5 to 6 lakhs because you have expend only 50 to 60 lakhs.
Thanks for explaining that. It becomes very clear. Do you have a question?
Yeah. How far are we from that?
So this is a very tricky question. So we have developed the preclinical model. We have the GMP facility which is coming up. We are also filled our CT10 forms and then CT11, and then we can go for the productions. So tentatively, if I say, then roughly 3 to 6 months. In the months.
To come to allogenic?
No, for the CAR T cells.
For the CAR T. And
for allogenic, it's still in development all over the world. It's not in the market yet. Yeah.
Just to give the audience a perspective into why this focus on CAR T, the government of India has actually made CAR T as one of the mission statements that they need to indigenize CAR T so that it reaches the masses. And it can be addressed to the Ayushman Bharat scheme itself.
Yeah.
So that is the focus which has come onto it. Now, the two important things that THSTI has actually done is, one of the most important reasons for cost is the lentivirus vector. Now, the vector production, if it happens in-house, the cost anyway comes down by around 10 to 15 lakhs, if I'm not
Percent.
wrong. Yeah,
in
10
percent,
to
if you
15%,
talk 10 to 10,
sorry, 10 to
20%.
15%. And the other fact would be having an indigenized version, and when you're not dependent upon outside sourcing of vector, that also cuts down the cost as well as the timelines. Probably
also.
we'll be able
and
to.
we are also sourcing everything from West. It's like not only the vectors but also the cytokines what we are using for the development of CAR T cells. So that if we can indigenize it, then that will also reduce the cost.
Those are the next steps that we are kind of looking at. But at the present where we are on it, they have a GMP facility which is ready. They are in the process of operationalizing that GMP facility. It will take them around 3 to 6 months, and probably then the CAR-T cell therapy might become more easily accessible to the clinicians.
Yes.
Right? And you're also working on a CAR-T cell therapy for multiple myeloma, which is a new, which is another indication which is as yet not approved.
Yes.
So
And
how far are we in that development phase?
So the data I have showed you about CD19, in the same way we have done it for the BCMA construct, the multiple myeloma one. So we have the data ready, but still we are looking for the, obviously the investors as well, and also the approval of the GMP facility. So once we are given the approval, then we can file the phase 1 clinical trials.
Thank you.
So,
yeah, I had a question. I mean, what's so special about the virus that it costs so much, and how do we go about reducing the cost of that? Because it looks like that the main cost of the CAR-T comes from that.
No, if we say around 50 to 60 lakhs of the treatment cost, then 10 to 15 lakhs is of the virus.
And if you develop it indigenously, will that cost go down substantially?
Yeah, it will go
or
down.
does it
Obviously,
remain the
it
same?
will go down. Because the logistical aspect which is included in the CAR-T or the transportation of virus is also very high. Like per se, it's 5 lakhs. You can reduce that.
Oh, so the transportation costs a
because
lot.
You cannot transport the live virus directly from the source to the institution.
Yeah.
There are a lot of paperwork and also the regulatory approvals, and that adds up to the logistic part.
And so is it in the plan of THSTI to develop an indigenous virus as well?
Yes, in line of developing.
And how far are we from that?
So we have published that paper. So in that line, this is for the research and development. Once we have the approvals for the GMP one, we will scale it up, and will obviously go for the QC on all. And then once it is done, then it will be available for the production of CAR-T cell.
Okay, thank you.
So, another moving away from the cost aspect and the pricing, as this becomes more and more available, there'll still be a cost. 5 to 6 lakhs is also not less for the ordinary patient. So now, does CAR-T cell, or are we beginning to see with CAR-T cell any connection with the cancer biology? Are there particular types of patients with particular biologies that are more susceptible to CAR-T versus those that are not?
There will be responder versus non-responder.
Yeah, and do we know what kinds respond better?
So, but the beauty of personalized medicine is that it will be for you. So we expect that it works like for 90% of the time for you, because the immune cells are driven from the source itself, the patient itself. So your cells knows what problems you have, but it is not acting it because of the exhaustion or the other things. But since things are from your body, if it is given back to you with the special arming, then it will obviously work for you.
Okay. So we are not at a stage where, because after all, finally clinicians will have to decide which patients to, very aggressively.
So the relapse, till now, the after conventional therapy, you have to go for the CAR-T. So whatever the first line of defense you have, like chemo, radio, you have to give that. If patient is not responding to that, then only you have to go for the.
Do you see a time when CAR-T will become first line?
Yes, if the regulators are in line.
No, if your product is in line.
No, it's not always about the product, but also how regulators sees it. Since this is the new technology, so people are reluctant, or the regulators are reluctant to adopt it as a first line of defense. If it will be normal in the coming days, then it will be coming to the first line of defense.
Maybe when you make it as an allogenic, that time the regulators will have a different perspective on it. Until such time that we complete those, I think still FDA wants 15-year data post-CAR-T.
Yes.
So once they have that long-term data, they'll be more amenable to having it improving or expanding the indications for CAR-T. So it is a time-bound process. We have to
process.
understand.
We have
It's
to
not
understand.
actually the regulators who have fault. Just
so
one question.
If a new medicine comes to the market, you will not be rushing to give it to the patient.
So it's a process.
It's just a process.
So just one question on one of your slides where you showed that the tumor absolutely vanished in that slide, right?
Yeah.
Now just tell me, were those mice also observed for a longer period of time after
Yeah,
that
we
to see
have-
whether recurrence happened?
We have seen it for 40 days.
Is that a sufficient timeline? I do not know how it translates into.
So
mice
people have done it for
lifespan.
28 days only. So we have looked for the 40 days.
So you've done a better job at that.
Yeah. So we have the standard care and they had the protocols. So we wanted to look what happens beyond that time point. And then we have seen the survival. Obviously, the first marker what we see is the survivability of the mice.
Great, thanks. Questions from the audience? Anybody have any, burning questions on CAR-T?
Thank you.
Great. So thank you so much, Dr. Atul, for this session.
Thanks to the chairperson and thanks for a wonderful talk by Dr. Atul Roy. Moving forward, I would like to invite the chairpersons for chairing the session, Dr. Balakrishna, Director and Co-Lead Cellular Therapies Department of Hematology at Sir H.N. Reliance Foundation Hospital, Mumbai, Dr. Renu Saxena, Senior Director, Head of Hematopathology, Medanta, Gurugram, Dr. Ritu, Director, Hematopathology and Immunology, Pathology and Lab Medicine, Medanta, the MedCity, Gurugram.
Okay, very good afternoon to all of you. And at the outset, I'd like to thank the organizers, Dr. Nitin Sood and his team, for inviting me to chair this beautiful session. And I must compliment the program which has been made, which is really in keeping with the advances that are happening in hematology. So it's my pleasure to invite the first speaker. That's Dr. Rahul Bhargav. He is Director and Head of Department Hematology at FMRI Gurgaon, and he'll be talking on a very interesting topic, Precision in Action, Redefining Outcomes in MIDH1 AML.
Thank you, ma'am. Thank you. Thank you, Nitin, for giving this. I think it's very, very important that we have moved on completely, at our center, we have completely moved on to 3-day genomics, as you keep on hearing, across day and night, in and out. For every AML patient, we get our NGS reports in 3 days, and so we have a huge data set of 3,000 patients now, where we can define whether 7+3 is required or not. And true precision hematology in terms of triplets has really made our life 3 things important which has happened. It has reduced the cost of hospitalization, it has reduced the loss for the patient, people can go back home, and it has reduced the toxicities, increasing the outcomes of the transplant, going up to 83% in matched sibling transplants. So that's a huge thing which has happened. So we are going to talk about very, very important component of today's IDH1 and FLT3 which we have. Though FLT3 is out of scope right now, we are almost going to publish a paper on 13 patients of triplet combination instead of 7+3. So it's time to change your thoughts to something newer, which is a triplet therapy. So precision in action, IDH mutated AML management from unmet need in IDH1 AML, we knew that Aza-Ven tends to do well. So the recurring thoughts in these meetings, which Nitin has actually organized, is should 7+3 be buried deep underground? I mean, should 7+3 we write the obituary? Yes, there will be no-sayers and there will be yes-sayers. And the beauty of the democracy is that through the dialogues and the communication, we reach onto the conclusions. It's not one-way ticket that I say something and we all follow. It is not like Man Ki Baat. We just have to talk and communicate with each other to reach onto the consensus which is best for the patients. So that was an unmet need, we all knew. It used to take 3 weeks, and I will encourage people to use 3-day genomics, which is huge for the Indian studying. I would say overview, agile study, real-world studies, which we are going to discuss, and the key takeaways. This is what we are. The 5-year-old survival by cancer types. 5-year-old survival in amongst cancer is 24%, in 2 years is 32%. It remains still the major thing, and this is going to soon change because now we'll have our own data. By our Hemonet, we are going to organize in October. We'll have our own Indian data to showcase and not the US data, that how the Indian AMLs have actually moved between the tier 1 cities and tier 2 cities. There's a lot of things which needs to be done in tier 2 and tier 3 cities. It's just not homogeneous in this country right now. It's pretty heterogeneous, and we need to understand that, and we need to make every effort to reach to the last mile so that even the last mile people can get the best therapy treatment which a rich and the famous can get. So that's the whole idea. So unmet need in IDH1 mutation. We always had this doubt whether this IDH1 and IDH2 are poor mutations. Does it increase the relapse? So there's enough literature which is contrary sometimes, but they tend to go towards the poor markers. So we keep on blindly following ELN criteria of having a 821 with c-kit. We say good risk. No, friends. 821 c-kit with NRAS is not a good risk marker in Indian setting until unless you have a GEO. So again, we have published a paper why India needs more GEO than ever. So unmet needs, persistent IDH1 clones and MRD despite therapies. We have got a couple of patients which we have been incorporated into this, where the IDH1 is still persistent enough where we did not have the ivotazanib previously and we were monitoring NGS MRD. So 3 new things which has happened is 3-day NGS and NGS MRD apart from the flow MRD. That has become new in today's world, where we can follow each mutation. We can actually see each and every clone getting disappeared based on the therapy, like whether azaven, flagven on 7+3. And believe me, 7+3 does very poorly. So that's paper is under publication right now. So persistent IDH1 mutation clones, older and unfit patients have limited tolerability. Disease persistence and co-mutation complexities is a major problem which continues to have. So we do have a lot of inflammatory markers, inflammatory milieu within the system, and that markers comes also not as only inflammatory markers in NRAS, but they also come with plenty of chips. So if you see an average TCG data from MSKCC versus the Indian data, we have got 1.5 times more mutation than any American mutations have. And in the setting also, if you see the Asian Americans living for a long time, still Asians does have higher mutation burden than the original virgin Americans, which tends to have lower mutations. So they go through a freeze-thaw cycle. We have got a tropical country, and that is why inflammation is a central part of it, and that's why longevity companies are making big in the country. Why addressing mutations early is critical is an early event in the leukemogenesis. It does not make it proliferate. The proliferation, there are 2 mutations which helps to proliferate, which is PTPN11 and FLT3. Delayed targeting allows accumulation of secondary resistance mutation. Early molecularly matched therapies associated with higher remission. And what we have understood when we showed our data and compiled our last 77 patients of AML, showing a matched sibling transplant going up to 83-year survival at 1 year, we saw what happened was what different between people who are not doing so well. The difference was pre-transplant. Whatever you do pre-transplant, I'm not talking about right now about those people are ineligible for transplant. Their median survival will be 1 or 2 years at max. But what about a younger population? We have got younger population every time when we see through that. And that is how we see these mutations coming up, and that's why you have to do a transplant. It means before transplant is just not the flow MRD negativity, it is also the NGS MRD negativity. It actually increases. And now Dr. Astha, under Dr. Renu Saxena, she has been trained in AIMS. She has just published data that flow MRD itself is not sufficient. It's time to look beyond flow MRD in AML. And that is why all these reasons adds more reason to attack and address these mutations, whichever mutations. And believe me or not, there are NRAS mutants which are being targeted right now. There are TP53 mutants because these are unmet need. So who is the next TP53 after is NRAS? And IDH1 is still better off. IDH2 is again there with very which can be targeted. So ivosidenib, an overview. Relapsed refractory with susceptible IDH mutations, relapsed refractory people were used in global market. The drug has been approved by CDCSO for import and sales and distribution in newly diagnosed intensive chemotherapy ineligible AML with IDH mutations in India. And in is IDH mutation similar in outcomes in IDH2 mutated AML? The answer to that is probably no. The IDH2 mutated discussion between me and Dr. Dinesh, when a young patient who just had IDH mutation going on with cytopenias, only neutropenia for 6 months duration, picked up on a routine bone marrow as having an AML to do a transplant or not. Luckily, we did debate on that, and 2 years back the data was sparse, and now we have transplanted his 2 years post-transplant in molecular remission at this present moment of time. So does IDH1 requires transplant? If the answer to that is yes, then you need to go do something more to reduce the tumor burden and the disease mutation in these subsets. Molecular testing informs prognosis ELN2 guidelines which continue to use still in India. Probably it is high time that we have got 3,000 samples of NGS. We can actually define our own guidelines to see whether these mutations really how they fares on our own system. And that's where the agile study comes in now. This is the double-blind study. We utilize in all the ways. Can it be used in part of an induction, a double induction, or a triple induction? Should we give as a when ivosidenib? Should we give as a ivosidenib alone? Or can it be used post-transplant to reduce the IDH1 burden? But the important thing is, at some point, we need to do NGS MRD, and that is the most important thing. And these are the baseline characteristics. And if we see the event-free survival, treatment failure, median using this definition was improved to 22.9 months with IVO plus AZA versus 4.1 versus placebo versus AZA. This trial was designed at that time, which still can have a criticism that AZA-VEN becomes the standard there. In YLA study, you can go up to 70% with AZA-VEN alone. But if you combine the drug, can it go to 90% like FLT3 has done? So AZA-VEN gilteritinib, there's a CR rate goes up to 92%, our own data of 13 patients. Huge response. The only problem is the prolonged cytopenias. So in a FLT3, if you get in 3 days, will you still give 7+3? I will leave to the audience and we can discuss sometimes during the coffee. Secondary endpoints, the overall survival benefits, median OS was 29.3 months versus 7.9 months. So we all remember, please, Dr. Dinesh continues to say, AZA-VEN is not curative. Ivosidenib is not curative. AZA-VEN ivosidenib is not curative. These are the agents where you can use an induction to reduce the 7+3 toxicity as well as the cost, and of course the bed occupancy. In private corporate hospitals, ALOS is a very word utilized with government hospitals should start utilizing it, which is called average length of stay. We cannot give AZA-VEN sitting in for 28 days in the hospital. We tend to give in all during the outpatient thing. AZA-VEN for our AZA-VEN ALOS is 3.5 days. It means people just stays for 3-5 days and 3.5 days and they go back home and they take the therapies. And this is what the data looks like when you have a co-signaling mutation with DNMT3, with SRSF2, with RUNX1 and RTK pathways. Ivosidenib still overcomes these CHIP mutations and so forth. These mutations needs to be seen because that mutation, they are sometimes hardy to take away even after transplant. But we have started seeing if these chips continue to remain as a chip, they still have got higher chances of relapses. Should we do something? And those 83% we feel that by utilizing DLI as a cytidine as a maintenance strategy has been able to push us more. So DNMT3, best overall response by baseline co-mutations, if you can see, 63% in DMT3, RUNX1 73, SRSF2 60%, and RTK pathways are 70% with IVO plus azacitidine. This similarly correlates with azacitidine plus venetoclax. Then is there a utility of adding a third drug? The answer to that is not from the agile study, but the rest of the studies. In every 2 patients in IVO achieved a CR and was not detected. So median time to response was 1.5 months, which is 1 cycle to 2 cycles is the maximum time which it takes to reach onto the CR, and that to the flow CR and NGS MRD, which needs to be seen. The absolute neutrophil count recovery path is already shown. Median follow-up time was 15.1. You can see through the curves how each cycle they fare with aza-ven and aza alone. Neutrophil levels recovers and stabilizes during IVO plus aza within 27 to 28 days, not going to up to 35 to 40 days in aza-vel gilteritinib. Infection rates, yes, the major important thing when you have a high tumor burden, the only thing which you have to remember is the differentiation syndrome. Though we have used in 4 patients, we have not been able to see any differentiation syndromes till now. Probably there was low count AML patients. Rapid ANC, rapid recovery and sustained recovery consistent with lower rates of infection with IVO plus aza. 40% lower than grade 3 infection rate with IVO aza versus the placebo aza arm. So platelet count recovery is faster and hemoglobin recovery similarly as being remains sustained. Transfusion independence, median follow-up was 28.6 months. 53.8 people maintained the transfusion independence when used in combination. So these were transplant ineligible people, they were elderly people, because the goal between the young patient and the old patients are different. In young patient, for us as a center for excellence for AML and lymphoma, we feel that the moment they can reach to MGS MRD negativity, they need to be get transplanted, because we use RIC transplants for haplos once they're in NGS MRD negativity. Versus the transplant ineligible, the goal is how long they can go and stay back at home and have a quality of life. So the entire 2 spectrums are different in both the things. And these are non-hematological toxicities, nausea, vomiting, pneumonia certain times tends to occur at this present moment of time. So endpoints, mutation clearances, this is the important curve which you have to see. ASXL1 33%, DNMT3 33%, U2AF1 40%, NPM1 75%, RUNX1 75%. So percentage of patient who did have a mutation clearance. And this is the new mantra which we have to all remember, is the mutation burden which needs to be cleared, because unless this does not go into CR, probably the flow MRD might not just be sufficient. IVO versus VEN, the real world comparison has happened. The CR rates 42 point versus VEN plus hypomethylating agents is 26.7 versus IVO plus HAM is 42.4, which is statistically significant. And similarly, the CR and the CRIs, incomplete CRs, which are greater. So when you have a target, rather than just using as a VEN, probably a third drug or as a ivosidenib is going to help you better, and that can only happen if you have a 3-day genomics and not a 3 weeks genomics, which is being done currently. So this is the real world comes in. Actually, in the same study report, high rates of febrile neutropenia with VEN AZA versus the IVO HAM. It means the drug is acting both on the CR rates without causing much of a toxicity. So the key takeaway is a positive result with the Agile study, which was in a patients who were not transplant eligible. Can you explore that in Indian young patient? Yes. If you have an IDH1, if you have a co-mutation, yes, you need to do a transplant. If you have got a triple mutation, they tend to do badly. That there's a data from Tata Memorial which says if you have got 3 mutations together, the DNMT3 and other things, they do not do well. If you have got the ASXL1, it is not as good as well. Unprecedented OS benefits within IO as a manageable safety profiles. New safety lesions have come up in this present moment of time. So with this, we come to an end of the presentation. The whole idea of the targeting for us at a center like Fortis is how can we reduce the cost, how can we reach to the miles, to the last mile, where people can be served with these agents by not putting them into the hospital but in the outdoor. And we are being evenly succeeding into this, that through AZA, ivosidenib or AZA-ven gilteritinib, more and more people are taking happily outdoor patients and not the indoor patients. So we have the ELOS paper coming soon. It will be interesting to see and communicate to the hematology community about the average length of stay in the hospital, which we need to do that. We need to reduce the people sitting in the hospital as well as the transfusion requirement. Thank you, everybody.
Thank you very much, Rahul. That was an excellent presentation and of the latest things that are happening in AML. Just a comment I'd like to make before we open to the floor. You talked about cost. And one way, if we have a resource setting situation and we want to reduce the cost for these mutations, one can resort to RT-PCR for common mutations, which not only reduce the cost, but also bring the time down. If you want to further reduce the cost, for example, a patient on IDH1 inhibitor, you can just do IDH1 on digital PCR.
Absolutely.
Which is 1 day TAT, and very, very cost
Absolutely, ma'am. Second point well taken, ma'am. I think that's the way that PCR, so we are designing a AI tool in which you put a mutation, it will tell you what is the best way, the peripheral blood or the bone marrow, and which way to utilize, because it is getting more complicated every day. If you have a co-mutation, it becomes difficult. Now, why we are saying of 3-day NGS? So why we have adopted a 24,000 rupees cost test for all of us? Why? The answer is simple. We do not do PCRs, so there's no doubt that we do not any longer do PML RR alpha. We do not do FLT3, which cannot pick up the long reads, which are rare variants in NGS, which can be picked up now, because there's a criticism that if you do on Illumina or you do an S5, probably some mutations will be lost on FLT3, which will not be picked up. We can pick up a long reads now very confidently. We can pick up the MECOM mutations, which can be there, which can be the modifiers into the system. That is why the entire platform has moved on to 3-day. And with this going on, ma'am, what we are doing along with that is a low-pass WGS. So cytogenetics also goes away. So in tomorrow's world, one sample for flow cytometry, second sample only goes for the NGS, which gives you the cytogenetics, because the data, when the sample travels from Assam to the central lab in Mumbai to get a cytogenetics done, 60% cells are lost. 60% cells are lost. You get the cytogenetics gone. Dr. Dinesh, please ask.
Dr. Burani, I think one question we can have.
Without asking your question, we cannot be fulfilled.
Yes.
IDH1 PCR, ma'am, is available?
Yes,
in your
ma'am.
lab?
We have standardized.
Yes.
Okay, so you have started doing it?
Yeah.
Because his NGS is 3 days for...
Exactly.
This for the Fortis Gurgaon, 7 days for my hospital, and 21 days for some other hospital. There's a difference in the...
No. So that's not true. So there are two ways. I'll tell you why. How we have designed the sample. There's a Genexus machine, there's a S5 machine. On a Genexus machine, the cost to us is 18,000 rupees, and it goes out to the market is either 22 or 24,000 rupees. That's a fair ask. From 18,000 to 6,000 rupees is not much. Second code is for the rest of the people on S5, where you require a manual intervention, where you need a larger flow cells. So please understand.
We come in that group.
So no. So that comes from the government hospitals, which are not ready to shell out that much amount of money. They still want to do the NGS on 89 gene panel. That costs 14,000 rupees. And the answer to that is less manual work, lower flow cells. So for a hematologist, please understand why it used to take 3 weeks for your results. Because the Illumina platform has got at least 96 samples you require to fulfill the whole flow cell. So you collect 96 samples and you wait. Or you have a mini-seq, because the cost will not come down. Or you do exon sequencing at the depth of 100, 300, not going up to 2,000 or 3,000. We do our depth at 4,000 of NGS in Thermo Fisher Genexus machine, and NGS MRD goes up to 20,000 depth. So clinician has to understand that what you are getting in 3 days, why we have developed that assay for the country, is to get the depth and the correct mutations.
Yeah, just one comment to add, just 2 comments actually. One is, you're very right, you have a huge chip for Illumina which you need to fill up, but we've devised a way by which we mix other things, and so the cost comes really down, and that we run it every week now. So that's one thing. But I still get the point that we need a quick answer. So what has now come up and what we are really now planning to go into is the NanoSeq. Now the NanoSeq reads long reads.
Yes, ma'am.
And AML is one thing that we can do on it. So we are looking towards that right now.
So ma'am, 2 things, continuing it forward and making it more futuristic. The nanopore reads actually is of 1 lakh rupees, ma'am, right now, which is going to give you the answer. Dr. Dinesh, what you wants the answer within 4 hours, we have the ability to give that answer in 6 hours. FLT3, NPM1, all you will get in 6 hours, if you are ready to shell out 1 lakh rupees on a nanopore. And you do not require 8 samples. Each individual sample can be done. Each individual sample, 1 lakh rupees, nanopore technology, as it comes by, it will start running into that. So that is one thing. Second most important thing we all have to understand is just not this. The fragmentomics also have started creeping in, and the use of digital PCR. So let me ask you, you have been writing qPCRs, quantitative PCRs for ages for BCR-ABL. Have you ever asked, is this the RQ-PCR or a digital PCR? In India, only 2 labs actually run the digital PCR. the rest is all RQ-PCR. So in digital PCR, you can actually pick up one copy as well. You can go up to the 10⁻⁻⁶ as well. So the thing is, we have been designed to treat patient and not look at the reports the way they come. And that is what we are trying to change through entering into the genomics. It's just not this. And you're happy to know we have got my own link, which is a proteomic platform to monitor entire proteomic platform for inflammation at this present moment of time, and moving there from to extent machine, which is only MRD going up to 10⁻⁻10 through a mass spec for myeloma. So gone are the days of 10⁻⁵, -6, you'll go into 10⁻⁻10. And these technologies in comparison to US is like dirt cheap. So garden, जितने भी लोग सर garden लिखते हैं 3.5 लाख रुपए का, उसकी Indian price 1 लाख रुपए. So if you want to really help and benefit people, this is the platform.
Thank you. I think we've been hearing the bell for a long time now.
Thank you,
so thank you very much for an excellent discussion and talk. And we move on to the next one.
So the next speaker is Dr. Dinesh Burani. Welcome to the dais for the topic.
It's not loud.
Not loud enough? Okay. Thanks. So I think Dr. Dinesh Burani will be talking about, the presentation is already there now. Sir, I welcome you to present your opinion on ivosidenib. And just to say something on the previous talk, I agree that all the guidelines, the ELN 2022 and 24, along with the NCCN and the ASH 2025, they are suggesting ivosidenib with aza with aza for all the patients who are before the transplant not fit enough for the transplant. And the whole discussion about the techniques for the digital PCR and the PCR and the NGS is based on the sensitivity of the assay. So this sensitivity of the assay is, so they are saying that now the PCR and NGS is for the diagnostic. PCR is important for the time it takes, and NGS for the co-mutations which are there. And for the digital PCR is mainly for the monitoring due to the sensitivity. Over to you, sir.
Good afternoon. Thank you, Nitin and his team, for inviting me. What Rahul was saying is a doublet, means using ivosidenib with azacitidine. I'm going to talk about the triplet. So I think the exciting era is there. So I just did a search. If you are using a doublet, I'm more interested in the MRD. So if you use a doublet versus triplet, the IDH1 MRD with the doublet is 50% and the triplet is 91%. Even with the FLT3 is 54% and with the triplet is 83 or 96%. You have all the bad groups and all, the MRD negativity has significantly improved with it. But don't start using from tomorrow, because you have to learn how to deal with the cytopenia. We have not learned yet how to deal with the venetoclax dose. How much is enough? We don't know. Is it 7 days or 14 days? And on the top you have now the gilteritinib, so that is myelosuppressive. So we have to learn how to, you can have the MRD negativity, but if you have a prolonged cytopenia, we cannot afford to have a prolonged cytopenia, especially in our settings. So this exciting era is there, but we have to be careful. It's very good, effective triplets, but we need to know how much is enough to reduce the mortality is not zero in our country with azavan. Considering someone is using 7 days of venetoclax, someone is using 21 days of venetoclax. If you do a trial, you have to use it for 28 days of venetoclax. So there is a huge difference into the. So what we are going to talk is beyond doublets, the triple drug combination trial. I have only 13 minutes. Beyond doublets, ivosidenib monotherapy in some patients who cannot tolerate even azavan. Beyond unfit, whether using intensive chemotherapy with IDH1 mutation, the ivosidenib, and in the other diseases like MDS. So there are 3-4 areas which I'll try to cover it. So beyond doublet, whether it's a triplet combination, so this is a phase 1, and there's still a very premature data. We don't have a phase 3 data, but at least it shows there is a more MRD negativity, more effective combinations. So ivosidenib with venetoclax plus minus azacitidine and IDH1 mutated. The other important thing we were struggling is to get the mutation is present or not. So Rahul is saying is a 3 days, but it takes a 5 days to 7 days to get this, and waiting for that doesn't make sense. And so I think the PCR, I don't think any lab had a PCR, so I'm first time hearing it. So I think the answer is to get the PCR IDH1 done, and then you decide whether you want to do a AZA with the ivosidenib, or you want to use a triplet, whether you want to do a ivosidenib with the combination of chemotherapy. So I think that having a PCR, which was not available earlier, makes sense for us. So this is a combination. Various drug doses of 800 also have been used. 7 days of azacitidine, this ivosidenib daily, and the various doses of venetoclax has been used it. The ivosidenib was started on cycle 1 day 15 just to keep it away from the venetoclax effect. And there are the different dose levels. This was the new and refractory AMLs, and there was a safety analysis. It's very effective. I will be more interested into the grade 3 side effects, 26% febrile neutropenia, lung infections of 20%. So it's a significant, your infections are there. Very low TLS, very low differentiation syndrome. So there's not much of differentiation. We can handle it, the tumor lysis and these things. But I think the important is to handle the infections when you're using a triplet. Effectiveness, if you see the blue and this light color, which is with the DL1, which goes to the 100% with the DL4. So the overall response rate is 100%. 90% of MRD negativity is very effective. Very small numbers. We have to be careful in the interpretation of these data. But the preliminary data suggests this is very strong, very infectious combination. But we should be aware of the toxicity. Then is EVOLVE-1 study. This is a phase 3 combination of ivosidenib with azacitidine, with and without venetoclax. I think they have made a smart move of AZA with ivosidenib is a continuation. Is just a venetoclax. They have put it into the whether you reuse it. It could have been the AZA-VAN plus minus ivosidenib. They have done AZA ivosidenib plus minus venetoclax. So at least we will know how much the venetoclax, the toxicity and the efficacy is adding on the basis of on the top of AZA and ivosidenib. This is going on. So this is various groups are involved. More than 18 years with a newly diagnosed AML harboring IDH1 mutation and deemed ineligible. They all have been done in the triplet has been still in the ineligible to the intensive chemotherapy. Considering now the paradigm is there, the AZA-VAN is effective even the younger age. I think that should also be tried in a younger age group. And the standard arm is the ivosidenib and azacitidine. Experimental arm has a venetoclax. So this trial will going to tell us about so cycle 1, 7 days of AZA, venetoclax, 7 days of AZA, and continuous ivosidenib. So we had to wait for the results. Beyond doublet, the monotherapy, the phase 1 multi-center. So someone who cannot tolerate, says you have a very elderly patients come, they want oral medicines and they don't want to have as I said, you can use a single agent. So there are few groups. This was a whole refractory cohort, 126 patients. The untreated AML not eligible for standard of care, other the MDS or other malignancies, and there's other categories. So there was the ivosidenib alone. Safety and the drug toxicity was seen. There was, I think, the number of patients given somewhere. We had to be careful about the QT prolongation, differentiation syndrome, cytopenias, the CR/CRh of 1/3. So 30% of the people is still achieved with the monotherapy. You have a CR/CRh, the multiply treated. Overall response is around 40%. Transfusion independence is 35%. Out of 34, CR/CRh is 21, and no residual IDH1 mutation on digital PCR. So the 21% of the patient had the deeper responses even with the single therapy. I think the PCR is a good welcome into this. Getting running for the NGS becomes difficult. So someone who can, send a additional. How long it takes to come back?
If we do it in the panel, which is what we are now going to be putting in the panel, it takes about 4 days. But if you do it singly, digital PCR is 1 day.
1 day. So I think it probably is going to change my practice. If we get a result in a 1 day, we want to know whether your IDH, since the drug is available, whether you are IDH1 positive or negative, even in the chemo, in the ineligible or the eligible, especially if you are using azavan. So rather than using, especially a young patient using azavan, you would like to use a triplet. So this is intensive chemotherapy with ivosidenib or inosidenib, so adding a third drug. The Western world will be going for the intensive plus additional. Say if you see venetoclax, they have gone for intensive with venetoclax. So we have to think differently if you are going for the intensive therapy. You have to cut down something. Whether you, I don't know how much we can use it, 7+3 and ivosidenib. We are still struggling with the only 7+3 toxicity. Adding another drug, whether they'll have additional toxicity, this may, how much is applicable to our country, I don't know. So there's a trial, the phase 1 trial, ivosidenib with the induction 7+3, and then then there is a consolidation if you are achieve a CR, and this is the primary endpoint is safety and tolerability. There are 60 patients, de novo and secondary AML. If you see a CR, the overall response rate is in the 80s, except the secondary AML. So there is a good response with the intensive therapy with targeted therapy. So there will be 2 schools, I think, in the Western world. Some will be using a triplet with the low intensity. Some will be using the full chemotherapy with the targeted agents. We have to see how definitely the people who are not eligible for intensive therapy, we should try the triplets, not now, but we need to learn how to use it in the toxicity. But in a younger age, if you are going to use azavan, probably having a targeted therapy will have a value. Beyond in the other indications, so there are many other indications, the phase 1 trial in myelodysplastic syndrome, there is a safety profile and the overall response rate of 40%, and the 68% of the CRs are durable. Estimated 5-year persistence of CR is 5 years. So if you achieve a CR with this, you will have a longer survival. That's a possibility. Where is the ivosidenib going? So this is advanced hematological malignancies, with all the malignancies which have the IDH1 mutation, MDS, myelofibrosis. Ivosidenib maintenance post-transplant, so you can use it as a maintenance. Ivosidenib the monotherapy in high-risk and low-risk MDS, and ivosidenib with ruxolitinib. So the combinations in the myelofibrosis with the ruxolitinib. So various combinations with IDH1 mutations are proposed. With this, I will stop. Thank you.
So thank you very much, Dr. Burani. Let's have some questions, comments.
I have made up for the previous discussion's time.
Yes, Dr. Nitin, I think you want to say.
Thank you for the lovely talk, sir. Just wanted to ask, how long do you wait for testing to come before you start your AML treatment? I mean, we talked about PCR and NGS. Do you really wait for the NGS reports, or do you start based on PCR?
The Western world is different from Indian country.
Yeah,
they say waiting for 15 days is, you don't make a difference. But that 15 days, my patient has already waited for a month. So I think the majority of us, we get the patient is already been neutropenic for a month and then come to us. There in Western world, you have some symptoms. They do a CBC. You have a cytopenia. You reach to the center. So I don't think we should wait for long. Waiting for 2-3 days is not bad, but waiting for 15 days may not be the good idea. By the time you can have a recovery of neutrophils. So someone who has been neutropenic for a month and then you wait for 15 days doesn't make sense.
So that's why, our practice is to wait till PCR, and with the help of ma'am, we've got the IDH1 incorporated.
This is the first time I'm hearing. I was saying the company also, they were saying you use a IDH1 inhibitor, but where to use it? Because you don't get the report.
Yeah, no, so we've incorporated the IDH1 in our PCR.
This is even the company was supposed to support the people for IDH1 mutation. I don't know whether they have approached you or not.
Yeah, so I was just going to. So the company actually approached us, and I think Dr. Nitin is very well versed about it. So they came and we actually discussed with them, should we start digital or should we start the other one? So we actually zeroed down to digital first. So our first attempt was to go into digital, but there is the point Dr. Nitin said that we anyway get a lot of mutations done by RT-PCR. We could add that to the panel. It will be easy to get it done in one go, but you could always monitor using a specific one.
Then you have to wait for 4 days.
Yeah, that is 4 days. That is true.
That's because we batch the samples.
Because we batch the samples.
Then Rahul will say, let's wait for 1 or 2 days more and then get the whole LGS.
So yeah, that's true.
I think if we can get it in 1 or 2 days, it's fine.
So
So because
that's
like
what.
the number increases, we always can reduce it to 2 days also, because again there's a wells and we batch the sample. But another point which I want to add is that the PCR which has is primers to the specific alleles for both the IDH1 and IDH2. So which are the most common variants listed by the guideline.
Yeah. So IDH2 mutation, the drug is not available with us. I mean, someone who can procure it from outside is a good thing. But at least this drug is available over the counter kind of things. You can
And
write
I
it
would
in.
say IDH is actually the next, it's a hotspot mutation. So it's just like a ATRA now. So it's
And
inhibitors
the
would be
good
like.
part with this is that you don't get a significant neutropenia. Your counts will go up. So if Rahul showed you the one graph, there's not much of a neutropenia. So probably the infections, we have to see how we, I don't have any.
It increases the enzymes which cause hypermethylation. So it is just it causes normal maturation of the blast.
Thank you.
Yeah. Any other questions? No. Thank you so much, Dr. Burani. And thank you, the organizers, for this.
Thanks to all the chairperson. Moving forward, I would like to invite the chairpersons to chair the next session. Dr. Dinesh Burani, Director, Hemato-Oncology and Bone Marrow Transplant, Rajiv Gandhi Cancer Institute and Research Center. Dr. Meet Kumar, Director and HOD, Hemato-Oncology and Bone Marrow Transplant, BMT Next, Gurugram. Dr. Nitin Gupta, Senior Consultant, Institute of Hematology and Molecular Medicine, Sir Gangaram Hospital, Delhi. Thank you, sir.
Good afternoon, everyone.
Good afternoon. Hi, so my name is Dr. Balakrishna Patte. I work as a director of hematology at Sir H.N. Reliance Foundation Hospital in Mumbai. We do bone marrow transplants, CAR-T, and treat all hematology patients. So I will, the topic that is given to me is modern management of ALL, from chemotherapy to precision immunology. I guess in acute lymphoblastic leukemia, it is more exciting than AML. Since morning you are hearing about AML and how we have changed treatments, but I think ALL, it is actually more exciting than AML. All of us know that any form of hematological malignancy, you have induction chemotherapy followed by consolidation, followed by maintenance. Some of these patients are going to relapse, some of them are going to have bone marrow transplants, some of them are going to have CAR-T. All of that is managed through MRD monitoring. When you get to elderly patients, induction chemotherapy of 1 to 3 months to reach a point where there is consistently monthly undetectable disease, and then consolidation of 6 months, and then maintenance of 2 years. That's very, very difficult to achieve in a 65-year-old person. And that is the reason 4 years back, if I had a patient who is 70-year-old with ALL, acute lymphoblastic leukemia, 50% of elderly patients with ALL are pH positive. But in both scenarios, pH positive and pH negative patients, to achieve this of 8 to 9 months of treatment and continue to give them maintenance is very, very difficult. So let's look at the actual data. In BFM and UCAL 2014, in an elderly patient, your 5-year overall survival is less than 20%. And the reason for that is poor tolerance to intensive chemotherapy because of fitness issues. Thrombosis, infections, relapses, a lot of people don't respond. The reason why they don't respond because intensification of chemotherapy is not as much as in younger patients. And that is the reason reducing the toxicity without compromising the efficacy and survival rate is very, very important. Hence, novel agents like blinatumomab and inotuzumab are being investigated initially in relapse refractory setting, which are licensed in relapse refractory settings, and hence then now moved on to the younger patients as well as in the frontline setting. So both the drugs are not new, they are old. Blinatumomab is a CD19 directed bispecific antibody, first approved in 2014 in relapse refractory BLL, and now approved in young patients as well as in frontline setting. Inotuzumab is a CD22 antibody drug conjugate, which is again not a new drug, first licensed in 2017 in CD22 positive relapse refractory BLL, and now also licensed in small children in 2024 for relapse refractory ALL, CD22 positive, and also licensed now along with chemotherapy in younger patients in the frontline setting. So these are the data for the trials for the frontline setting. We'll go through those in a moment. But before that, I will tell you a story of a patient. So I've got one 38-year-old gentleman which is Ph negative acute lymphoblastic leukemia. No comorbidities except that he had COVID, a severe COVID in 2021. Although fortunately he does not have a sequelae of that. In February 2026, recently he presented with GRD, fever and cough to the respiratory physician. He did a CBC and found that his WBC count is 28,000 and platelet count is 76,000 with 42% blasts in the peripheral blood. His bone marrow we did, which had 90% blasts, which are CD19 positive, CD22 positive, CD20 negative, CD79A positive. Hence he's got CD22, CD19 positive ALL. BCR-ABL fish was negative and CSF was normal. His genetic profile shows conventional karyotype, shows deletion 5q, monosomy 7, and a break in chromosome 9. None of these are high-risk abnormalities. Ploidy analysis shows hypodiploidy, which is a high-risk abnormality. Fish analysis shows PDGFR-B1 and CSF1R. However, partner chromosomes were not identified for both of them. NGS showed primarily PAX5 P80R, which was proved by another lab by NGS again. IKH head-up1 was negative, and Transec ALL suggested same thing, which was P80R. VF was 62%. Again, none of these abnormalities, excepting hypodiploidy, is considered as high risk. Although 5 years back, I would have classified this patient as high risk and considered, based on UKLR 2012's randomization, donor, no donor randomization, were considered for allogeneic bone marrow transplant if a suitable donor was available after induction. I will go through data of this paper. This is 2025's Nicholas Short's paper from MD Anderson. We'll go through this paper in detail in a moment. But in young patients, if you give inotuzumab along with hyper-CVD, followed by inotuzumab plus methotrexate and high-dose cytarabine, such 4 cycles with 12 intrathecal chemotherapies, and then combined with 4 cycles, 28 daily of blinatumomab, your near 100% patients will be MRD negative at the end of first cycle. Now, if you look at this data, patients who have got allogenic transplant based on risk stratification and patients who did not have allogenic transplant based on risk stratification, there is no difference in survival. So what the author says is that young patients who are Ph positive ALL, if they have inotuzumab with hyper-CVAD with blinatumomab, they achieve a long-term remission, almost cure, without using allogenic bone marrow transplant, even in high-risk setting. So that is what we would do for this patient. So he is received hyper-CVD plus inotuzumab and hyper-CVD plus methotrexate with IT, and then his MRD at the end of first cycle itself, first chemotherapy cycle by flow cytometry as well as clonosec. Clonosec is done at Washington by one of the companies. You have to literally ship the sample. Was negative. His NGS and karyotype was completely normal at the end of A section of the first induction chemotherapy. Subsequently, he had 2 blinatumomab cycle, each of 28 days, and his NGS, MRD and clonosec is negative. He is going to go for 2 more cycles, which is INO plus hyper-CVAD and MA, followed by 2 more cycles of blinatumomab to complete 8 cycles, and then going to go on maintenance of 15 cycles of POMP with 3 additional cycles of blinatumomab, which reduces your total duration of therapy. This is his actual report. So this is a mid-cycle clonosec MRD, which had 4 cells in 3 million cells, and since then it is negative, and current, at the end of second blina, it is undetectable. So we have three targeted therapies in ALL: rituximab, which we are not going to discuss today, inotuzumab, and blinatumomab. So inotuzumab is a CD22 drug conjugate, caliciamycin, and the side effects that you get are related to this drug, not related to the antibody. So what side effects do you get is veno-occlusive disease is more common in patients who have got anthracycline exposure, and more common in patients who have previously been exposed to anthracycline, or if you are using it in post-transplant patients. It is licensed in 2017 for relapsed refractory patients in adults, and it is licensed in 2024 for relapsed refractory ALL in pediatric age group. It is licensed in combination with hypercvad at all age groups, whether child but is not licensed as a single agent in young patients. So it is effective in clearing leukemia from the bone marrow in nearly 80% of patients. This is the story of elderly patients. So 5 years back, if I had a 70-year-old person with ALL, pH positive or negative, I would have said your survival is less than 10%, and your chance with chemotherapy to get to a CR is less than 20%. What happened with INNOVATE study? Inotuzumab in combination of chemotherapy, if you look at the CR rates, in chemotherapy it is 29%, and it is inotuzumab plus chemotherapy, it is 81%. It is almost 3 times higher. Your MRD negativity is 28%, and MRD negative with inotuzumab is 78%. It is significantly higher. If you use that in salvage 1, after any form of chemotherapy, patients have failed that and relapsed. If you use INO in combination of chemotherapy, you have 3 times higher chances of going into complete remission. And if you use in salvage 2 after chemotherapy, even in patients who have been exposed to blinatumomab, you have almost double the chance of getting into complete remission. The side effects are more common in allogeneic transplant patients in terms of BOD, not in chemotherapy patients. And this is in a front-line setting. Now we are moving to front-line inotuzumab. There are 3 trials, and if you look at the graphs, they are flattening. So overall survival is significantly improved when you use inotuzumab in a front-line setting, not only in the relapsed refractory setting. I will talk about older patients where you have used hyper-CV. What we have done is in younger patients, but I'll talk about elderly patients who have no chemotherapy options, and if you have given inotuzumab plus hyper-CVD plus blinatumomab, this is again MD Anderson published paper from last year's ASH. You have almost 50% of your patients which are high risk by classification. All these patients are not going to survive for 18 months without an allogenic transplant, and it is not possible at this age group, at 70 years of age group, to do allogenic transplant. See, the median age group that we are treating here with this is 68 years of age. 20% patients were CD20 positive. All patients were CD19 and 22 positive, and almost 18 to 20% of your patients were CD53 positive. I will actually read this out to you. So if you look at, there is a significant follow-up of 88 months. It's not a short follow-up. You have a 88 months of follow-up. And if you look at your overall survival, you have an overall survival of 78% in a 70-year-old person. So your 78% of your patients are alive at the end of more than 5 years if you use inotuzumab with blinatumomab in a 70-year-old person. While on chemotherapy, less than 10% of your patients would be alive at that time. And if you look at patients who have got adverse cytogenetics and who are between 60 to 70 years of age, you have around 73% patients alive at the end of 88 months. So they have got a significantly improved survival by addition of inotuzumab. Here your OS is 50% in all groups, including patients who are more than 70 years of age with high-risk cytogenetics, where allogenic transplant is not possible. So what the author says is in pH negative, newly diagnosed ALL patients who are elderly, if you add inotuzumab and blinatumomab to your chemotherapy, you have deeper remissions, you have excellent responses. Next is blinatumomab. It is CD19 T bispecific antibody T engager. All of us know about that. I'm not going to go into mechanism of action. So here we talk about our patients. This paper I have shown you. This is Nicola Short's paper from MD Anderson. So this, what they are doing is they are giving you hyper-CVAD with inotuzumab, hyper-CVAD with high-dose methotrexate plus cytarabine, 4 cycles of this and 4 cycles of blinatumomab. Then you have 2 years of maintenance in women and 3 years of maintenance in men in UKLL 2014 protocol, where you have reduced it to 15 months of POMP oral treatment with 3 cycles of blinatumomab in between, total 18 months of maintenance. And what has happened with that? What have you achieved? Again, I will read this. This is a 4-year follow-up again. This is not a short follow-up. You have 95% of patients who have achieved MRD negativity. In that group, you have almost 100% of patients in a younger age group who have survived at the end of 4 years of follow-up. This is the graph. So in maintenance, you have this red color that you see is blinatumomab. Those red again are blinatumomab, and these are your chemotherapy cycles. So what we have achieved at the end of 8-year follow-up is that you have almost overall survival rate of 80%, 79%. Now what they have done cleverly is that they have found that how many of these patients have been classified for allogeneic bone marrow transplant otherwise if they were not in this group. And they have compared these patients with high risk cytogenetics who had gone for allogeneic transplant, who have not gone for allogeneic transplant. Approximately around 18 to 20% patients eventually did go for allogeneic transplant in this group as well. And they found there is no difference in the survival when you did the allogeneic transplant and when you did not do it. And that's the reason they say that in a newly diagnosed Ph negative ALL in a younger patient, if you use hyper CVAD along with blinatumomab and inotuzumab, allogeneic transplant is irrelevant. So these patients are surviving with a longer term remission without allogeneic bone marrow transplant. What is most significant in ALL patient is MRD. So what is very, very important is that getting to a lowest possible level of MRD. There is a clear difference in MRD positive patients and MRD negative patients. So what is the actual role of blinatumomab? When did it came in 2017? What did it came for? It came for eradication of MRD. So it was used in MRD positive patients to make them MRD negative. It was not used to treat patients with the blast. However, over a period of time, we have understood that patients who have got significant number of blasts also it clears. So in patients who are MRD negative, if you get them MRD positive, they fall into this group where they actually do not need allogeneic transplant because their survival is similar. So it is primarily used for MRD negativity. So what that means is that if you use blinatumomab in any patient with MRD positivity, you are going to go down to such a low level that possibly a role of allogeneic transplant is going to get eradicated in those patients. So this is the cartoon that I would show you. So this is persistence of disease. Then you have morphological remission. You have flow cytometry MRD negativity remission, and you have a clonoSEC MRD negativity. And beyond clonoSEC, also there is some amount of disease left. So what is the relevance of knowing that information? That you have 1 in 1 million cell negativity like our patient. He is already negative, but I still have to give 2 more cycles of blinatumomab because of this. So this is an entirely different paper from Mayo. They say that use blinatumomab even in MRD negative patients. What is the implication of that? So they have studied 112 patients, and when you use blinatumomab in MRD negative patient and follow them up for next 5 years, they found their overall survival is different. So even when my patient is clonoSEC negative, if I use 2 more cycles of blinatumomab, it is definitely going to be beneficial to him. So this is the difference on that paper. So chemotherapy continuation, if I only give chemotherapy and if I add 2 more cycles of blinatumomab, he definitely has a better survival compared to that. So what point I am trying to make is that blinatumomab is useful in patients who have got blasts. Blinatumomab is useful in patients who have got low blast, in the sense morphological remission. It is useful in patients who are MRD negative, and it is useful in patients who are MRD negative. So across the group, it is going to be useful. So after that, now we are going to move on to Ph positive ALL. What is the role of inotuzumab in Ph positive ALL? So this is INNOVATE study. There are 2 arms of it. There are 49 patients in one arm and 16 patients on another arm. All these patients had inotuzumab. And if you look at the CR rates compared to a standard of care, the standard of care CR rates are 55%, and your inotuzumab arm in Ph positive elderly patients is 72%, although there was no difference in overall survival. Compared to this, what is significantly changed in Ph positive patients? So if you have got a 75-year-old person with a Ph positive ALL, it was very, very difficult to treat it 5 years back or 10 years back. This is a historical data of pre-imatinib Ph positive elderly patient. Their survival is less than 20%. This is changed significantly now. So what happened? If you give this 75-year-old person only dasatinib along with dexamethasone, significant number of these patients are going to go into a reasonable remission, although not MRD negative. But if you combine 2 to 4 cycles of blinatumomab and give them dasatinib, your 90% of patients are going to get cured. They are not going to be only MRD negative. If you follow them, this is an NEJM paper, please read this. This was published in 2020. So these patients, it may be a 75-year-old person, but if you combine blinatumomab 4 cycle along with, these are chemotherapy ineligible patients, if you give them a TKI inhibitor along with it, your 90% of patients are going to get cured, although they are going to remain on a TKI inhibitor. The last immunotherapy that I am going to discuss is CAR-T. All of you know that. There is a chimeric antigen, head is a tumor-specific antibody, and tail is the T-cell receptor. This is the first patient, first paper published in New England Journal of Medicine from which hospital? This is a New York hospital. I forgot. So they have almost 85% complete remission rates. This is Park's paper, 85% response rates with CAR-T. So again, we'll go back to the same slide. 80-year-old person coming to you with pH positive acute lymphoblastic leukemia or pH negative. Their survival response rates were less than 20%, survival rates were less than 10%. What can you do for these patients? So you can give them blinatumomab, get them into remission and do a CAR-T. You can do CAR-T at 89 years of age. There is no age limit on this. And what are their cure rates? We are not talking about MRD negativity only. We are talking about cure rates with CAR-T across the group, even at 85 years of age, is 60%. That is remarkable. So, and it is all the age groups. If it is approved for pediatric patients, adult patients, after initial therapy, it is after used, after blinatumomab, inotuzumab failure or relapse, after blina and ino, it is used after allogenic bone marrow transplant. In allogenic bone marrow, of course, patients should not be having acute GVHD at the time when you are using CAR-T. But in all those groups, it is still found to be very, very useful. The side effect profile is lesser when you take patients without lot of blasts. So lesser number of the blasts, lesser side effects, more blasts, more CRS and more ICANS. We need to remember that. Now, if you look at this, the whole trial data of all 3 CAR-Ts, almost 18 to 20% of these patients have gone on to have proactive bone marrow transplant after the CAR-T. No one really knows who are these patients and which patients at the time of diagnosis you take for bone marrow transplant at the after the CAR-T. No one knows that. So that requires time. Now we would need more time to understand whether these patients really needed transplant or not, and how do you segregate these patients from other 80% of patients. But you have to realize that 80% of patients across the age group have achieved a complete remission and gone on to survive for 4 or 5 years after the CAR-T without major side effects. And if you look at the response rate, these are up to 70 years of age. Their CR rates are with the CAR-T are almost 70-80%, and these are multi-drug refractory patients. Now after that, B cell, we will very briefly touch T cell because it's part of ALL. Now nothing has changed in T cell. You incorporated nelarabine in UKALL 2014 in England, and their CR rates have not changed. There is no significant difference. However, there is a hope now that there are several studies that are going about allogenic CAR, which is CD7, and in next 18 months to 2 years, we are going to have a CAR-T for T-cell ALL as well. So there is a hope for T-cell ALL. So what is the future in acute lymphoblastic leukemia? There are several subcutaneous, blinatumomab's problem, it's a prolonged infusion of 28 days. Patients have to be connected to the pump, it is expensive. So there are several companies which are doing trials for subcutaneous blinatumomab, which is under investigations as effective or better or even more effective than IV blinatumomab. I'll take 2 more minutes. Subcutaneous blinatumomab injections can be given like insulin 3 times in a week. Patients don't have to be connected to the pump. Now there is in vivo blinatumomab and in vivo CAR-T. What that means is rather than manufacturing CAR-T in the lab, you inject a mRNA vaccine and it works like a BiTE or a CAR-T inside your body. But that, it is still in early phase, but that is going to happen in next 4 to 5 years. Blina is already incorporated in maintenance like we are doing for our patients. Inotuzumab is not because of there is a limited dose of 2.7 into milligram per meter square because of risk of BOD. Duration of maintenance has definitely reduced by use of targeted therapy. What are unanswered questions are which patients are considered for bone marrow transplant? Is there a really role of bone marrow transplant in ALL patients now? Second question that is unanswered is how do we choose patients for bone marrow transplant and CAR-T? Which patients will go for it? So this question we are going to answer in Mumbai on 30th of August. I'll show you that for a moment. With Blina and INO use, induction and consolidation, do we really need maintenance in ALL? Because you have reached beyond clonosec negativity only during the induction in these patients. So what is the role of maintenance? This question remains unanswered. And can maintenance therapy be guided by MRD status of these patients during maintenance? So those are unanswered questions. So we have our cytogenetic and molecular studies, and how do you predict treatments for patients? This is a meeting on 30th of August in Mumbai. It's called Hematology Oncology Horoscope. Quite some of these questions will be answered there. This is a very focused molecular test and genetic test. And how do you choose your treatment based on the molecular test? Type of a conference for a meeting for a day. So please register your DNB MD candidate, DM candidates can register for this. That is the number to register. You call those numbers and we'll get you registered for that. And I leave you with those conclusions. Thank you.
So, thank you, Dr. Balakrishna.
Thank you.
So I think there will be many questions from the audience. We can take one or two. So may I ask one question?
Yes, sir.
So somebody who is chemo-refractory, B-cell ALL, and again, inotuzumab refractory.
Yeah.
What should we do?
So in that circumstances, definitely if they are CD19 positive, you would use blinatumomab. So any number of blasts, even I know refractory, blinatumomab will get them into MRD negativity. And
Blina is not available, so
not easily available. I guess so. So what do you do beyond that point? If you have access to blinatumomab, once you achieve a remission, this person who is relapse refractory, again based on the MRD negativity, you would decide whether they go for CAR-T or not. But certainly I would consider Blina followed by CAR-T.
Right. So any question from audience?
Yeah.
I mean, what about the safety of Blina when you have bulky disease?
Right, so that is a little bit of a problem. So like CAR-T, blinatumomab is like little bit like CAR-T. T cells get activated. If there are too many blasts, you are going to get CRS. You are going to get ICANS. So that is a little bit of a problem. So reduction in the disease load is very, very important before you use any sort of T cell therapy, either CAR-T or T cell engagers. So you see that all the time when in high disease burden you use blinatumomab. But still it is a manageable toxicity. So what we do now in our patients when we use blinatumomab is that we don't start with 28 milligrams, microgram. We start with 5 micrograms for 24 hours, then go to 7, then go to 14, then go to 24. And all these days are counted. In the trial they were counted. So if you give a gap of more than 4 hours, then they need dexamethasone again to reinitiate the dose. But otherwise, if the gap is less than 4 hours, you don't need steroid. And if the gap is less than 12 hours, for example, all gaps are counted because your blinatumomab is in the system while that side effect is happening.
Right. So I think in the interest of time, we will close this session.
Thank you.
Just I will call the next speaker now. Thank you, Dr. Balakrishna.
Thank you.
So next is MRD in ALL, and speaker is Dr. Chirag Shah, Ahmedabad. So Dr. Chirag, welcome.
Good afternoon. I thank the organizer for this opportunity to talk about this very important topic which all morning we have been talking about, and also debating about what method of MRD should be using. So I will go over some of these questions in the real practice. I think this is all very well clear that why MRD, because it is the most important prognostic and now we can say even predictive tool. How do we choose the treatment? So we will be answering these questions: how to collect, what method, what source, the timing, frequency, role in deciding transplant, role in deciding other interventions, and the interpretation. And the main this is mainly from the review in Blood Advances in 2025, where they've taken 10 experts and tried to answer these 7 questions which are clinically relevant. Before we go to that, I think it is important that the MRD is done right, because all the answers that we are going to get is based on how was the collection. So first, very simple important point to remember is that the bone marrow aspirate 1 or 2 ml first sample should be sent to the lab for the MRD, because if you are taking the further samples, then there is dilution from the peripheral blood, and that can give a false negative MRD. The stability is so for the stability purpose, it should be processed within 24 to 48 hours. If it is taken in EDTA purple top, then 24 hours, and if it is heparin green top, then up to 72 hours. In general, earlier the better, but for people who are sending it outside to a different city, this is important. When you collect it, gently invert the tube 8 to 10 times after collection and keep the sample at ambient temperature. Now, ambient temperature for the Western world is 10 to 30 degree, but for us it may be higher. So we may need to put the coolant alongside, but not put it directly with the tube, not with the vacutainer, because there will be cell loss in that case. So it should be placed, temperature remains lower, don't put it inside the box. And if you are doing the PCR, then you can divide the sample for both PCR and flow MRD from the single vacutainer. The adequate events for the flow cytometry based MRD, which is what most commonly is used in India as of today, is generally at least 10 lakh mononuclear cells. Less than 1 lakh is not adequate. 10 to 15 is good. 25 lakh is preferable, but many times you cannot get that many cells, especially early on in the treatment where the dilution, the bone marrow is hypocellular. Next generation MFC is something where you can get a 10 to the power of -6 sensitivity like NGS, but in theory, yes, but practically hard because you need 1 crore or more mononuclear cells. So again, in early on hypocellular, very difficult to get, but possibly later on. So now coming to these 7 clinical questions, what is the optimal MRD assay for the management of acute lymphoid leukemia? So in patients with B-cell ALL, this is a very nice paper you can read through, but these are the conclusions. I have posted exactly those conclusions. So NGS based MRD is definitely better if possible, but we know that as of today it is difficult, and the only one which is approved standardized by US FDA is clonoSEQ, which is quite expensive. But where available, and as in Europe they have many places standardize the PCR. If we can do that, as we learned that people here have started standardizing various PCRs for different purposes, then that can become useful and more cost effective. So in general, if you have NGS based MRD, that is better. For pH positive, of course, BCR-ABL1 PCR. So yes, in pH positive, NGS for the immunoglobulin rearrangement, T cell rearrangement, and RT-PCR for BCR-ABL1 are complementary. Although NGS for IGTR may be more suitable for prognostication because this assay has a greater specificity for the leukemic clone. In patients with T-cell ALL, we have to remember that the NGS and MRD assays are complementary because the NGS here is not very well validated. So especially you get sometimes this low level NGS positivity and you are not very sure. So there the MFC flow cytometry based is also to be used together. So MFC or PCR assay based may be helpful in select cases, such as when NGS-based MRD for IGTR is unavailable. The biggest problem may be that if you haven't done it at the baseline, then you cannot use it. And as you can see here, that cost is an issue in every country, not just India. So this paper from US also says that when it is too financially costly, then you go to MFC, which I think would be the very, very large number of people here. So when you are talking about different methods, for us MFC is going to be the big one. Also MFC provides antigen expression, which we don't get from the NGS. In patients with pH positive for whom NGS based MRD for IGTR is unavailable, PCR is preferred over MFC. But again, for us, most commonly it is RT-PCR. And MFC for India, many centers have standardized it fairly well. And I think that still would remain a very important option for us in terms of availability, cost, and even the speed. So the second question was, what is the appropriate sample source? So we understand that doing repeated bone marrows is invasive, and we would like to do a peripheral blood, but for the flow cytometry, there is clearly 1 or 2 log lesser sensitivity for peripheral blood compared to bone marrow. So what you can do is that once you achieve bone marrow MRD negativity, then it may become, you kind of can switch to peripheral blood to make it easier for patient. And then you can even alternate, say out of every 2-3 months, whatever time points you are doing it, you can do one time bone marrow to ensure that the sensitivity is okay, and then otherwise do peripheral blood. There is talk that for patients with extramedullary only disease like B-cell or T-cell lymphoblastic lymphoma, peripheral blood may be more important, although this has not been confirmed in studies. So you may have to do both peripheral and bone marrow in this. The third question is that what is the optimal timing and frequency of MRD assessment? So I think most of us do the first in the frontline ALL therapy after the induction, and if it is positive, then at end of consolidation. It can also be done for follow-up every 3-2 months thereafter for first 2 to 3 years when the risk of relapse is highest. Depending on the how high risk the patient is, what was the earlier, how soon did you achieve or not achieve MRD negativity, you can change the frequency of testing, and of course what you are going to do with that information. So if the patient is not going to be able to go for transplant or high-end treatments, then you may not want to do so many MRDs. For those patients who are undergoing allogenic HSCT or CAR T cell therapy, it should be done before treatment and after treatment every 2 to 3 months. We know that before transplant MRD negativity has a very strong prognostic impact, so negative or positive. So basically that is a time point where you want to know. Also, if there is an option, you would want to do some more treatment to achieve MRD negativity before going into transplant. Now, when determining the duration of MRD monitoring for an individual patient, the overall risk of relapse, the availability of a high sensitivity MRD, and a potential alternative to bone marrow assessment, and the cost should be considered. So at least MRD we should do at end of induction. If positive, repeat at end of consolidation. Adults may take longer to clear, especially for the pH positive. the standard cutoff is 3 months, based on which you decide the prognosis and even interventions. So the next question was, how should MRD inform decisions for transplant? This is for patients undergoing frontline therapy. So for patients with standard risk ALL, including those with Ph positive ALL, who achieve MRD negativity within first 3 months, with or without the use of blinatumomab, as the previous speaker alluded to, routine allogenic transplant is not recommended. So this is a very important value of doing MRD. Now for patients with high risk who achieve MRD negativity at this end of induction or even end of consolidation, it is not clear whether we can exclude transplant. So the recommendation is neither for or against, because there is no high quality data to be sure. But if you decide that the patient has achieved early MRD negativity and you are avoiding transplant, then you should do very close serial monitoring of MRD. Now patients who remain MRD positive after a frontline therapy that included blinatumomab, then they have poor outcomes, and these are patients where transplant becomes a very important option. When feasible, you should try methods to eradicate MRD before transplant, because we know that if you go into transplant with MRD positive, the results are almost half in terms of survival compared to MRD negativity. So the next question was, how should MRD inform decisions for allogenic transplant in patients with ALL undergoing salvage therapy? This was for the front line. Now for salvage therapy, can we use MRD to exclude transplant or decide when to undergo transplant? So patients with relapsed refractory ALL should be consolidated with allogenic transplant regardless of MRD response to salvage therapy. So eradication of MRD before the consolidative approach is associated with superior outcomes. So whenever possible, like we said earlier, that try to eradicate MRD before transplant, but it's not always possible, as we know. So another very important information is that patients in whom MRD is detected after CAR T-cell therapy should be referred for allogenic transplant. There was a question earlier that this is an unknown, unanswered question, and this is, they are not saying absolute, but this is one area where you can be kind of further pushing for transplant versus if MRD is negative after CAR T. So also in terms of prognostication, post CAR T 3 months, if MRD is positive, then almost all patients relapse shortly. So this is another way to kind of predict the the CAR T results, which you and patients all are very interested in knowing. The sixth question was, how should MRD inform decisions for non-transplant treatment? This was for transplant, but what about non-transplant intervention? How would you use MRD to answer that question? So patients with persistently detectable MRD despite appropriate therapy, or those who have become MRD negative and now have MRD relapse, should receive MRD directed therapy, which is one of the immunotherapy, blina or INO, or CAR T, and where these are not possible, to consider salvage chemotherapy. So intervention is recommended regardless of the MRD level, provided you have high confidence in the reporting of the MRD, because you have to be very careful with false positive MRDs, especially in the T cell ALL, where you can get sometimes these background noise. So as we are aware, blina is recommended for most patients with B cell ALL who have MRD persistence or relapse and who do not have prior exposure to CD19 targeted therapy. In India, I think for us, INO is less studied in this setting, but a very, very important option because we are all much more used to INO. And of course now CAR T cell therapy. So those are the options to be considered for suitable patients. And the last question was how should MRD reports using NGS be interpreted and acted upon? So I will not go in much of the detail. I think this is lot more of a lab question and maybe some lab experts can better answer that. But the idea was, I think in short, I would say that be careful with this interpretation, know your lab well, so don't keep on changing your lab, otherwise you will not know who you are interacting with and what are the consistency in correlating with your clinical outcomes. So over the time, if you are using the same lab, same person, talking to them repeatedly, you will have a lot more clarity. And whenever in doubt, see the trend, maybe repeat MRD in about 4 to 6 weeks rather than jumping to a major intervention. So knowing the lab and being careful about this interpretation is very important because our interventions are not easy, and also not intervening, like not treating, is also risky. So I think I end here. Thank you.
Any questions?
Again, for Ph positive, you said it is MRD at 3 months by PCR. So normally we do flow cytometry as well. And if there is a discordance between the two, how to go ahead with that?
Yeah, so I think you have to kind of repeat both. It's not very clear, and PCR can give false positive in multilineage cases. So as of today, the two tests that we have are not going to be very useful. This is where you will need the rearrangement, PCR or NGS.
Thank you, Chirag. We'll finish the session. Thanks for giving us an opportunity. Thank you.
Thanks to the chairperson and the speaker. It's a lunch break, so we'll meet you again at 2:30.
तू बाहर जाके ज्वाइन कर रही है?
Hello. हाँ यस ओके ठीक है ओके
Hello, 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 hello. Check 1, 2.
तो वो सेंटर
Check. Hello, 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 hello. Hello, 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 hello. Check, check 1, 2. Hello, check. Hello, 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 hello. Check 1, 2. Hello, check. Hello, 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 hello.
हाँ अब उसे येलो के साथ
Hello, 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 hello.
किस चीज़ पे करना है?
Hello. Check. Hello, 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 hello. Check 1, 2. Hey, hey. Check 1, 1, 2, 2. Hey. Check 1. Check 1. Hello. Check 1, 2. Hey.
क्या दिक्कत है?
हेलो हेलो
जोड़ना उस पर, इसको तार का हटा के यार पहले तार तो पता करने दो उस वाला कौन सा है, पता चला कि
check, hello, hello, check 1 2, hey, okay, check 1 2, check, hello 1 2, check, hello, check 1 2, check 1 2. Hello, check 1 hey 1 2, check 1 2, check, check, hello, check 1 2, hey, check 1.
Hello. Check. Hello, check. Hello. Bipin. पीछे चेक. हेलो बिपिन. हेलो. इसमें आवाज कम आ रही, इसमें तेज क्यों आ रही? छोड़ दो यार, तुम बोलो तो गुस्सा हो जाता है यार, इसलिए मैं कुछ बोलना ही नहीं चाहता, मैं बोलूंगा। Check, check, check. अब ओके ऑन है ये बंद कर दिया
So, good afternoon, everyone, and welcome back post lunch. To resume the post lunch session, I would like to invite the chairpersons to chair the sessions: Dr. Lalit Kumar, Chairperson, Oncology and BMT, Artemis Hospital, Gurugram, and Colonel Dr. Sanjeevan Sharma, Senior Consultant, Clinical Hematology, Army Hospital, New Delhi.
Yes, sir. Here, Dr. Rajan.
तीनों हैं?
Sir, एक पहले ये आएंगे. She will be joining. Till then, we'll have Zoom. Joydeep Chakrabarti on Zoom.
Okay.
So first, you have to invite Dr.
Well, very good afternoon, and thank you, Dr. Nitin, and the team for kind invitation. Well, CLL is something which really the number has been increasing, and there has been so much of change in the past 1 decade. I remember when we started our career, we used to give, for stage 0 and 1 or sometime 2 also, we used to follow surveillance, which we still follow. But for when the treatment used to come, then we used to give chlorambucil. That was the thing in the initial period, and then subsequently rituximab, bendamustine, and some of those things came for therapy. BTK inhibitors we had used very little while working in AIMS because of the availability problem, cost issues, and other things. But now in the last, I think, 5-6 years, things have changed a lot, and there has been kind of large amount of experience by the BTK inhibitors, the first generation and second generation, and which I'm sure our colleagues are going to share with you. So in this session we have 3 important talks, and the first is the frontline CLL, how to choose between BTK inhibitors and venetoclax, which is another new drug in the line for last 5 years. And I was told that the patent for this drug is going to finish next month. So I think there are 3 or 4 companies which are waiting the patent to be over. So we would be fortunate once the venetoclax becomes easily available. Nowadays not so easily available, and we have to import, and there are a lot of issues, paperwork and other things. But once it is generic brands available, I think the practice definitely will get a boost, and more people will be using. So to share this, I will request Professor Brigadier Dr. Rajan Kapoor, who is one of the pioneers in the field of hematology and currently working in the layer as a commandant and the director. Dr. Kapoor.
Thank you, sir. Okay. So this is about the frontline CLL management. First of all, I'd like to thank Dr. Nitin, his persuasive power that I've left this place in summers. We just had a snowfall in June, and I've come to the sweltering heat of Delhi. So thanks to you and Tejaswani for inviting me and giving this opportunity. So as sir had brought out, I'll just be going through CLL, the initial treatment. The next speakers are going to talk about the genomic changes in CLL. I'll be basically concentrating on the rationale for using BTK inhibitors versus the BCL2 inhibitors. What is the clinical evidence? For the paucity of time, I'm just going to focus on 2 major studies which has just come this month only, that is 5-year follow-up of CLL13 and CLL17. We'll try to make a decision matrix. So we start with a case which we get in the clinic, very common 67-year-old diagnosed as CML. As sir said, most of the patients we do adopt wait and watch. It's against the, say, anthem of malignancy diagnosis. Here is a disease where we say we have diagnosed the cancer and we are not going to treat. But then slowly, when they meet the criteria for treatment, then we have to decide what to do. And now we are spoiled for choices. Most important thing is the risk stratification in CLL. And though not mandatory at the diagnosis, because if we are having a wait and watch, we may avoid this, but once we decide to treat a particular patient, we have to do interface FISH. So these are the common markers which we have. We have been listening from the morning. The common villain which we have is this DEL17P or loss of TP53. 11Q has had a poor prognosis with chemoimmunotherapy. DEL13Q generally has a good prognosis. But if you ask me, if you have to do a frontline classification, the ones which I have marked in the red box, TP53 mutation and IGHV hypermutation, that has to be done before we start treatment. Why it is very important is that if it is mutated or mutated to P53 or unmutated IGHV, they are not likely to respond to the common medication. Now we have already seen this is the gatekeeper of resistance, and TP53 causes disruption of the DNA damage, and if that is detected, 100% chemoimmunotherapy is a failure. So obviously very important to know whether this is there at progression of the disease. Please remember, whenever you want to treat CLL, initially or at relapse setting, you have to repeat the FISH because TP53 may come down 9 months. Now, targeted therapy is non-negotiable in this aspect. And what about the IGHV? If it is a mutated one, generally indolent growth, these are excellent candidates for the BCL2 as we'll see in subsequent slides, but because considering the cost, mutated CLL can respond very well to chemoimmunotherapy regimen, the FCRs and the BRs. While the unmutated ones, they do not respond very well to chemoimmunotherapy. We may have to give continuous BTK or intensive triplets, as we will shortly. Before we go into the thing, it's very important to understand how these things work. The first and foremost is the BTK inhibition. Now, BTK or Bruton's tyrosine kinase is the central node in the B cell receptor signaling. Now, if you see, BTK has many downstream signals which are activated whenever the BTK is activated. When BCR signaling active BTK is there, the few things which happens is there is a survival advantage, now cell cycle progression, and the apoptosis is delayed. But you can, when you have BTK inhibition, the survival signals grow. But this, whenever you do a BTK inhibition, you can give an analogy of a bacteriostatic agent, like a linezolid. It suppresses the clone but does not eradicate. It does not promote apoptosis. So this is very important to remember that BTK needs a continuous suppression. It cannot eradicate the clone as such. So this is the famous Resonate 2 trial which established continuous BTK is probably a standard of care, and it is the agent with which you can compare the newer agents. So you have a progression-free survival of almost 40% and 10-year overall survival of 70%, which was way better than what chlorambucil used to give us. Then came the second generation acalabrutinib. So you see here we have the Elevate TN trial, 6-year PFS of almost 80%. If you combine ACAL with obinutuzumab, it is 78%, alone is 65%, and if you, they used to compare earlier with chlorambucil, it is less than 20%. So the bottom line is, at 6 years, almost 80% of patients receiving ACAL and obinutuzumab remain progression-free. Now we come to BCL2 inhibition. So this is for this presentation, when I read about this and tried to make this cartoon, this is very interesting. So CLL cells overexpress BCL2 to sequester the pro-apoptotic, that is called as BIM, the BH3 only proteins. Now what does venetoclax does? It pushes out the BIM from that BCL2 niche, and once the free BIM is activated, the backs and back, and it acts on mitochondria. Very important to understand, it causes the increased porosity of mitochondria and they lyse. So this is a lytic agent, it causes apoptosis. That's how BCL2 can lead to lysis of cell and decreased burden. Now if you have to understand what is the mechanism of action and the treatment strategy, ibrutinib versus venetoclax, as we had seen, It's a static agent, ibrutinib. So you have to give continuous BTK to block BTK-mediated proliferation and survival. Now, it leads to prolonged responses, but you cannot stop it. On the other hand, when you give venetoclax, it causes active apoptosis. It can leave deep responses, fixed duration. So if you see this graph, there is initial MRD reduction. Now in CLL also we are talking about MRDs. Now you have a fixed cycles around 24 cycles, and there is a high probability of long treatment-free response. Now this is the CLL 14 trial where they used obinutuzumab and venetoclax, and 5-year PFS was 62%, while they compared with chlorambucil, which was almost 27%. Now the other question comes, can we combine both BTK inhibitors and BCL2? So this is very interesting again. Now when we give ibrutinib, now ibrutinib, as we remember from the earlier diagram, so it not only has a survival and pro-apoptotic, it causes the migration of lymphocytes from the lymph nodes into the peripheral blood. So whenever we start treating patients of CLL with ACAL or ibrutinib, the TLC goes up. The patient says, मैं तो और खराब हो गया, पहले 30,000 तब 60,000 हो गया. So you have to explain to them that it causes the lymphocytes to come out of the niche in the lymph node to the peripheral blood. Now venetoclax sensitive cells are in peripheral blood. Unfortunately, venetoclax does not work inside the lymph node because there are other proteins which causes resistance. So when you combine ibrutinib with venetoclax, there is a synergy and there is a dual vulnerability, and you have a molecular harmony, and there has a clinical benefit. You have a faster and deeper response. So there is a case to combine this. So this is one trial which I'm going to say is a CLL13 GAIA trial, which is a 5-year, which has just come 1 week back. So that shows if you have a triplet, so you have obinutuzumab, ibrutinib and venetoclax. So now they are also going into an AML or a way. So you have a triplets, so they have a much more better response. So if you see this diagram, if you give a doublet or a triplet, venetoclax, obinutuzumab, or with ibrutinib, now you have a 92%. And in this triplet, if you have a IGHV mutated, it is close to 100%. So that is probably a game changer. So I just took away the Kaplan-Meier curves from this. If you see the PFS, very impressive PFS. If you see the top one is the triplet of GIV followed by GV, RV and chemoimmunotherapy. But if you do a subset analysis, very interesting fact comes in. The top one is the unmutated IGHV. Here there is not much of a unmutated IHV. There is a substantial difference if you use a triplet over a doublet or a chemoimmunotherapy. But if you see a mutated, even the chemoimmunotherapy works well. So if we do not have that kind of a finances, if it's a mutated IGHV, you can still use a chemoimmunotherapy or a doublet. There is no point practically to use a triplet in a mutated IGHV, because as with all the diseases, if you use triplet, the side effects are more. Now, there is a role of MRD, probably next speaker would be talking about it. If the MRD is positive at 15 months, the results are not that good. The other things which came out, obinutuzumab is definitely better than rituximab when you're using a partner as venetoclax. This is what I made, following key takeaways. If you use a triplet, it is 81%, but look at this graph of adverse events. If you use a triplet, cardiac events are much more, and as CLL is an elderly disease and we have a lot of patients with atrial fibrillation and all, that is a problem to take. Now the other trial which came, which answered the question which we are trying to answer, is a fixed duration versus continuous in CLL 17. In this trial, they took TP53 also, and they proved that fixed duration of venetoclax and obinutuzumab is better than the continuous BTK inhibitor. The problem is the median follow-up is only 34 months. Here is a disease where we are talking about 10 years, 20 years. 34 months is no period to be followed up. So if you, this is the slide which showed that MRD guided, there are 5 studies. The most captivating is the Captivate one, though it was a phase 2 where they had used venetoclax and ibrutinib. The key PFS was almost 95% in this. In this, they did an MRD guided. They gave venetoclax for fixed duration, but ibrutinib was decided by MRD. If MRD was positive, ibrutinib was continued. If MRD became negative, ibrutinib was discontinued. It's a very rational study. We're waiting. It's too early to say whether it is going to be game changer or not. So MRD, yes, we should do, but I'm not very sure whether we can adopt in the clinical practice, because here's a disease where we have indications for treatment. So why go for MRD? The cost is going to go up. So, as Sir had pointed out, what is the data from India? As of now, also, the recent paper, almost 50% are still on chlorambucil. So, we really have to figure out where we are going. This is a very interesting paper which just came on ASCO education book. So, there is A to E. So, advanced age, biology, clinical presentation, drug specific and expectation evidence. How do we do that? So, how do we do that? The most important thing is when you pick up a BTK inhibitor, always think about the arrhythmias. Now, the atrial fibrillation is the one which we are worried about. The other side effects which we have are of hypertension and the bleeding risk. A person on oral anticoagulants and all giving a BTK inhibitor is a problem. In venetoclax, so we are not used to TLS and CLL. It's never heard of, but venetoclax, when you give, there's a problem with the TLS. Practically, I have never used venetoclax in CLL because it is a complex dosing. So, but this is a nice table. If it's a high risk lymph node, ALC is more than 25,000, you have to give inpatient. So, there are drug-drug interactions. I don't know how to manage venetoclax because in AML we are using posaconazole to cut down on the dose of venetoclax. How to do it in CLL, we don't know. So, this is a paper which came out yesterday only, where they had compared ibrutinib with venetoclax and ecal. So, you can clearly see second and third generation BTK inhibitors are much better as far as atrial fibrillation risk. When you use the doublets and triplets, your neutropenia risk goes up and lower. If you go with BTK inhibitors, there are less of neutropenia. I won't talk about this molecular resistance, which is there in the next talk, but needless to know, there are certain markers. You can shift over if there is a covalent BTK inhibitors to a non-covalent one. Future horizons, the new kid on the block is petotrubinib, which is a highly selective. It does not require C481 site, non-covalent. It works very well. There are BTK degraders which are coming into the market. The bispecifics will come into CLL as well as CAR T cells. Now, the most important thing is what are the patient expectations, whether they want a BTK inhibitor or BCL2. If they want to, an elderly patient, they want to avoid clinical visits, infusions, go for BTK inhibitors. Young person wants to get cured or off medicines, we can give a combination therapy. So our patients, this is a patient which was given venetoclax and obinutuzumab, high likelihood of achieving UMRD. So if you have to summarize in one slide, this is the algorithm which I tried to make from all. So you newly diagnosed TP53 disrupted or DEL17P, till now BTK inhibitors. In DEL17P, no point in giving fixed dose because it's going to persist. So you use a BTK inhibitor backbone. If it's a mutated IGHV, fixed duration clonal eradication, BCL2 backbone. Unmutated, try to give, if young, a triplet. Triplet is the answer for the unmutated one. Always look for comorbidities. If it's an arrhythmia, don't use ibrutinib. Arrhythmias can develop in between also. Fixed BCL2 based combination would be the answer. So just a minute more. So this is the TP53 and IGHV favorable. Obinutuzumab, if can be afforded, moreover rituximab, and triplet only in unmuted one. So it's no longer a protocol, it's between clonal biology, comorbidity and patient lifestyle. I think this cartoon I picked up, most of us would be at multitasking, listen, ignore and forget all at once, but maybe someone has listened to it. So any questions I can
thank you, Dr. Rajan.
This is the last slide.
That's a nice summary. And thank you so much. So do you get a lot of cases in Ladakh or
No,
very
no,
few?
no. We get a lot of thrombosis and other things, sir.
Okay.
Not to
Mountain
CLL,
sickness and other things.
Yeah, so a lot of troops there, so probably that.
I was just wondering, like old timer, like what is the place for rituximab in CLL nowadays? Where do you use it? Do you still use it or
Yeah,
don't
so
use it?
the rituximab we do use as a form of a chemoimmunotherapy. So bendamustine, the best partner till now we are using rituximab or an FCR. But as of now, if there is TP53 or any other mutation, then no doubt we have to use a continuous BTK inhibitors. Now, chemoimmunotherapy still has a role in a mutated IGHV mutated young patient as such, but most of the patients generally we have shifted to BTK. I personally don't have experience of venetoclax. I would like to take opinion of how if they use venetoclax in CLL, because it's a very complex dose. You start with 20 milligram, then 50. I don't know. We don't get the tablets. We use venetoclax in AML with posaconazole and use 100. I don't know how will we titrate it in CLL as such. So I haven't used, sir, any.
A lot of people have experience with the AML. I think they're using venetoclax with.
Yeah, I can answer that. So, I mean, CLL, venetoclax, first now the 20 milligram tablets are available.
Okay.
But before that, we split 100 milligram into 4 and gave it to patients, 1/4. That's how we did. And it worked very well. These were relapse patients, but this is a powerful drug. And even at 25 milligram, the lymph nodes melted away. So you have to be careful.
Yeah, so TLS is an issue.
And we have not been able to go up to the 400 milligram because there is either cytopenia or lot of glossitis, mucositis with trying to higher dose. But it works very well that way. I have now patients on the frontline fixed duration regimen. They are doing well, again not able to go beyond 200, but so the finite therapy. And you mentioned that in TP53 to give continuous treatment, but I think there is data, I don't remember offhand, but you can use the combination, stop finite therapy, and they will have a treatment-free interval of few years, 4 or 5 years and all. So kind of then you can repeat.
Yeah, this is the guy I'm taking last week. So they have recommended that because they did not use TP53. CLL17 was the only one, but their TP53 did very badly with the fixed duration. So now TP53, because of the biology, requires continuous suppression. You may give ven and all, but you will have to continue ibrutinib. So as of now, present day, TP53 positive means you go for a BTK inhibitor, IGHV mutated, go for a triplet. Others, if you can afford, you use a ven and BTK, but we do use chemoimmunotherapy in IGHV mutated also. Transplant allogenic, I just remember my AIMS day, we did one when medical oncology was not a very good transplant using rituximab and other things. So,
Thank you so much, Dr. Rajan.
Thank you.
Great.
So, our next call after the frontline CLL, we have relapse refractory CLL and how we sequence after the BTK again. So this is a talk which we are getting from Dr. Joydeep, who will be joining us on Zoom call. So may I request Dr. Joydeep, the tech team, to please connect Dr. Joydeep's Zoom call.
Good afternoon, can you hear me?
Yes, Dr. Joydeep, please.
Thank you very much. And so, I'm sorry I couldn't make it.
Yes, Dr. Joydeep,
and,
please.
Organizers, especially Dr. Singh, was very kind to allow me to do this online. And he is also very kind to help me out with the topic which we have changed.
So, Dr. Joydeep, there's an echo. Are there two devices which are open side by side? Because there's a lot of echo.
So, Dr. Joydeep, there's an
an echo. Are there two devices which are open side by side? Because there's a lot of echo.
No, sir, you can continue. We can see your slides. Just make it full screen. No, sir, you can continue. We can see Actually. Just make it full screen. Yes, yes, it's okay, sir.
Thank you, Dr. Joydeep. So the session is open for a quick couple of questions. Yeah, Dr. Nitin has a question. Thank you, Dr. Joydeep. So,
hi Joydeep, can you hear us?
The session is open for a quick couple of
Yeah,
questions.
we were just discussing. Do you know what the cost of the feedback? We were just discussing. Do you know what the cost of what the cost of
I am free, I come free. What's the cost of what? I can't hear.
No, the cost of the CAR-T.
For which one? 1922?
1922, yeah.
So the 1922 car, as you know, we get it on a only patient basis. So the cost of the car is comparative basis without any manufacturing, what do you call it, profit. We get it for 45,000 to 50,000 US dollars as of now. But definitely, you know, there are lots of discount schemes and lots of other things that can be applied. So I think, you know, that is the cost of the CAR-T as such. But as you know, that there are many Indian companies who are now coming with dual and triple CARs, and definitely if you're going to produce it indigenously, hopefully the prices are going to be much less. So it's only a matter of time that we see our own dual and triple cars, and maybe the next generation cars also. You know, it's high time we look into a third-gen car right now.
So the triple car is also $45,000 to $50,000?
Yes, the same price.
Right. Okay.
Now,
Thank you.
I think, you know, a third generation car, if you ask me, the triple car is also $45,000 to $50,000 will work better. And you've got two pathways of full stimulation in a third gen. And you've got your CD40, your 28, everything. So I think, you know, a third generation car might have better the use in diseases like CLL compared to just a second gen car. Just a second gen car, you know, people are spending lifetimes on that. So not just, but the great second gen car, right?
Thank you, Dr. Joydeep. I think you initiated a nice little thought process about CAR-T in CLL, something which is very less talked about, and thank you very much. Thank you, Dr. Joydeep. I think you initiated a nice little thought process about CAR-T in CLL, something which is very less talked about, and thank you very much.
Well, now it's my proud privilege to introduce Dr. Amrita Ramaswamy. She is AIMS alumni, and only hobby for Amrita is have a coffee from Pondicherry. That's what she always likes.
Thank you, sir. Mike? Okay. Okay, this is the pointer. Okay. Good afternoon, everybody. First of all, I would like to thank Dr. Sood for giving me this opportunity. And I was supposed to go in before Dr. Joydeep, but then I'm going in a little later, so the topic may be, you know, he spoke about something which is probably still not available for many patients in India. But then we have a lot of, now we understand that nowadays it is molecular hematology. Everybody talks about molecular oncology, molecular hematology. But how much of this is actually relevant to clinical practice? Do we need to do NGS, maybe start doing NGS in CLL as well? So these are certain questions which I would like to kind of clarify and answer and talk about. So what are the molecular tests that are really important and which impact our decision, which impact our clinical management in patients with CLL? Now all of us know that CLL is an incurable disease. We may talk about time-limited therapies, we may talk about indefinite therapies, but then at the end of the day, it's an incurable disease. Patients are going to relapse. We can talk about functional cures, yes, but then it would still be an incurable disease and multiple therapies are available. How do we best choose the best initial treatment for a given patient? What are the biological factors that we look at? What the disease biology is? These are things which have already been covered by Dr. Rajan in his presentation, but how do we choose? So Dr. Rajan has already extensively spoken about IGHV mutation status. He has spoken about TP53. He's spoken about deletion 17p. So one thing which I would like to point out is there is a paradigm shift, whether we like it or not, in the treatment of CLL. There was a time when we were doing BR for all patients. That used to be our go-to regimen. But the paradigm shift is we are moving away, whether it is time-limited therapy or indefinite therapy, we are moving away from chemoimmunotherapy. We are using chemoimmunotherapy in a very, very small subset of patients, probably younger patients who have mutated IGHV and who have a good progression-free survival and maybe one extra therapy before they eventually relapse. We are moving towards targeted therapies, and that's the paradigm shift in the treatment of CLL. Now this is a table which shows us what a baseline evaluation of a patient with CLL should include. So we have tests to establish the diagnosis, basically a CBC, and most of them have leukocytosis. So you do a peripheral blood flow cytometry to establish the diagnosis. And apart from that, when we talk about additional tests which help us prognosticate patients and decide what treatment option would be best for that particular patient, we talk about FISH tests, which look at the common abnormalities like deletion 13q, deletion 11q, deletion 17p, trisomy 12 on peripheral blood lymphocytes. Conventional karyotyping, how many of us actually do conventional karyotyping in CLL? Okay. Are you successful? Do any metaphases grow or they don't? Dr. Harshit. Yeah.
Yeah, anyway, FISH is the standard for the standard 4 mutations or the chromosomal translocation that we are looking for. But then overall cytogenetics are we do send them, though the reports pick up abnormalities less often. FISH is obviously directed to a particular chromosomal abnormality that we are looking at. So the samples are sent, but yes, maybe 10% of them do find some abnormalities.
See, most studies tell us that a complex karyotype, which is defined as more than or equal to 3 cytogenetic abnormalities, confers a poor prognosis, and these patients are also better off getting continuous therapy. But I don't think many of us do cytogenetics as part of routine clinical practice. And we need to understand that CLL is a slow dividing disease. The mitotic index is quite low. So you probably would not be successful by doing conventional cytogenetics. And what is generally done is CPG stimulated cytogenetics, where you basically stimulate the B lymphocytes to divide, and then you look at metaphases from those cells, because normal B lymphocytes, they do not proliferate so well, and it's very difficult to culture them and look at metaphases. So what is specifically done in CLL is something called CPG, oligonucleotide stimulated cytogenetics. Apart from that, how many of us do TP53 mutation through sequencing? So we need to also understand that TP53 mutation is not synonymous with deletion 17p. Somebody can have a deletion 17, somebody may not have deletion 17p and still have a TP53 mutation. You can have a monoallelic loss, you can have a biallelic loss. Both confer worse prognosis, but biallelic loss actually confers a worse prognosis. So it is important to do TP53 mutation and just not end with a fish. And IGHV mutational status, obviously unmutated IGHV, again by sequencing, needs to be done in all our patients. So I think I would, just with this table, I would kind of summarize, or I will go through the other slides, but then if you ask me what is essential for practice, definitely we need to be doing a fish panel. And probably in the near future, we could be doing a CPG stimulated conventional cytogenetics to identify people with complex karyotype, which may not appear on fish. And these people also tend to do badly. And TP53 mutation by sequencing has to be done, and IGHV mutational status also needs to be done by NGS to kind of identify whether somebody is mutated or unmutated. Now, very quickly, when we talk about prognostic and predictive markers in CLL, prognostic markers are those biomarkers that will tell us information. There is a difference between prognostic and predictive. So prognostic tells us, even without receiving treatment, how somebody is going to behave. We know that deletion 17p or TP53 mutated CLL, they do bad with any therapy. Be it continuous therapy or be it time-limited therapy, their overall prognosis and their overall survival is not great. So in that situation, obviously TP53 and deletion 17p is a prognostic marker. It tells us how a particular patient is going to do, and it is also a predictive marker because it tells us what treatment we'll have to probably choose for that particular patient. So some markers are prognostic, some are predictive, and most markers, if you see, they are both prognostic and also predictive of a patient's response to a particular treatment. Now coming to the established prognostic markers, so this is again a short summary. When we talk about the FISH or the cytogenetic markers, the favorable one is when you have isolated deletion 13q. Then the ones that have intermediate prognosis are trisomy 12 and normal karyotype, and the unfavorable ones are deletion 17p, deletion 11q, and a complex karyotype. When we talk about the molecular markers, which we identify by NGS, the favorable one is the mutated IGHV, the unfavorable ones are TP53 mutation and unmutated IGHV. So people use the term TP53 disruption sometimes to indicate that somebody may have a TP53 mutation or they may have a deletion 17p. And the emerging molecular markers are Notch1, SF3B1, BERK3 and ATM. Now these emerging markers, they have been shown in various studies to kind of confer a poor prognosis, but we really need to show clinical trials. Probably they may get incorporated in the future, but as of now, data is pretty limited. Though there are studies which show that these molecular markers confer a poor prognosis, I don't think they are essential for clinical practice. Now, we also need to understand that the incidence of prognostic markers, it varies both in the treatment naive and in the relapse setting. So, do we repeat a FISH when somebody relapses? Absolutely yes. So repeating FISH at the time of relapse is extremely important because bad cytogenetic abnormalities or bad genetic alterations are enriched in the relapsed and in the refractory setting. And somebody who didn't have a TP53 or a deletion 17p in the treatment naive setting, when he relapses, he or she could acquire a TP53 mutation or a deletion 17p. But the IGHV status is one marker which tends to remain stable throughout the disease course, and you may not repeat it again and again. So this is just a slide showing how markers, they kind of differ in untreated patients and in relapsed refractory patients, with Versa abnormalities becoming more prominent as the disease evolves and as the clone evolves. Now, is deletion 17p and TP53, are they synonymous? No, they are not synonymous, and we have already touched upon this. So we'll have to do both FISH and also next generation sequencing to identify whether somebody has a deletion 17p or a TP53. So as I said, biallelic TP53 inactivation confers a worse overall survival in all populations, both in treated and in untreated patients. Now when we talk about IGHV mutation status, so the technique that is used is next generation sequencing. So basically the IGHV region is sequenced and it is compared to a database, and if there is less than 98%, if there is a more than 2% change when you compare it with the germline sequence, you call it a mutated IGHV, and if there is a more than 98% homology with the germline sequence, you call it an unmutated IGHV. So basically you would sequence the patient's DNA, the DNA in the lymphocytes, in the CLL lymphocytes, and you compare it to a database and you see how homologous it is to the germline sequence. So if you have greater homology, it is unmutated, and if you have more than 2%, that's a very small number. If more than 2% you can demonstrate a difference or a change, it would be a mutated IGHV, which confers a better prognosis, and chemoimmunotherapy still has a role in these patients. Deletion 13q isolated confers a good prognosis. Deletion 11q, as I said, worse prognosis. Trisomy 12 is an intermediate prognosis. So these are the emerging molecular biomarkers, and then with next generation sequencing kind of taking over most diseases in hematology, very deep and ultra deep sequencing, they can identify even small clones with very, very low allele frequencies in these genes. But then there are some studies which show that these clonal and subclonal mutations in these genes, they can impact the overall survival and a shorter time to treatment in some of these patients, but we really do not have good quality evidence or literature to support the same. And when we talk about MRD, I would like to see a hands up. How many of us do MRD in CLL? Okay. So how do you base your treatment decisions or on that? Is it like when somebody is on some treatment, do you do MRD to stop treatment, or you do MRD to probably escalate treatment? How does doing MRD kind of give confidence to you or to the patient in somebody who has CLL?
So we started doing this primarily for the fixed duration regimen. So if patient at the end of 1.5 years has been MRD negative, then I'm more comfortable stopping. But if not, then I would continue the BTK inhibitor. So that's where, as of today, I am using it.
Okay, so only when you want to stop it?
Yes, only for a stop.
Dr. Sood?
I mean, we know BTK inhibitors very rarely get somebody to an MRD negative state. It's usually the venetoclax based treatment or the fixed dose combination that will do it. At the moment we do it at the end of the first year when we're giving somebody obinutuzumab or Venetux, especially in a relapse setting.
If somebody is positive at the end of the fixed duration, would you continue or would you still stop?
No, I think I would still stop. I don't base my decision.
So the MRD positive result has really not impacted your treatment decision?
No. We don't base, there's no evidence to say that you base your decision on that, but it just gives you more confidence really. They're generally MRD negative.
Just to show the patient that such an expensive regimen has put you into an MRD negative state.
And you're now done.
Okay. So, I personally do not do MRD in any of my patients with CLL, and I'm not sure until we have more evidence whether I would even start doing MRD. Would you do a bone marrow or would you do a peripheral blood?
Bone marrow at the moment.
Okay. So these are lots of unanswered questions when it comes to CLL MRD. So like we have robust data in ALL MRD, we are still not there yet, and I think a lot of fine tuning needs to be done. So that is just one, that is my take, or that's just a short message on CLL MRD. So in all patients who have CLL, CpG stimulated cytogenetics, probably we may start doing them in the future to identify people with a complex karyotype, because these are patients who do better with continuous therapy compared to time limited therapy. TP53 mutation, absolutely yes, both at diagnosis and at relapse. And IGHV status just once before you start treatment. Probably we may start doing gene sequencing panels when we have more data about the genes that I mentioned. MRD, I think, still is not yet prime time in CLL. And with this, I would like to end. And I can take any questions. Thank you.
Thank you, Dr. Amrita. Is there any questions or any comments? Yes, Dr.
So IGHV, as you said, is compared to some database.
Yes.
So
I read it up just yesterday.
So yeah, I mean, surprising. So that is a database.
That's how the technique is, and I was surprised. So there is a database, it's called IG Blast or IMGT or BT. So that's where they have the minimally mutated or the virgin sequence, and the patient sequence, once they sequence it, once they amplify and sequence it, is compared to that sequence in the database, and the difference is calculated. More than 2% it is mutated. If it is less than 2%, it is unmutated.
Yeah, so after hearing that, I was also concerned that it's such a tiny line. Yeah, that's 2%. I mean, you are making very big treatment decisions based on that, and that too some database which I don't know. I mean,
how
we
relevant
many
it
times
is to
say
Indian population.
Exactly. Yeah, that's the other concern.
So I personally feel probably mutation status also may go out of fashion, because we are moving to targeted therapies. I don't think we'll be doing chemoimmunotherapy in most of our patients in the future, unless of course we have a very young CLL, mutated IGHV status, you just want to buy some more time with one line of therapy. Probably these are the patients where you may really benefit to know whether somebody is IGHV mutated or unmutated. If you had an elderly patient, 70-year-old or 60-year-old, I don't think anybody would even be considering BR or FCR in the future.
Yeah, BR definitely not, because it's definitely proven to be worse. But FCR, there's a very small indication now. Coming back to the IGHV mutation, I mean, we have a test, we have a FISH panel, right? And you asked about TP53. The practicality is that we do 17p, 11q, 13q, and trisomy 12. And the IGHV mutation is is by FISH, not by PCR. The real IGHV you have to do it
is
by sequencing by PCR. That is what will give you more than 2% or less than 2%. I think Dr. Ritu had.
I think Lal's offers sequencing.
So I'll just like to clarify on the IGHV mutation. So this IGHV is a longer kilobase gene. So you have to do it by Sanger sequencing and not via NGS. It's just like ITD, which is like capillary electrophoresis, just because it is longer sequence. And normally when you are saying that you match it with the reference genome, so that is 98% homology is just similar to what NGS sequences are read against your human reference genome. So 2% is just a VAF. It is a variant allele frequency. More than 2%, that is the cutoff. And it is just like a VAF and in a NGS term. And so 2% is the cutoff, which is normally for a chip also. So it will not be a difficult thing to like see the report and interpret. So otherwise it's a wild type, which is like a normal gene, and the mutation would be a mutation. So wild type and a variant, which is different from the normal human genome. So yeah.
Cytogenetics you were talking about, this is done from peripheral blood or bone marrow?
Bone marrow.
Bone marrow,
Yeah.
in CLL also?
You can do it on the blood, but then you need to stimulate the B lymphocytes. I think it said blood, if I'm not wrong.
No, basically in acute leukemias we do from bone marrow, but here from
See, you
blood
need a dividing cell fraction so that you can, do metaphases and look at the metaphases. So if you have if you have a tumor with a very low proliferative fraction, a low mitotic index, you need to be adding CpG oligonucleotides, which are actually they are similar to bacterial DNA. So just like a bacterial DNA, it stimulates the B lymphocytes, it stimulates the TOL-R receptor 9 to be accurate, and it makes the B lymphocytes divide. And then once they are in the cell cycle and they are dividing, you kind of can identify the metaphases better.
But what is one answer, from blood or bone marrow?
Bone marrow, all karyotypes.
I think it's blood. Can we see the slides again, please?
And one more thing, this TP53 and this deletion, TP53 and deletion, TP53 and one more thing you said from NGS, that is the only technique for that, TP53 and another thing you were saying, that is by NGS. Is this the only method for?
TP53 is
only by NGS?
Yeah.
No other technique?
No. It's a gene that has to be sequenced. So it says conventional karyotyping in peripheral blood lymphocytes with specific stimulation. Stimulation is using the CpG oligonucleotides, which is like a bacterial DNA. So it stimulates the B lymphocytes to divide, and then you do a karyotyping.
IGHV, you said Sanger sequencing.
That is always right.
One more thing, Sanger sequencing for IGHV mutation. So the lymphocytes are normally seen in a patchy distribution in the bone marrow biopsy. And now we know that CLL is actually labeled once the peripheral blood count is more than 5,000. So it is like you have to do, so peripheral blood is much more useful in a CLL setting as in a CLL/SLL setting rather than bone marrow.
We hardly do a bone marrow in CLL, right?
Because
even for diagnosis,
patchy.
we don't do a bone marrow.
Biopsy. No, but peripheral blood shows a
You
better
have
picture.
PRC. I think that's the only indication where you probably do a bone marrow in somebody with CLL.
Right, aspirate will have but it will also not have a homogeneous distribution of lymphocytes in a drop of blood as well. Like, I understand.
Yeah, it's on blood. It's on blood. It's on blood.
So
thank you, Dr. Amrita. I think we had a good discussion. And just
thank you.
We had very interesting session. 3 talks on CLL. And Dr. Rajan Kapoor's talk, who introduced the fixed dose schedules for venetoclax and BTK inhibitors. And then subsequently we had CAR-T cell mechanistic aspect by Dr. Jaideep Chaudhary and Dr. Amrita, who told us about prognostic and predictive factors for CLL. So with this, I think we'll call now Dr. Tulika Seth to take over from the next session.
So thank you very much. We have a panel discussion. So I invite Dr. Harshit and Dr. Pavan for this. And can I have my slides, please? This is final, yeah. Lovely. So we're shifting gears now. We're moving to AML. And AML, as you know, is something that we all have been treating for many years, and now with the advent of venetoclax, we're now finding many patients who were earlier ineligible for intensive chemotherapy. We're able to offer them many good options. So we have Dr. Pavan Kumar Singh, who's Vice Chairman, Hemato-Oncology and BMT at Sharda Hospital, Greater Noida. And we have Dr. Harshit Khurana, who's Professor and Senior Advisor, Medicine and Clinical Hematologist, Department of Clinical Hematology and BMT, Army R&R Hospital, New Delhi. And this is a sponsored session. So can I project my slides? Okay, so we have a case discussion. So our first case is a 67-year-old gentleman. He presents with fever, body aches, the typical symptoms and generalized fatigue. He also has comorbidities of hypertension and type 2 diabetes. So he's older in age and he has several comorbidities, and he has anemia and a high white count. He has 60% blasts and moderate thrombocytopenia. So this is very simple. What test would you recommend at this stage? Either of you may jump in.
Ma'am, so first of all, a bone marrow assessment, both aspirate biopsy and samples for conventional karyotyping, PCR panel, and these days without an NGS we can't proceed. So the molecular as well as the NGS workup, the basics. And in addition, the workup for comorbidities and the functional status of the organs have to be parallelly, simultaneously go on.
And he has fever, so it could be disease fever, but it could also be an infection. So you would also want to do
a blood culture, a urine culture, and a chest X-ray, a CT scan, whatever, based on the clinical presentation and associated symptoms and clinical signs for the fever.
Perfect. So we have this gentleman on the bone marrow, 56% blast. IPT is given here. The molecular test shows NPM1 and IDH2 positive. He's negative for FLT3, ITD, and IDH1. Cytogenetics normal. There's no prior history of MPN or any familial cancer syndromes. There's no previous autoimmune or other chronic illnesses. So what risk category would you consider this gentleman to be in?
So based on the current this, it can be put in intermediate risk only. So and because nowadays molecular characterization is also incorporated into the classification, so I think obviously it is not fitting into the favorable, and adverse risk factors are not there. So IDH2 mutation ideally is means can be incorporated.
Okay.
So the newer classification, the 2024,
Yes.
which is essentially
Right.
not based on the less intensive but intensive chemotherapy, in that it comes into favorable category. The IDH mutations have been included. Otherwise, in the previous one, the IDH was not considered.
So this is something that I just wanted to highlight, because we now have many patients who our previous guidelines were all based on chemotherapy, 3+7 or other standard therapies. Now that we're using, many patients are on aza venetoclax. What is the prognostication of patients who are on aza venetoclax? So we know that aza venetoclax is quite good for patients who have IDH2 mutation. IDH1 mutation doesn't do too well. So even though, as Dr. Pavan said, it would be intermediate risk, but perhaps now looking at this, I don't know how widespread this new classification is, but we know that patients on aza venetoclax with this kind of a mutation will do okay. So what are the factors that you consider for deciding whether you're what are your frontline options for an AML patient? So patient has come, obviously he has AML. Sometimes patients are older, if they're very old, if they're in their 70s or 80s, then of course it's a no-brainer. But we sometimes have patients in their 50s and 60s where we're not really sure what to do. So how do you approach this? Of course, we all do this, but it's just to enumerate, so please.
Important things are so one is the disease related characteristics which we need to take care of, and other is the patient related things like his fitness, age, performance scores. So these are important things, and so obviously age and plus underlying infection also, that also need to be ruled out, particularly in our set of patients where we see delayed diagnosis, patients coming from their background also, so risk of infection is always there. So that has to be ruled out before deciding and even discussing about the patients. So molecular abnormalities are, so normally means the NGS report usually takes time unless we are doing in the different platform where we get early report.
So do you wait for the NGS report, supposing the patient is afebrile, no tumor lysis, no hyperleukocytosis, no other issues?
Ma'am, actually, if we see in our routine practices, like IDH2 particularly, even if it is there, so targeted therapies, they are not recommended as first line. So basically we have to decide between aza-ven versus the intensive therapy. So, and that does not depend on the molecular report. So it's
So mostly
decision is mostly based on the
comorbidities,
comorbidities, age, and
right.
performance score.
One thing that we don't really talk about is patient treatment preferences, and at AIMS we were kind of, I think, doing a patriarchal system in kind of making these decisions. Now, even at AIMS we're changing. I have 77-year-old patients who are having DLBCL and other things, relapse 2 lines, and they still want treatment. So I think it's also important for us to remember, and I think medico-legally also it's a good point to just make sure that we are checking with patient goals and treatment. Of course, some may be unrealistic, but in some situations they could be attainable. So what are going to be your goals for this patient? Would you prefer best supportive therapy, HMA monotherapy, venetoclax with an HMA, venetoclax with low dose Ara-C, or intensive chemotherapy?
So, ma'am, because it's a 67-year-old, so we are not obviously looking at the cure at this moment, because ultimately it has to be to provide better quality of life and to get some initial control of the disease, and then after that some kind of maintenance so that he should remain in remission. We know that it is not going to be a durable remission, but at least the good quality of life can be provided to this patient.
Right. And though we do counsel our patients that this is palliative therapy, but we do have patients who have survived quite long. My longest surviving patient on Azaven is 6 years now, with very good quality life. But obviously this is not the rule. Most patients we see, about 3 years or so, and then they do progress. But this is just a slide to show how the landscape of AML has really radically changed. And Tejaswini is here. I remember giving a lecture on how 3 and 7 is no longer standard of care for AML. So yeah, so it's been a lot of changes. So Azaven is used a lot. We have seen definitely improvement in patients who have been on this combination compared to azacitidine alone. This regimen does have some common side effects. Cytopenias are there, they can have GI problems and other issues. But we all are using this very much, and I think this has really been a very good thing that has happened to us in India. Now, when we use azacitidine and venetoclax, do you use azacitidine first and add venetoclax later, or do you start both agents together? How's your practice? This is, we're all colleagues and we all may do things differently, so there's no right answer or wrong answer. Just want to know how you do it.
So we prefer to use both together actually, as far as feasible and
that is recommended also.
So that's the preference most often than not. Certain scenarios, in certain patient situations, we end up with first drug being AZA and gradually add when subsequently, but most of them are started together.
Perfect. So the reason for that is also because they are synergistic. So both of these, so we know that there are many anti-apoptotic genes that are there in AML patients, and when we use venetoclax and we use AZA, you're able to subdue many of these genes together, and if not, then you could end up with a venetoclax resistance kind of a situation. So it's preferable to use them together, but we've also had occasional situations where we could not give them together and we sequence them, but as much as possible they should be used together. So we know that tumor lysis is a real problem when we see these patients, and in AML in particular the tumor lysis can occur at a lower cutoff. So Dr. Pavan, what do you do and when do you start the medicines, and how do you manage the counts in somebody who has a high count with AML?
Most of the time we usually start both the drugs together. Only thing is that there are some patients who are presenting with very high count. If they are presenting with the unknown diagnosis, so obviously we'll be doing something to bring down the white cell count by giving hydroxyurea or maybe other cytoreductive agents like cytarabine also. So by the time we get the diagnosis, already in most cases we see that the TLC already start to drop. And most of the cases we see when we just start the therapy by that time in almost all cases we used to bring down the TLC to relatively decent number.
So sometimes just hydration works, and then
Yes,
you can always add hydroxyurea. If you're adding hydroxyurea, then you also have to be careful of the platelets, but absolutely. And then we all are aware of the escalating doses that we give, and most of us are using it along with an azole, so we're actually using lower doses, but then in that also we do escalating doses. So once you start venetoclax and HMA, clinically, what are the challenges that you've come across during the first 2 to 3 weeks? And how do you deal with these challenges in your practice?
So ma'am, initial challenges are obviously TLS is there, so we usually keep monitoring on that, and then the patient usually becomes neutropenic, and sometimes they have underlying infection also that. So in what our policy is that we used to do CT scan for every patient who is coming with a diagnosis of leukemia, and just to rule out any fungal infection in the lungs, and if it is there, we usually put on antifungal agents and tumor lysis prophylaxis. And cytopenias also, so we usually prefer giving venetoclax. As of now, we are giving only for 14 days in the initial induction. We are not giving more than that, because right now also I am struggling with a young patient whom we have started azaven, and he's 32 days, still the blood counts have not recovered.
Okay. So, so I think everybody here, even though we're all hematologists, we're also very good at infectious disease, and managing patients with bacterial or fungal infections is very common. There are dose modifications when we're using concomitant antifungals, and again, everyone is aware, it depends what agents you're using. If it's a CYP3A moderate or strong inhibitor, you need to make sure you reduce the doses so that you don't get too much cytopenia, but you will get cytopenia. So earlier, when we had intensive chemotherapy for everybody, one of the things I always teach my residents is that without myelosuppression, you can't have cure of leukemia. So myelosuppression is something that will be seen in patients who have even AZA and VEN. And so if you had a situation where you have this elderly gentleman, you've given him aza-ven, he's not had any tumor lysis, you've given ven along with some posaconazole, and now he's got grade 4 neutropenia. There's no fever though. So what would you do at this patient? You're just on day 9. Would you continue day 14 as you are doing in your practice? Would you try to push for 21 days? Would you stop? You know, what would you do?
Ma'am, so if there is no fever, I would continue at the same dose and push on till at least 14 days, if not beyond. But if patient is not developing any infection or fever till that time, so an attempt is made. In a very few patients, we've been able to reach 21 days, but most often they develop febrile neutropenia and serious infections, and one has to stop most often than not.
So earlier when we started using aza-ven, we used to push for 28 days, and that used to be really, really tough. Now what we are doing at our center is we're trying our best to get to 21 days. I will not say each and every patient gets to 21 days, but in some younger patients, some fitter patients, we've been able to do that. Cytopenia is going to be there. The problem is that often we don't have enough SDP support, so that's a bit of an issue, but we are definitely trying to do it. If we also do a bone marrow around day 14, and if there is no blast, then we are using GCSF. So that's something that we are doing because we really want to try to get in as much therapy as we can, because that is what the guidelines suggest, and we try to follow the guidelines as much as we can. So it's very important, as per the Viale study, to give the treatment, because patients who were able to get at least this 21 days of treatment, they had a good result. So this is basically from the trial itself. So patients will have cytopenias. They will, and this was not really related to the dose. So, and as these patients would get subsequent cycles, the cytopenias obviously improve because the bone marrow is getting better. And this is just to show the neutrophil recovery in patients over time improves. And though a lot of neutropenia and fever was there, in the study that didn't lead to too much early mortality or death, but of course this is Western data. So in India, of course, you all have to do what is best for your patients, and we do know that we have a lot of multi-drug resistant infections and other things. So you have to keep the safety of your patient intact, but again, try to push for as much as you can. Now, so I'm happy that you're giving at least 14 days. There was a study where they looked at 7 days of venetoclax versus the standard. And this was a large French study that was presented at ASH. And in this, they actually found that, that this was an inferior result when they used only 7 days. So 7 days is definitely a no-no. Whether 14 days, 21 days or others is there, we're not absolutely sure, but 7 days is not a no. And there's other studies. So that was a French study, and here we have several other studies. We even have a study from India. So if you look at the top right corner, there's a study from Bhubaneswar, where again, the other thing that they found was when you only gave 7 days, the neutropenia was also not less. So this reminds me of when earlier when we used to use 7 and 3, some of my colleagues would say for like sick patients, they'll say, okay, let's use 5 and 2. But again, the cytopenia would be the same and the chance of going into remission would be less. So 7 days doesn't reduce the cytopenia and 7 days gives you a worse outcome. So 7 days is definitely not something that we should go with. 14 days, 21 days, good enough. And how do you manage the cytopenias? Obviously, you're using good anti-infectives. You can, if you're using an azole because now you have an infection, you will have to then again modify Azaven, especially even the first cycle outpatient. We don't do that. So what is your practice?
Ma'am, absolutely in patients. First cycle, full cycle,
okay,
inpatient.
Good. So, because I was wondering if I'm doing something wrong, because a lot of people were actually saying that they have to admit the patient if they try to do more Ven, and so they do it as an outpatient. So that was fairly new to me.
I did treat one elderly lady with oral Aza and Ven. To begin with, suggested a 14-day course, but then she did manage outpatient therapy with requiring very few admissions, but these are anecdotal. I mean, mostly we try and keep them in the hospital.
Okay. So the recommendations are not to hold venetoclax dosing until you achieve remission. So if you do a day 14 marrow and you are in remission and you are having an infection, I think it's perfectly fine to hold the Ven after that. If you're not in remission and you don't have an infection, then I would go on. So, and if you're not in remission and you have an infection, then I guess it's a gray area and you have to decide what to do. So we know that patients will require transfusion support, but that they require even with intensive therapy, and now the bone marrow. So when do you do a bone marrow? Do you do it at day 14? Do you do it at day 21 or 28? How do you decide?
Usually 28 days.
Ma'am, actually, so first thing is that in my opinion, I think from day 1 itself, we have to decide the venetoclax dose. And as per institution and as per physician choice, he or she has to decide from day 1 itself how long the venetoclax has to be given, depending on the age of the patient. Because then only we can do some standardization, and based on that, we can decide about the duration of venetoclax and the dose also per day, with azoles or without azoles. And bone marrow, whether to do it or day 14, 21 or 28, I don't know. If day 14 marrow, what we are going, so basically whatever we are doing, we have to be selective in self, means we have to decide what we are going to do after the result of that bone marrow. Like I'll tell you, I usually don't prefer doing, for AML, when we are using Aza-Ven as induction, we do it after the completion of at least day 28. If the blood count recovers, it's fine. If it doesn't recover, then also we do day 28 marrow. Like I give you this example, this young boy, we are giving Aza-Ven. Day 28, we did marrow and it's completely empty marrow. Blood counts are still low. We have given almost 20 units of blood, RBCs, and every day RDPs and SDPs. So in my opinion, from day 1 itself, we have to decide how long to give.
Agreed. So it should be an institutional policy, and we have seen patients where their bone marrow cellularity is less than 5%, so they've actually become almost aplastic. So those are patients, then you have to really wait for those people. Hi, Dr. Bhargav.
I remember. I think
Please join, please join.
we can say, again, people will say, so I think it's based on the mutation burden and the mutation status, that how long you want to give a venetoclax. There's a very beautiful paper this time published in ASH, and we are looking at our own data saying that if you have an NPM1 and you still go ahead and give the azacitidine and venetoclax, 14 days is sufficient enough. While in a TP53, you need to give at least for 21 to 28 days. From a YLA study, there's a subset study which talks about, based on the mutation type, you can actually decide how long to give. It is not needed that every single thing which will take for 28 days. So Aza, when gilteritinib, 2 papers, seminal papers talking about only 14 days, doing a bone marrow, if the bone marrow is empty, you start GCSF. If the bone marrow on day 14, with Aza, when gilteritinib is not negative, you continue giving venetoclax and gilteritinib for 21 days and wait for the recovery. Otherwise, 21 days is the consensus where people tends to see whether the marrow is empty or not. If the marrow is empty on 21, be liberal in giving the GCSF, because with this triplet combination or with the doublet, the median time can actually be 35 to 40 days for the recovery to happen. And in TP53, it can also be a prolonged idea which can happen. Absolutely. And in TP53, also based on the allelic burden, whether it's monoallelic or biallelic or the VAF and the type of a mutation or the hotspots, whether it's R127 and other mutations, you can actually tailor-made your azacitidine to decide whether it is going to do that or not. So we just have found out there are 2 mutations where whatever you do, you stand upside down, you get 28 days of venetoclax, they are not going to respond. But the sample size is like 10 or 15, so that's why you cannot say that conclusively. But India stands at such a place that if you just combine your retrospective data and see and have the NGS data, just simple NGS data and duration of venetoclax, a beautiful curves can come up that which mutation and which type of mutation has actually helped you. So I think it's all based on the mutation status and the type of mutation which helps.
Thank you, that was really nice.
So it depends upon the TP53,
yes,
what is the VAF,
TP53
what is monoallelic, biallelic, what is the type of mutation of TP53. TP53 has got at least 18 mutations which can be seen through the NGS, which can help you to decide whether to give it that or not. So it's a very imperative now for the doctors just not to see as TP53, but a constellation of TP53.
Agreed, because we've had some patients with very good response, and you're right, there is some where they don't. So again, but this is the best therapy we have. So I think the consensus so far is 7 no, 14 to 21 is the ideal. And if we can have mutations and other information to guide us, that's there. But many times it's not just the mutation, could be infection. Yeah, you had a question, comment?
About the day 14 marrow. Generally in patients who are having recurrent fever, they have febrile neutropenia, where, I'm not very keen on giving for 21 days. I want to probably stop treatment earlier. I would do a day 14 marrow.
That's what we do.
And if the blasts are not there on the day 14 marrow, and if they are having febrile neutropenia and borderline sick patients, I would probably hold the venetoclax from day 14 itself. But if the patient is otherwise well and...
Then 28.
Then I would, not 28, 21 days, and from day 21...
No, the bone marrow on day 28.
Bone marrow on day 28, yeah. I would give venetoclax for 21 days, and then, as Dr. Bhargav said, I think you should be liberal about giving GCSF. And day 28 marrow, definitely I would do, because I would want to know whether somebody has achieved a remission or not.
So the reason we were bringing this discussion was that in a few other meetings I went, people were like, oh, as soon as there's cytopenia, you stop. So I think that should not be the thing, because we are treating leukemia, and we are used to myelosuppression. So that's why I'm glad that in this audience we don't need to do this, but I think maybe there are other audiences where people are worried about cytopenia. But as I said, without myelosuppression, you're not going, except for maybe when you're using IVO, that's a little bit different, but otherwise you will see. So now the other thing to remember is that in intensive chemo ineligible AML patients, when you're using Aza-Ven, particularly in geriatric patients, is your goal always remission?
So, no ma'am, the frailty assessment and comprehensive geriatric assessment is very paramount here. They are very labile and fragile patients. They succumb to the therapy rather when we are trying to achieve a cure. So it is better to give them quality of life and dose adjustment to what is tolerable and what cytopenias are manageable. So that is the goal, especially in the geriatric population.
And we have had patients where when you do a marrow, they actually do have blasts, but their transfusions have reduced, they're staying at home, they're doing a lot of things. So again, it depends on why you're using the azaven. Sometimes we use it for a few cycles because we have a young patient who may be having pneumonia and we don't want to give him intensive chemotherapy. But ultimately, if it is a patient who is elderly, the quality of life is really there. Though some patients will go into remission, but we do know that majority of patients don't. So about 30% or so will go into remission. The rest may still have some low percentage of blasts, but they kind of do well. The subsequent cycles, some patients may further after the third, fourth, fifth cycle, they may have a better response. So that is there. How much time do we have left? I don't see time. Okay, so we've got very few minutes left. So if you have, now what about the subsequent cycle? So I think we'll jump to the subsequent cycle. So initial patients, we had a discussion. What happens in the subsequent cycles when you have cytopenias? What's your practice in the subsequent cycle? So you have a patient, bone marrow is good, less than 5% blasts, but now in the second or third cycle, he's been having cytopenias.
So aim is again 14 to 21 days, cytopenias to be managed accordingly, but in case of febrile neutropenia or sepsis or a large organ related infection, then we need to stop earlier. Otherwise the ven goes on at least for 14 and try up to 21 days if feasible.
Okay, so basically I think we covered most of the issues. So if the patient has cytopenia subsequently, you must make sure, because again, our goal is quality of life, and if the patient's going to get grade 4 neutropenia and end up in the hospital with infections, that's not great. So you can use GCSF and you can modify the doses of venetoclax if needed. But again, periodically check the marrow to make sure that the cytopenias are not a herald of the relapse. But if it's just cytopenias, then you can continue to do well. So the median survival is about 4 or 5 years. Patients are tending to do well. As I said, my longest is 6 years, but on the whole, I do find that the majority of patients after about 3-4 years, they tend to relapse. That's of course a big problem once patients who are elderly, fragile and frail and have AZA and VEN, and now they have relapsed. And so how do you manage those kinds of patients? What do you do for them when you have somebody who fails AZA and VEN?
Not many options left though. So try decitabine, try a single agent, azacitidine, whatever, or sometimes
have you used cladribine and low dose Arac?
Yeah, low dose Arac. You have to keep trying something, whatever patient tolerates in the acceptable doses. So that goes on.
When obviously the NGS may be repeated, and if you have any targeted mutation
Very
coming
true.
up, that
Absolutely.
also can be added.
Most important to do that.
Ma'am,
Good
one more
point.
thing, during the maintenance phase, one thing that can also be done is if the patient is having prolonged cytopenia and disease in remission, so we can delay a few days, wait for the recovery, and maybe if the cytopenia is still persistent, we can completely omit VEN and continue with AZA.
So it's really a balancing act, and you do need to make sure that you don't give too little therapy, because if you delay for several months, you may end up with a relapse because you've done that. So yeah, so you do need to make sure that you keep them on a tight leash. And there is now some data on some patients where you could, stop the AZA and VEN. So there are a few articles where they're talking about it. But again, these patients that you stop, you will have to do MRD. You'll have to really monitor them properly. You'll have to know that, and it probably wouldn't just be a flow MRD. You'd have to look at their mutations and make sure that that's negative. But who knows, there may be some patients that would be able to have a time-bound therapy for this as well. So with that, we have ending. Any questions, comments from the audience? Okay.
Can I ask a question? If Dr. Chirag sir, you said that when broken into pieces, so I think it's a film coated tablet. It is not suggested to be broken, though availability is always an issue, yes. So do you prefer to give them kind of an alternate day if you have to reduce dose, or would you still prefer to break them? So we go either way sometimes. What do you see your?
No, I would give continuous rather than based on the mechanism. I think we would want a continuous inhibition. So I would give continuous rather than alternate day. But breaking, I know what it says, but it worked very well. And because in CLL, it was a single agent. So we knew that there is no other treatment. So whatever it says.
Well, now we're going to have 2 or 3 generic also coming
now,
in.
And now 20 milligram is also available. But at that
and now
time,
the 20 milligram is available, right? Earlier
available.
it wasn't.
Yeah.
So I think we have many options now.
So I have one more point for the house or the experts, that adding with the, all of us are giving it with the azoles, POSA versus voriconazole. So a paper last year, that is How I Treat series from the blood, it suggested a 50 milligram of venetoclax rather than go for longer duration with a lower dose than interrupt the dosing. So what is your opinion on going on for 50 milligram for 3 weeks, 4 weeks, or 100 milligram for 14 days?
We actually prefer the lower dose.
50 milligram.
Yeah, that's what we are doing, but again, everybody's different.
One thing we did in almost 30-40 patients, looking at the posaconazole level, which time it reaches. So we have to remember the posaconazole takes at least 4 to 5 days to reach to the level where it can modulate the venetoclax dosing. So when you start initially, for first, you say 14 days we are going to give by, the first 5 days are like either way around is of 100 milligram, it's no dose. 50 milligram, 70 milligram, 100 milligram, we can debate on the doses, but that 100 milligram is just 100 milligram, it's not 400 milligram.
So that's if you're starting venetoclax on day 1. Many times we start on posaconazole while we're kind of arranging things, and so then you can do that.
Second paper which talks about is that venetoclax always has to be given with azacitidine because the cell kill is at the majority of time.
That together, we discussed. Yes. We said you must give it together.
So rather than giving on the day 8, and that's why the results were, response rates were not so great.
Absolutely.
Now with this, either if you have to go posaconazole way, you have to give IV posaconazole to maintain the level on the first 2 days, and then, or otherwise you go on to 400 milligram for first couple of days and change over to.
Or start milligram. POSA before 5 days prior.
Yeah. But I need to know that I'm going to develop leukemia 5 days prior.
Okay, lovely. Thank you so much. Big hand of applause for my panelists. Thank you.
I think the most important thing, ma'am, with the generic is because we do a lot of OPDs in tier 2 cities in Patna, Raipur, Bhilai, and so on and so forth. I think without a 7+3, as a when backbone will help them to save money from the Ayushman card, and they will be able to get benefits of that. So I think that's what we spoke about, the health economic benefits on using. Yes, ma'am. So health economic benefits of using as a when versus 7+3 in an upfront setting in a young patient.
Thanks a lot to the moderator and panelist. Moving forward, the session sponsored by Zydus. For this, I would like to invite Dr. Rahul Bhargav, Director and Head Department Hematology, Fortis Memorial Research Institute, Gurugram, for the talk on defining CMV prevention in high-risk cases. Over to you, sir.
Thank you again, Nitin, for giving us this opportunity. I think the most important thing all of us has to remember, and the biggest dreading thing was during the haplotransplants or during the MUD with ATG or with the GVHD was the CMV. So a vicious cycle. Why I'm trying to tell you narrate the stories of the past was, you do a haplotransplant is a learning curve because we are almost at 70% of 1 year survival with haplotransplants. If you see that how that journey has begun, is that you do a haplotransplant, CMV gets reactivated, you give ganciclovir, the count goes down, patient gets admitted, you give blood platelet, and one fine day you say, oh, poor graft function, graft does not come up, so you have to do a second transplant. So this was a routine thing when you're giving ganciclovir. Then we said, okay, let's give cidofovir, and sorry to suggest, but cidofovir was a big letdown. I mean, We would have used in almost 90 patients, and it just didn't work. It just didn't work. And when say the cidofovir in BK virus does not work, please make sure, please remember that if you have a hemorrhagic cystitis because of the BK virus and you are giving cidofovir, is just you are spending 50,000 every week. There is no utility. We have just shown that the paper is gone for the statistics. It does not work. The only thing which works is probably God or our embolization, which we have mastered over past 10 patients. You embolize the artery, hematuria settles, patient becomes better. 10 out of 10 people doing well with HC. 200 days of letermovir cytomegalovirus infection after hematopoietic transplant is a major problem. We know the body's immunity is at fault. We also do know that with daratumumab, there's an 8% incidence of reactivation of CMV post-transplant. Again, our own data of people who have gone to daratumumab to develop on CMV colitis. And teclistamab and telgitamab, we are prospectively capturing the data of CMV reactivation at every step to see whether the reactivation takes place. Another thing is we have to see when people start doing more and more sickle cell transplant, in the African ethnicity, there's a larger likelihood of getting the CMV reactivation than the Arab and then the Indian subset. I think that's where the things became much more beneficial with the advent of letermovir, which you used to get from outside, and now it has started coming. So anywhere if you can get CMV disease, always the biopsy has to go through the biopsies and you have to see through. Early CMV reactivation reduce overall survival from allogeneic transplant. There's no rocket science. Everybody knows that and everybody has gone through this. August audiences does not need the introduction for this. Early reactivation is associated with increased non-relapse mortality, reduced overall survival following allogeneic transplant. Sibling transplant was never a problem because we were all IgG positive and not IgM negative. But MUD, where you start using more ATG, the more you start alemtuzumab. I don't know how many people use alemtuzumab during the conditioning. As Nitin is from UK, their King's College protocol was all alemtuzumab, nothing ATG, everything was alemtuzumab. We started using more alemtuzumab and CMV just jumps up on day 14. I mean, you see crazy numbers going up to 1 lakh and 2 lakh. Cytomegalovirus infection, considering a 99% seroreactivity rates, TMS CMV reactivation is 43.8. Ames data is 9.56, CMC Valor is 38.8, and probably similarly is our own data sitting somewhere in these slides which will come by. So evaluation of infection complication, retrospective data of 381 patients, 1058 infection episodes. Median time to first infection was 13 days for bacteria, 2 days for viral, and 20 days for fungal infection. 35% viral infections, of which 48% was CMV. CMV is a problem. It's not that it is not there. So similarly, Dr. Neha has published this data from our set of 102 patients. Majority underwent a matched sibling transplants. In the pediatric groups, these were the pre-transplant positivity rates were there. And the CMV reactivation version was observed in 77.6 patients, and the median ganciclovir was followed by valganciclovir. Cidofovir was not much of a use at that moment of time. Letermovir inhibits the CMV DNA terminus complex, which is required for viral DNA processing and packaging, and we have still not seen any resistance to letermovir till now. We do when people do have a breakthrough, because you do get a breakthrough in a pediatric subset. Yes, when you are on tons of antibiotics and you get on steroid on treatment for GVHD, you do get letermovir breakthroughs, but that does not mean that it's resistant. It's just the disease biology. And one more thing, EBV escape has been found to be more on letermovir, as we have seen in a couple of patients of ourselves. Letermovir is highly specific to CMV, is about 1,000 times more potent than ganciclovir, a bad drug causing cytopenias. Ganciclovir does not hold true. I don't know how many people tends to use valganciclovir and ganciclovir, just continues to have cytopenias. CMV DNA terminus complex inhibitor indicated for prophylaxis of CMV infection in adult and pediatric 6 months of age weighing at least 6 kg or who are CMV is seropositive. Is in an adult pediatric patients 12 years of age older weighing at least 40 kgs or kidney transplant recipients. In organ transplants, it was when to start prophylaxis, start as early as 0 to 7 days. Fewer bleeps with letermovir started very soon. At our center, we tend to use in haploid on day 8. We have not seen any engraftment delays because of that. Low risk to miss early reactivations at this present moment of time. Letermovir prophylaxis for CMV in hematopoietic stem cell transplant phase 3 data, which was letermovir 480, which tends to change to 240 because of the cyclosporin versus the placebo. 20% 67 centers in 20 countries were utilized, and if you can see, the prophylaxis did lead to less of CMV reactivation than the placebo, 41 versus 6.8, and there was a crossover thereafter. So letermovir prophylaxis does lead to significant decrease in significant CMV infections, helps you to engraft even if it goes up to 45 to 90 days, because people tend to give to 90 days, more to 120 days. There's a later engraftment also because of the reconstitutions. You can continue to check on your NK cells and other T cells to see the immune reconstitution and decide to stop, but there's no such data. We tend to go up to 60 days because of the cost, and we have seen far few and less complications beyond day 16 haplotransplants and mud transplants. At 24 weeks, transplantation clinically significant infection rates were much, much lesser in letermovir versus placebo. Time to event to analysis of clinically in the primary efficacy group, rate of clinically significant among letermovir recipient was 18.9 as compared to 44.3. So throughout the Kaplan-Meier curves, it will continue to show that you give placebo versus letermovir has got better prophylaxis strategy to lead to lesser CMV reactivation as well as the CMV infections, which was a dreaded complication utilizing ganciclovir. And in a forest plot analysis across all groups, major was antithymocyte globulin and immunosuppression weak from transplant. Antithymocyte globulin was the biggest supporter in which the letermovir was found to be useful. Safety data, no myelosuppression, no nephrotoxicity. The conclusion was that it is effective in preventing clinically significant CMV infection, not associated with higher myelotoxic or nephrotoxic events. Letermovir infections from cytomegalovirus infection in allogenic stem cell transplant retrospective analysis from our low middle income group countries. This is where it comes from our own data. The CMV reactivation data showed occurrence in 6 patients, 20.7 overall, 4 in the bioequivalent group and the 2 in the innovator group. So when we didn't had the letermovir from the country, we did use the originator one, and we compared our data with the bio innovator with the generic version. There was an equivalence between the innovator group and our group. So saying that Indian generic version of letermovir does hold its value, it is as good as or not inferior to the innovator. So you can see the group can be seen, graft-versus-host disease, BK virus, and letermovir induced discontinuation rates were not there. So nobody discontinued letermovir because of the intolerance. So that is not a problem at this present moment of time. And if you see the curve, the Kaplan-Meier curve survivor comparing time to CMV breakthrough between innovator and the bioequivalent group in adult allogenic transplant, you can see the letermovir group and the bioequivalent group is blue, which is almost same between the two groups, and not major difference between has been found. This is the paper, letermovir prophylaxis for CMV in adult allogenic transplant, which has been published. Extending the duration of letermovir prophylaxis. I'm so sorry. I think extending the duration to 200 days, whether it can be beneficial for all of us is known. We know if you give a drug, it will be great. But what about the cost-effective benefit? If your reconstitution is good, I'm so sorry. If your reconstitution has taken place, if you're not having GVHD, if you're not on steroids, you're not on Jakavi, that is the time point you can actually stop. But the data is that you continue giving it for the longest time, you tend to have a benefit. And that's what the data shows. That if you continue to have high risk versus low risk for CMV reactivation, people tend to do more of alpha beta depletion transplants and so on and so forth. HLA one locus mismatch because you're going to use a lot of ATG, haplotransplants, umbilical cord transplants, which we don't do. Ex vivo transplant, ex vivo T cell depleted using alemtuzumab or GVHD, actually you tend to use more. You can extend the prophylaxis, but can we use the immune reconstitution in this condition? to see whether your NK cells and the other rest of the T cells have come by so as to prevent you from CMV infection? The answer to that is yes, this is an ongoing thing, but the numbers are so small at our level because we see a lot of less of GVHD because of front-loading transplants which we do use. We use a lot of ATG at 2.5 milligram versus a PTCY, and that's why we see cost-benefit ratio that 2.5 milligram ATG is good enough in preventing the GVHD. So we do see less of acute GVHD, more of chronic GVHD at present. So ongoing data, letomavir, total given 94 patients so far. Extended 2 days, 170 days median, 3 patients, 2 with concomitant GVHD and 1 with MUD. Immune monitoring guided duration of prophylaxis, we have started. Last 10 patients, we are seeing that. Secondary prophylaxis, breakthrough infections, total 12, 10 viremia at a median duration of 40 days. CMV colitis is 2 patients, no major side effects. This is our own data of what we are collecting in a prospective manner. Efficacy endpoints are, is the breakthrough, how much breakthrough can happen, and even if the breakthrough happens, is it a CMV disease which is happening at that present moment of time. Cumulative rates of clinically significant CMV infection in primary efficacy, extending the duration 200 days beyond following transplant is efficacious and safe in reducing the incidence of late clinically significant CMV infection patients at higher risk. Secondary prophylaxis, CMV reactivations day 0, you can start and you can see through that the CMV viral copy numbers continues to remain low. So secondary prophylaxis also plays a huge role in this. Letomavir for secondary prophylaxis of CMV infections after allogenic results from a French compassionate program where people will be given ganciclovir, valganciclovir, foscarnet, cidofovir and other. And once you bring down the copy numbers to negative, actually you can use letomavir prophylaxis in these strategies as well. Only 4 patients of 80 developed a CMV breakthrough infection. This is very, very peculiar in sibling transplants or a match-unrelated or a haplotransplant for sickle cell, where invariably you land up giving foscarnet on day 15, day 16. As soon as they engraft, they develop a CMV, people from African origin. Please remember that if you are venturing out into sickle cell transplant, this is the major problem, need to capture that. Immune reconstitution is this is happening. This is what we do on a day-to-day basis in terms of lymphocyte, T cells, and NK cells. You can see through that, and the monocytes and the dendritic cells. What is the optimal duration of letomavir prophylaxis? The recommendations from the European says is recommended as a strategy for choice of preventing CMV or primary for seropositive allotransplants. Start as early as transplant, but no later than 28 days. Prophylaxis should continue at least 100 days. We tend to continue at only 60 days and not 100 days because of the cost, because it still costs 50,000-60,000 rupees a month. It's not not so expensive. Extended prophylaxis could consider in patient high-risk CMV and can continue to at least 200 days. For individual, prophylaxis for longer than 200 days after transplant can consider if the treating physician judgment is benefit stronger than the risk based on your immune reconstitution. In pediatric, again, between 28 days it has to be started. Prophylaxis at least 14 weeks, and extended prophylaxis could be judged based on high CMV infection. This is the pediatric transplant patient. 20 patients started on letomavir, sickle cell 12, thalassemia 5, AML, MUD 3, haplo 17 started on day 7. 7 breakthroughs, 1 organ involvement, concomitant GVHD, and 6 CMV viremia on day 16, median duration 5 sickle and 1 thalassemia. And these all 5 sickles, 4 has been of African origin and 1 of Indian origin. This is cidofovir first line therapy, which says that it is of no use. So you can actually go through that, we can send that, but this of no use. We can separate real reactivation from letomavir blips. That needs to be seen. If you have got 0 value, go up to 1800, up to 2000, 2500 copy numbers, we do not react to it. We do every weekly CMV PCRs. Turnaround time is 24 to 48, 24 to 36 hours. We tend to get quickly, and then these blips should not be considered as the breakthroughs. You have to wait for the subsequent readings to show that they are really going up. This is the blip versus the real reactivations which needs to be seen. Frequently late, early onsets, increasing viral load, less frequent, high viral load, rarely or no test positives, generally 1 or 2, but there are several in there. Pharmacokinetic profile or summary of letomavir is moderate inhibitor of CYP3-4A5 and other mutations, may induce CYP2B6, CYP2619 and CYP2C9. Why? Because you tend to use a lot of posaconazole and enzyme inducers. Cyclosporin inhibits several transporters of this, and you can see through that. We also do very differently few things. We get a whole genome for everybody who undergoes a bone marrow transplant. So we have got a pharmacogenomics on hand. We know which CYP mutations they are carrying in so as to tailor-made their therapies according to that. And for us, the whole genome is actually costing 22,000 rupees with a turnaround time of 14 days. So pharmacogenomics actually is playing a huge role in our whole genome through which we get on a day-to-day basis. Dosing consideration, litomobir tablet 480, it can reduce to 240 milligrams when taken concomitantly. Pediatric doses is still written there. Our experience on CTLs, we have given for 3 patients, pediatric 2 sickle 1 thalassemia because they had the money. Adult people do not have the money for CTLs by the time they do a transplant. Phosphonate therapy was already given, 2 cleared viremia and colitis, 1 succumbed to that. 1 CTL patient for adult AML mud, but patient had a refractory septic shock. He had a bad MLL mutation who did a transplant, went into CR, mutation on NGS negative, day 120, no GVHD, gave DLI, developed a grade 4 GVHD, and by the time you could handle grade 4 GVHDs, he developed a relapse. So we were able to take care of grade 4 GVHDs, and how we do that is on day 3, not on day 3, but the 3rd dose we tend to add Jakavi, and through Jakavi we tend to start reducing the steroids so as nobody should succumb to because of the infection. Jakavi do not lead to the deaths, it's a steroid which leads to more deaths. And luckily past 15 grade 4 GVHDs all have come back, so we are trying to write that up. So International Immunocompromised Society, we have got Dr. Neha, who is doing a wonderful job for us, so we do not remember any of these things. I courtesy to Dr. Neha, who has given and shared their slides. We have got ID specialists who takes care of all these things, but we have got nothing to do in this. And she is the country ambassador for all of us and having a worldwide tie-ups with both European societies and the American societies for looking at the CMV. So she is looking actively into a CMV. But the pharmacogenomics, along with Dr. Neha, has able to make a lot of difference, and probably in the recent past or later in the past, we have not lost any patient to CMV. Thank you everybody for patient hearing. Thank you.
So we are also starting to use letermovir. The only thing is that recently we've had 2 patients who had other infections, and maybe it's just that we're picking them up. We had one patient who got readmitted with confusion, and his LP was done and he had HSV6, and another patient had EBV. So I'm not sure.
EBV, you are absolutely right. So we have our own data of 6 patients who had a breakthrough on letermovir and EBV. So we tend to monitor the EBV very, very stringently now. In a mud setting, we just written a LinkedIn post a couple of days back talking about the EBV reactivation. We gave 1 dose of rituximab and EBV cleared up. So there was no lymphoma, it just appeared the EBV proliferation going up to 3 crore of copy numbers. But yes, so Dr. Neha just sent a report today that there were 7 patients who had got EBV breakthrough on CMV. There's a worldwide data also talking about patient on letermovir developing an EBV. So if your patient is on letermovir, please get in habit of getting an EBV done every 15 days just to collect the data in the future of what needs to be done. So the whole idea is that we need to standardize whole thing and collect our own data. There's a lot of heterogeneity in what we see and the rest of the world sees. Thank you.
Thank you, sir, for the excellent talk. And no, sir. So moving forward for the next session on multiple myeloma, I would like to invite the chairpersons, Dr. Isha Kaul, Director Hemato-Oncology and Bone Marrow Transplant at Medanta, Gurugram, and Dr. Rahul Bhargav, Director and Head Department Hematology, Fortis Memorial Research Institute, Gurugram. Just ask. Ask, ma'am. Hi, ma'am. So, Dr. Ganesh will be joining.
So we'll kick off the myeloma session from here. I've been told that Dr. Ganesh is going to join us virtually, and I think he's already joined. Oh, there's a lag also. Hi, Dr. Ganesh. I think everybody here knows him, Dr. Ganesh Jeshetwar. He is a consultant hematologist at Yashoda Hospital, Hyderabad. We can't wait to hear you speak on role of quadruplets in frontline myeloma and who should receive that. There we have him. Over to you. Over to you. I am more audible.
I'm sharing my slide deck. I hope my slides are visible.
Yes, they are.
Thank you so much. So, good afternoon, everyone. It is an honor and privilege to kickstart the myeloma session during Hemonet 2026. I'm really grateful to Dr. Nitin and the team for this wonderful opportunity. Of course, from actual to virtual, people say virtual to actual after COVID, and I'm here actual to virtual, missing the opportunity, and very appropriate to the topic. I had to skip the meeting, missing the opportunity to meet all the friends and mentors beyond academics. Thanks for again myeloma emergency for one of my friend's mother. So myeloma kidney, we all know, is an acute emergency. So when we think of the myeloma frontline therapy, the literature is very exciting, and I'm going to base my talk from all these evolving, burning issues in our practice, and most of it are very appropriately and robustly answered by the literature we have over the last just 4 or 5 years. So that as the generate era ended, yes, for most who can afford in India, both for transplant eligible and ineligible, who are deemed to be not so frail to tolerate the quadruplet, but those who cannot tolerate the quadruplet, at least triplet with monoclonal anti-CD38 antibody-based combination. So I'll also touch base upon high risk, ultra high risk. Of course, the special subsets, extramedullary disease and beyond myeloma is beyond today's discussion. So coming to the myeloma therapy, when we divide the frontline therapy, the goals of our myeloma treatment are to control rapidly as possible the myeloma as well as the myeloma related complications. And over the decades, it has been shown that the progression-free survival at first frontline therapy is the surrogate marker of overall survival of the myeloma subset. So the aim, the 2026 aim in frontline therapy for myeloma is to obtain the deepest possible response with whatever best possible options we have. And we have to achieve this with minimum short-term as well as long-term toxicity. As we all know, myeloma is an incurable malignancy, and they are on the frontline maintenance till the next disease progression. So also as of now, 2026, particularly for our patients from India, even today, for those who are transplant eligible, the transplant, autologous stem cell transplant consultation replaces the gold standard post achievement of deep remission with frontline, whatever options you choose for. And this is how the myeloma therapy has evolved. So there was clear-cut segregation between transplant eligible and ineligible in the beginning, as we used to prefer alkylator-based regimens in transplant ineligible and non-alkylator-based regimens for transplant eligible, because they used to be taken for male 200-based transplants. So over the years, with the advent of non-toxic, more potent anti-myeloma drugs like PI, INHs, and now anti-CD38 monoclonal antibodies, so these drugs are being used in combination, because as we all know, myeloma with all the therapy currently is incurable, and hitting the disease with all the non-cross resistant multiple mechanistic approaches is the best way to aim for the best possible and deepest and the durable remission in the frontline myeloma. So this is again the myeloma therapies with all these novel drugs. From 2000 onwards, you can see with the advent of bortezomib lenalidomide, the survival curves have started jumping up, and currently it's almost doubled over the last 2 decades. And with the evolving immunotherapy era, this is promised to the curve is going to go up steep. That is the continues to evolve even after transplant, post-conservation. So post-induction MR negativity is from 45% to 77%, right? So that is much better than those achieved with KRI. So this is again a visual abstract of this publication in Blood 2024. So the post-induction MR negativity is in intention to treat protocol is almost 1.5 times the KRT arm versus KRT arm. And the same is highlighted here on a longer follow-up. You can see the curves are separated and maintained. Now, with regard to the choice of proteasome inhibitor between bortezomib versus carfilzomib, we all know VRT versus KRT. This is the only trial like this, which is a KRT versus VRT randomized trial.
Dr. Ganesh?
In this trial, you can see the KRT and VRT are almost close to each other. There is not much of a difference, but there is a trend towards better PFS in KRT arm. So the frontline therapy transplant eligible patients, standard risk transplant eligible versus benchmark DARA, VRT, high risk, one high risk cytogenetic adenopathy who are again transplant eligible. Those patients whom you can take up for carfilzomib based on the ISA-KRT data, it has a it seems to be promising compared to bortezomib. However, the carfilzomib comes with its own logistics and toxicity issues. The ultra high risk, more than 2 high risk cytogenetic adenopathy. So our preferred first-line regimens in transplant eligible DARA VRD transplant followed by DARA plus then maintenance for high risk group. VRD is still acceptable and is preferred by majority of our patients because of logistics and financial constraints. But in this context, the previous genomic-based classification has to be taken into consideration. And transplant ineligible DARA VRD versus DARA RD. The frontline therapy transplant ineligible patients, you can see the three landmark trials, CPS, Windows, and Maya. The CPS is DARA VRD followed by DARA then maintenance. Again, you can see the MRD negativity 1.5 times normal, more 39% versus 61%, and the PFS of at 54 months, 68% versus 50%. Continuing bortezomib in these elderly transplant ineligible patient is a real challenge because of the neuropathy, cumulative neuropathy. toxicity of bortezomib, and this contains higher trial DARA, Mendex versus DARA versus Mendex, and you can see again 5-year overall survival of 66%, and the benefit is maintained even as long-term follow-up. So this is safest trial which we mentioned. Again, you can see the deeper and sustained remissions at various time points, which has translated to 54 months PFS of 68% versus 49%. So again, MRD negativity at 10 to the power minus 5 is maintained on long term. So again, Maya trial is again a landmark trial establishing DARA Mendex as a standard of care in transplant in patients who are not suitable for bortezomib as a frontline therapy addition. So even here you can see 5-year PFS 52% versus 25%, and this has translated to better overall survival 65% versus 53% at 5 years. So highest remains unmet need, you can see the lower curves, both DARA has not significantly improved the PFS of this high-risk subsets, and in this context there are novel immunotherapies like BiTEs and CAR-T are being placed upfront. The thermocol altitude 5 and altitude 6 earlier outcomes have been published in this year ASCO, and this is the landmark German Majesty 5 trial, and you can see at 2 years MRD negativity 100% with the addition of DARA as a frontline immunotherapy combination, and this has, you can see the MRD negativity by 10 to the power minus 6 at 6 months, almost 100%. So looking at this evolving literature, who should get the transplant in the future? Transplant is the question, because many trials which have shown that the outcomes are improved so much that transplant may be necessary, may not be necessary. So putting all together based on various years, the DARA, the induction, transplant, consolidation, maintenance remains the gold standard in our subset of patients. And in transplant ineligible, Maya trial, DARA RT or DARA DRG, followed by death or DARA then maintenance. So these are the conclusions for 1980s and ongoing. Stem cell transplant still remains the standard of care in our country. Of course, with the advent of these novel agents, the quadruplets and evolving immunotherapies, the MRD negative CR is now achievable, and which is sustained in newly diagnosed myeloma with a combination targeted therapies, and probably the future seems to be more exciting with the upfront incorporation of BiTEs and CAR-Ts. So this is a conclusion slide, the practical risk adapted approach. For young kids, standard risk transplant eligible, DARA VRD 4 cycle induction, early transplant, 2 cycles of DARA VRD consultation, and if feasible, monthly or at least once every 2 monthly DARA plus then maintenance till disease progression. Young kid, one highly saturated abnormality, again the standard of care remains same. Here, either valuable addition if the patient is deemed to be fit for bortezomib-based induction. Early transplant is mandatory for high-risk patients. Ultra high-risk, I mean, as of now, the standard of care remains same. DARA is accessible, urgent transplant at the earliest VGPR documentation, and compulsory doublet maintenance, and with periodic MRD tracking at least 6 to 12 months. And transplant ineligible elderly patients, DARA VRD versus DARA RD, and followed by maintenance with either R alone or DARA, then based on the genomic profile. For patients with renal impairment, DARA bortezomib dex or DARA BCD, and if renal recovery, then switching to DARA VRD and transplant after renal recovery. And for those financially cost-constrained patients, VRD, upfront transplant, and then provide maintenance and with periodic therapy. So, take home message from this presentation is quadruplet induction transplant maintenance improves outcomes across the myeloma cohort, including high-risk group. Post-transplant consolidation improves PFS as well have improved through enormous trial, and should be a standard of care in our practice. Duration of maintenance as of now is unanswered, but Dhaka had even standard of care for transplant ineligible brain and fit patients. So we are essentially getting in the era of precision hematology myeloma. Of course, there are so many things, but we have to change our approach to offer the best possible chance of success across the myeloma board. Thank you for this opportunity once again, and really looking forward to questions if time permits. Thank you so much.
Thank you so much, Dr. Ganesh, for comprehensively covering the upfront treatment. This is so silly. Upfront treatment of multiple myeloma. I shouldn't speak much. Any questions for Dr. Ganesh?
The time is up. Good for me. Thank you once again to one and all, and really dismissing all of you, and thank you for the opportunity of speaking in the
All right. I don't know if you can stay with us for the rest of the session. No. Our next speaker is Dr. Tulika Seth. Ma'am is a professor, hematology at the All India Institute of Medical Sciences, New Delhi, and she'll be speaking to us. Impact. I think we are okay now.
Target effects.
Yeah, I think we are good.
Okay.
So she's speaking to us on when outcomes meet convenience, optimizing outcomes with daratumumab. I think it's very interestingly worded topic. You can take it anywhere you want, depending on how, the questions that we have around the use of this drug. So really looking forward to your talk, ma'am.
Thank you so much. So this is basically a summary of many of the clinical trials, and some of it will be a repetition to Dr. Ganesh's talk. But I think DARA for all of us has again been a game changer, the way that venetoclax has been a game changer for us in the setting of AML. Here, DARA has been a game changer for us in the setting of multiple myeloma. So many of these clinical trials have already been alluded to by the previous speaker. So we have the Maya study where we had patients that were not eligible for transplant and got DARA-RD. We had the Alcyon, Griffin, Perseus. All of these have been kind of discussed. And then there were older trials like the Lyra, Cassiopeia, Cepheus, and Auriga again were discussed by the previous speaker. So I'll kind of just group them into patients who are newly diagnosed multiple myeloma who were transplant eligible, and those studies that were for transplant ineligible, and discuss them separately. So if we look at all the data that we have for patients who are newly diagnosed multiple myeloma in the transplant eligible study, we have several studies, of which one is the Perseus study. So in the Perseus study, the induction that they had was DARA VRD, and they compared it to the older VRD, and then they monitored these patients, and many patients were able to go on to transplant. Then they had consolidation and then maintenance. And what they found was that they looked at all the standard PFS and CR rates and MRD negativity, and the results were there that you could definitely see that DARA VRD and those patients who had DR maintenance significantly had a improved PFS, and overall MRD negativity was much more, and the CR rates were obviously more in this group of patients. So there was a 58% reduction in the risk of progression or death in patients receiving the DARA VRD, and it was a deep and durable MRD negativity, and that's already been highlighted earlier by Dr. Ganesh as well. So when you have a median progression-free survival projected to be 17 years for transplant-eligible patients receiving DARA-based therapy, that's really good because we know that this is a disease of older patients. Of course, sometimes we do have younger patients also, but usually even with transplant, 17 years progression-free survival was not something that was commonly seen in most of our patients. So this is obviously something that is practice changing. And the responses over time also were good. So patients who were able to get more cycles of VRD were able to go again into deeper responses. So many of us earlier, when we had the product, we were using it as a bridge to transplant and using fewer cycles. But here it shows that if you use it for longer cycles, you will get an even more depth of response. And the patients, the randomized study of the DARA VTD versus VTD in similar transplant eligible patients, which was the Cassiopeia study, that also similarly had very good response rates. And the responses again deepened over time, showing that this was something that was should be a longer term. And patients who were who achieved overall MRD negativity, they did very well post-transplant, and this was something that was maintained. The Auriga study was again alluded to by Dr. Ganesh, and in this they used DARA and LEN versus LEN alone as maintenance in newly diagnosed multiple myeloma patients after transplant. And the addition of DARA was again very impactful, and these patients did much better clinically in all the different subgroups of the patients that were there, whether even different high-risk groups also did well. So the overall benefit of adding DARA was much more, with a higher CR rates, and in patients who had a VGPR, the adding DARA deepened the responses so that many of these patients went into stringent CR. The benefit of DARA maintenance on MRD negative conversion translated into improved PFS. So, because somebody may feel, okay, what does it matter if you are MRD negative or not? So, it does improve the progression-free survival in these patients. So this is a study, a typical 65-year-old, he's a retired gentleman, earlier was an athlete, but now he's got several comorbidities, including prostate, he's got some asthma, he's on some inhalers, and he has back pain, and he develops the symptoms of multiple myeloma. He's got IgG kappa paraprotein present, he's got an EGFR of 91, he's got anemia, vertebral fractures, and so he's basically, and he's also got an ECOG too. So there's many treatment options that can be given to such a patient nowadays, and and most of us, I think, would choose a DARA-based regimen for him if the cost is available. Now, what about ineligible patients or patients where we need to defer the transplant in a different setting? Does DARA continue to hold its importance? Well, there are many studies in this setting as well. So the Maya study was in transplant ineligible patients, and this was an older study where patients were recruited in 2015 to 17, and so we have the results of this also. And here again, we can see that there were definitely there was an improvement in the PFS as well as in the OS. So this was important and believable. And in the long-term follow-up of these patients, again, this continued to have a good result. So with a median follow-up of even 7.5 years, the patients in the DARA RD group continued to demonstrate clinically significant survival benefit compared to patients who only got RD, and this was in the patients who were transplant ineligible. The Cepheus was a phase 3 study of DARA sub-Q VRD versus only VRD, and this was again in the transplant ineligible or the patients where transplant was deferred, and this was using the sub-Q DARA, which most of us are using. And again, this showed deep MRD responses and a higher sustained MRD negativity in this population of patients where we can't do transplant for some reason or the other. And over time, there was a 43% reduction in the risk of disease progression. So we had a overall PFS that was there, and as well as a OS. So many products can improve your PFS but may not have an OS benefit, but here the OS benefit was there. The study was done during COVID, and some cases were censored because of COVID. So what is the patient profile of patients who get DARA-based triplets or quadruplets? So there could be patients who may be going for transplant, and they may be on intensive therapy and then go for transplant. There could be patients where for some comorbidity or other reasons the transplants could be deferred, and there could be patients who are completely ineligible for transplant and will never go for a transplant. And in all of those patients, even though they were all very different patients, the benefit of DARA was there. So whether it was you're using it because you have a patient who's less fit, or whether you want to give intensive therapy and take them for transplant, in all of those scenarios, this has turned out to be quite a good product. In another case study, we have an even more older gentleman. He's 85 years old. He's again got multiple comorbidities like our patients do with ischemic heart disease, type 2 diabetes. He also had prostate cancer. He's on antiplatelet medications, anti-diabetic medications. And similarly, he again presents with the symptoms of myeloma, and here he has a worsening GFR. And he also has, when we're looking at him, he has 1q21 mutation. So this is a much older, frailer patient, and again we have many options to treat this patient. And again, you can choose what you would want to do, but I think for all of us, again, a DARA backbone therapy can be given, and since he's so frail, we would want to use a lighter regimen. So in the relapse refractory setting, again, we have multiple options, and we have many things that we can use, because this will depend on what the patient received earlier on, what his comorbidities are now, and different things like his renal function and the mutations and other things that we're dealing with. So we again have you can see if the patient was LEN sensitive, if the patient is LEN refractory, and decide on what to do, because these patients obviously with a longer life, they will be having multiple relapses, and we can choose the target that we want. In patients who have relapsed 3 or 4 lines of therapy, we are going to be having some excellent talks on the bispecifics that are available and all of us are using. And we had some discussion on CAR-T in CLL, so those options are also there. But what to do when patients have the first relapse? So I think the first relapse is again very important. So you want to see their risk stratification, you want to see the time from the relapse, and of course what therapy you gave them before. And the phase 3 Apollo study looked at patients in this scenario with the first relapse who had not previously been given DARA, and they looked at DARA plus POM-DEX versus POM-DEX in this group of patients. And again, DARA came out with excellent response rates, and these patients did very well. Now, of course, we are in the era of immunotherapy, and there's many new things that we are going to be talking about, and many of us are also using. But using DARA in the front line does offer a longer median progression-free survival. And even though we do have many options in the future, but because patients are now asking for more, as I was telling you earlier, we now have a 77-year-old gentleman who wants more therapy. Earlier, at our center being a government center, many patients in their 60s would decline further therapy after a first or second relapse, but now patients want more. So I think it's important for us to use effective agents in the front line, which might actually potentially even cure the patient if we can get up to 17 years or more. But even if it doesn't, it can delay the progression so that as the patient can survive better with each line of therapy. So this is a third case study where we have a 66-year-old female who has an IgA lambda multiple myeloma. She presents with fractures, she's got adverse cytogenetics, She's basically high risk patient who earlier did not get DARA at the front line, but was given it in the second line, where she had some partial response and progression. And then third line, she got some other agents. This is a case that I had not seen. And then she's admitted in the hospital with on a ventilator and poor cardiac function. So these are patients, obviously, that then you're going to have to see what to do. In our scenario, many such patients might even opt for palliative therapy. Some patients would opt for a bispecific if they could afford it. We don't have any clinical trials at the moment. So I think it's really, really important that the first line treatment should be really good. And if the patient has a first relapse, again, if the patient is not being given DARA, that's another scenario where we can use it. So this is a product that can be used in all lines of therapy, and has been effective, and I think has really been a game changer for us. And I think with that I will end. Thank you so much.
Thank you so much, ma'am. I'll just have one question and then we'll turn to the audience. So in light of the Majestic 3 results, now that we are using so much DARA upfront and using DARA maintenance, if a patient while on DARA maintenance or recently on DARA maintenance relapses, would you stop the DARA and put them on teclistamab, or just continue the DARA and add teclistamab and use it as a two drug combination?
So I think there is some data to suggest that even if the patient has relapsed on DARA, it might still work. So if the patient is not a very affording patient, we have continued with that and seen, because everybody can't go for the bispecifics. And we have had some patients who responded. So it's a small experience on our side. The others in the house can maybe comment.
Any comments or questions from the audience? Thank you so much. Thank you so much, ma'am. So we'll move on to our last talk of this session, which is by Dr. Pavan Kumar Singh. He's Vice Chairman, Hematology Oncology Bone Marrow Transplant at Sharda Care Health City, Greater Noida. And he'll be speaking to us on teclistamab in early relapsed refractory multiple myeloma, patient selection and real world considerations. And I think I'll ask you the same question also at the end of your talk. I think it's in fact more relevant to your talk than ma'am's. Over to you.
Okay, thank you, Dr. Isha, for chairing the session, and thanks organizers for having me here. So I'll just discuss about the real world experience, means what data is there, and then we can have many of us have used teclistamab alone and also in combination. So I think you'll get that answer to your question. So ultimately it depends on our own practice, how we are dealing with and what kind of patients, where this combination can be there. So relapsed refractory myeloma, we all know that myeloma is incurable disease, and relapses are imminent in almost every patient. Only thing is that the duration of remission, that is important, is matter to us and to the patient as well. So most of the relapse refractory myeloma, if we see with the relapse, and if the patient has received the multiple lines of therapy, so outcome depends on the lines of therapy also, as we can see in this Kaplan-Meier curve. So this is the study, the locomotion and moment pooled analysis in triple class exposed relapse refractory myeloma. So where we can see that the lower overall response rates and shorter median PFS was there, and those patients who have not been continued on these triple class exposed therapy. So we have seen in past few years that many drugs are being launched and getting approved for the myeloma therapy. And first thing is that the second and third generation of the already class of drugs, and the novel agents like monoclonal antibodies, ADCs, bispecifics, CAR T cell therapy. So these are the targets which are basically utilized for the development of these drugs, monoclonal and MABs, or bispecifics, or even CAR T cell therapy. So teclistamab, it is basically a BCMA targeted therapy. So BCMA is an antigen which is expressed specifically on the plasma cells and myeloma cells. and expression increases as the patient disease progresses. So teclistamab, basically it's a first-in-class drug, which is a T-cell redirecting bispecific antibodies, and that bind to the BCMA, and that causes the T-cell mediated lysis of the plasma cells. So it is administered. We all know that a step-up dosing schedule is there, basically to mitigate the risk of CRS and other side effects. So the standard dose, I'll just skip this. So outpatient administration, I don't know how many of us are giving teclistamab as outpatient, but still, yes, data is there, and maybe some of us may be having experience of giving it. We'll come to this in my later presentation. So it can be restarted. So when there is suppose interruption is there for because of any reason, because of infection or any other reason. So this is the standard. If more than 62 days are there, so then we have to reschedule and give the step up dosing. So it is basically administered as a personalized weight based and subcutaneous dosing schedule, and if there is a prolonged interruption is there, then we have to reschedule and give the step dose again, and the maximum after that maintenance dose is 1.5 milligram. If the remission is achieved, it is given as subcutaneous every 2 weeks. Less frequent dosing like 3 mg every 4 weeks, that is also but it is not standard. Now coming to that the data of what this teclistamab is having, so we can see here that the overall response rates of almost 63% and the VGPR rates of 59%. So and the duration of response also and PFS also is better at a median follow-up of 2.5 years, and it demonstrated deep and durable responses and manageable, almost manageable safety profile in this cohort of almost 200 patients. The post-hoc analysis in Majestic 1 study that also showed median PFS, so median overall survival, and the median duration of survival was prolonged compared to the standard of care, what was it was. And there was a sustained and clinical meaningful improvement in the health-related quality of life also. So the Majestic 1 data shows that the overall response rate 63% and the CR rates almost 56%, which is a significant improvement in these kind of patients where these patients are multiply refractory and almost exposed to multiple lines of therapy. So now result from the locomotion study, and it highlighted that the triple class exposed patient relapse refractory, there were 2.3 times more likely to reach overall response rate and a significant improvement in terms of duration of response and the PFS. The pooled analysis of locomotion and movement studies demonstrated median PFS, overall survival, median duration of response nearly 3 times, 2 times and 3 times respectively with the teclistamab as compared in the real world treatment studies also. And it demonstrated substantial efficacy benefit, and based on that the recommendation is there. Again, if we see the high risk features, means even the overall response rates of 63%, and if we see the sub analysis of this days, penta-refractory disease, high risk cytogenetics, patients having older age, bone marrow, high tumor burden, then in extramedullary disease as well, the response rate was significant in those patients who are having multiple relapse setting. Even in heavily pretreated patient prior exposure to BCMA targeted therapy, teclistamab showed promising overall response rate and median PFS. So efficacy was increased in patient with earlier. So when it was used as a patients who are using in relapse setting, if it is used early, the response rates were better. So almost 15% difference is there, that we can see that overall response close to 75% as compared to 60% in those patients where it was given after the exposure as a more than 3 lines of therapy. So Majestic 1 data shows that the high risk features even had teclistamab showed benefit in patients who are having high risk features, and heavily pretreated patient also with prior exposure to BCMA targeted therapies, there also the results were better. Now, it was the safety profile, overall adverse events, if we see, it was well tolerated, and the rate of discontinuation rates due to adverse events were low. So CRS, particularly if we see the CRF when we used in this study, when tocilizumab was used as a prophylactic, the incidence of CRS rates were significantly better. So initial this in OPTEC study also, that prophylactic tocilizumab was used to mitigate the risk of CRS in the outpatient settings. So monitoring and investigation, we all know that these are how to manage CRS, and close monitoring is very important. Now that is why step-up dosing is there, and prophylactic tocilizumab, I don't know how many of you using this or not. Management recommendation, I'll just skip. So even ICANS, if you see, this was the neurotoxic events, total events almost 14%, and ICANS events 3%, where the no changes in the rate of ICANS at even longer duration of follow-up. So monitoring, investigation, ICANS, just skip. So infections, these are quite common. Here we can see that almost more than grade 3 infections in the overall population was almost 30%. And it is quite significant. So monitoring and investigations are required. So we have to be closely monitoring for these infections. So these are the recommendations: prophylaxis, vaccination, and reduced dosing if there is any infection is there. So these are the recommendations: prophylactic PCP, CMV, or any antiviral, antifungal prophylaxis are there. So these are the screening, prophylaxis, then IgG replacement is there. So initial recommendation was there to monitor immunoglobulin levels, but nowadays even if without monitoring immunoglobulin levels, the recommendation is to give, for at least initial phase of treatment, the recommendation is to give IVIG. So hematological adverse event monitoring, and this is the recommendation in neutropenia, anemia, thrombocytopenia. We all know that how to manage hypogammaglobulinemia. Again, so nowadays monitoring is not, so based on this paper, monitoring is not recommended, and we can give IVIG prophylactically for at least initial phase of treatment. So this is the real world across Europe and US demonstrated that deeper response rates with teclistamab in relapse refractory patient, and overall response rate was more than 55%. Again, Realitech study also, this also showed that outside of clinical trial, so we can see here that the response rate was almost similar as compared to the trial data. So clinical trial population often not representative of the real world population, we all know that. So again, I'll just skip. So retrospective analysis, this is a French real world study that also conducted across the 30 centers. So here also we can see that the overall 36% of patients had received tocilizumab or dexamethasone to manage the CRS and ICANS, and the response rates here also it is almost comparable. So overall, despite these real-world analysis of teclistamab in patient with relapse refractory, it demonstrated that similar overall response rates. I'll just skip this. So outpatient, so this is a thing that outpatient administration also is possible for teclistamab, but close monitoring is there. Now the question is whether we want to give tocilizumab as prophylaxis or not. So the growing real-world experience supports that effectiveness, safety, and feasibility of teclistamab treatment in patient with triple-class exposed relapse refractory myeloma. And so finally, to summarize, and based on these real-world studies, that teclistamab is a first approved BCMA targeted therapy for triple-class exposed, and it has high and consistent efficacy, and over a longer period of follow-up, it also showed durable response rates and predictable and manageable side effect profile, and the lower rates of discontinuation. So I'll just stop here. Thank you. We can have discussion.
Thank you, Dr. Pavan. So I'll ask you the same question that I asked ma'am, that if you have a patient who's DARA exposed and relapses, in light of the results of Majestic 3, would you just add teclistamab to the the DARA that the patient is already on, or stop the DARA and keep single agent teclistamab?
So, I think if I have to choose, I will decide based on the clinical profile of the patient. If relapsing early means high risk cases, so there even I know that some people have used this even after even though approval Majestic 3 data was not out. So before that also people used to combine teclistamab with DARA. So I would suggest means in my opinion, if high risk cases, yes.
No, I have no problems with using the combination, but the combination in somebody who is clearly DARA refractory. I think because if you look at the Majestic 3 data, the number, percentage of patients there are DARA naive. So we are extrapolating those kinds of responses to patients who are now DARA exposed and DARA refractory. They are not going to get the same kind of PFS benefits as somebody who is DARA naive and now getting a combination. So I think if we start using DARA tech combination, we have to be very careful now in how we prognosticate those patients, because most of these patients currently are going to be exposed and supposedly refractory to DARA.
Yeah, it may means
the cost burden of DARA tech combination is like really something.
The only thing is you have to be sure that they're DARA refractory. Many times what happens is patients may have not been compliant, they haven't taken it for some time. But yes, if you're like truly on DARA progression, then I think there's absolutely no point anyway using DARA. So DARA, otherwise like before we had teclistamab, sometimes we would have patients who were DARA exposed, and then we didn't have much else, so we would use another combination with DARA. So there is data to show that if you've had like a gap of 6 months, and if you can actually continue. But I think you're right about the Majestic trial. If you've actually failed on good DARA and you're being compliant, then why do it? Single agent teclistamab is also very good.
The results of Majestic 3 are so dramatic that I think it can come across as being, oh, this is like the magic potion and then this is, the answer to everything. But it's not true for both the patients that we are seeing now. Any questions from the audience or any comments?
We need to see whether head-to-head comparison between DARA tech versus tech alone.
You will never get that study, na? DARA exposed patients, the company will never do that study. Why will they do that study? Even if you read Majestic 3, the fact that most of them are DARA exposed is not actually brought out that prominently in the study.
And we don't know whether the response was because of teclistamab alone or whether DARA did anything or
not. Because but the single agent tech responses are not so great. So the results were definitely much superior to single agent tech. So, but the combination works, but I think the results that we have is for predominantly a DARA naive population. So it's tricky. And have you ever seen ICANS with teclistamab?
No, we have never. Even CRS also we have not seen. We have never used, means almost whatever number, I think 5-6 patients we have given, never required tocilizumab, not even steroids also.
We saw one very late ICANS actually, 8th month of treatment ICANS. So I think even though we worry about these toxicities in the first month or second month, even later on as we are using more patients, and at that point you may not be so vigilant, or the patient may not be so vigilant, and they've gone to their hometown or whatever. So I think we have to be vigilant about late toxicities as well.
I was just adding to that we had one patient who had ICANS. This was a very elderly gentleman, multiple lines refractory. Kappa was double-digit 1,000, very high burden disease, and from the very first dose, the step-up dose, he did have ICANS, which was manageable, but again, although it's not very common.
We were very surprised because we saw it in month 8.
Very unusual.
Yeah.
So we have usually we have seen with teclistamab very late CRS. Mostly 8 weeks, 6 weeks later they develop. They don't develop immediately.
So I agree. I think real world how we are using and sort of medium to long term toxicity, especially in responders, because those are the ones who will tend to stay on. So we still have to be vigilant if somebody is having some hypotension or neurological symptoms. This patient was, in the ICU in a remote location, and they were, basically read the act that she's going to die. And she got one dose of Texa and woke up. But it was not on their radar primarily that this is going to be ICANS.
Maybe tumor burden also, that also may be having some effect.
This was in CR, stringent CR. All right. I think with that we'll conclude this part of the program. Thank you so much to the organizers. Thank you, Dr. Bhavan.
Thank you, Dr. Pavan and Dr. Isha Kaul for chairing this session. For the next session, I would like to invite Dr. Sarita Rani Jaiswal, who is a Senior Consultant and Clinical Lead of PMT and Hematology at Dharmashila Narayana Hospital, New Delhi. Welcome, ma'am.
So very good evening. So we have already had 3 sessions for myeloma. So now we will discuss just to the extensive part of relapsed refractory multiple myeloma in this era of BCMA bispecific. So for that, I'll call Dr. Tejashwini Vaid. She's a consultant medical oncologist, Medanta Hospital, Gurgaon.
Good evening, everyone. Today, I'll be presenting the data on elranatamab, which is a BCMA-directed bispecific immunotherapy for adult patients with relapsed refractory multiple myeloma. So elranatamab is indicated, currently the approved FDA indication is monotherapy for treatment of adult patients with relapsed refractory multiple myeloma who have received at least 4 prior therapies, including an IMiD, a proteasome inhibitor, an anti-CD38 antibody, and have demonstrated disease progression on their last therapy. So this is the data from the locomotion study. Now, locomotion study was a study among patients who were triple class exposed, meaning they had received an IMiD, a proteasome inhibitor, and anti-CD38 antibody. And this class of patient usually performs dismally. As we can see here, the response rates to any next therapy is only 29%. The PFS is about 4.6 months, and an overall survival of dismal 12.4 months, which makes the case for newer drugs in this area. So elranatamab, it's a BCMA bispecific, wherein one arm binds to the BCMA and the other arm binds to the BCMA on the plasma cell. The other arm binds to the CD3 on the T cell, which leads to activation of the T cell, causing pro-inflammatory cytokines to be released, resulting in the myeloma cell lysis. So the Magnetism 3 trial, which is the registration trial for elranatamab. This is an open-label, single-arm, non-randomized, multi-center phase 2 study, wherein patients 18 years and older with relapsed refractory multiple myeloma post 3 lines with a good ECOG PS, creatinine clearance of more than 30, platelet count more than 25,000, and an ANC of 1,000 and above. A very important thing to note here is that patients who received other BCMA-directed bispecific antibodies were excluded. This population was then divided into 2 cohorts. The cohort A had not received, were BCMA-directed therapy naive, whereas the cohort B was BCMA-directed therapy exposed. That means the cohort B did have patients who had received other BCMA monoclonal antibodies or BCMA CAR-Ts. They received the standard dose of the drug, 12 mg subcutaneous on day 1, 32 mg subcutaneous on day 4. Following that, 76 mg subcutaneous on day 8 and weekly, up till week 24, and after week 24, we make it once in 2 weeks. And the primary endpoint was overall response rate. So very good overall response rates in a population that otherwise responds barely in 30%. 61% overall response rates with a CR plus stringent CR of 37.4%. Of the patients who did achieve a CR, almost 90% achieved MRD negativity, which is quite impressive. The duration of response, the overall duration of response among patients who achieved some amount of response, 66.9% continued to maintain that response at 2 years. And among patients who achieved a CR, 87.9% would be maintaining that response at 2 years. And the median duration of response was not reached. Progression-free survival, overall progression-free survival was 17.2 months. And among patients who achieved a CR, very good statistics of maintaining a CR at 2 years of about 90.6%. Again, these responses are durable in many patients. The probability of maintaining a response at 30% was at 30 months was 61% overall and 79.1% in patients who achieved a CR. The median time to response was a very quick 1.2 months, and the median time to CR or better was 6.5 months. And as we saw in the previous slide, that this is the time point when we start making it once in 2 weeks rather than weekly. And it'll be interesting to see if those responses last. So coming back to the data of the patients who achieve a CR, majority of them have an MRD negativity, about 90.5%. And I think we've skipped that slide. So most patients who achieve a CR, once they're put into the once in 2 week therapy, they maintain their CR. Some of them who have not achieved a CR develop a CR afterwards as well. Now this is where we have to be careful, as is true with BCMA-directed therapies, especially the bispecifics. The treatment emergent side effects were there in 100% of the patients. I would want to divide this into hematological side effects and non-hematological side effects. The CRS rates were high, however, most of the CRS cases were mild. So 71% patients developed a CRS, however, most of it was grade 1 and 2. It's the hematological toxicities where we have to be really careful. A significant percentage of the patients developed a hematological toxicity, and a vast majority of these were grade 3 and 4. So here we can see that 70.7% patients experienced a grade 3 or 4 event, and 4 deaths were deemed as treatment related by investigator, caused by either adenovirus hepatitis, adenovirus infection, pneumonia, which was again adenoviral, or pneumonia because of pseudomonal infection. Neutropenia, 45.9% patients developed neutropenia. Almost all of this was grade 3 or 4. So the myelotoxicity is definitely there. The treatment emergent adverse effects leading to dose modification was there in dose reduction was seen in 28.5% patients. The most common reason was either hematological, mainly neutropenia, or infections. The treatment emergent adverse effects, adverse events leading to dose interruption was seen in 77.2% patients. Again, most common reason being infections, 50.4%, out of which COVID and pneumonias were the commonest reason. The second most common reason was hematological adverse events. So yes, 71% patients did develop infections, out of which 51% had grade 1 or 2, 42% had grade 3 or 4. Commonest being respiratory, pneumonia, sinusitis, and also UTI, along with COVID. So this is the standard dosing of the drug. You give your standard pre-medication, then 12 mg on day 1, 32 mg on day 4. We personally prefer admitting the patient to monitor for CRS. And then on day 8 is the 76 mg dose, following which you continue the weekly dose till week 24, and after that you make it once in 2 weeks. The standard protocols for infection prophylaxis are followed. Again, the change in the duration and dosage of drug has a specific protocol. It's best to look it up when you encounter a problem. So overall, response rates of 61%. Majority of responses were CRs or better. Majority CRs were MRD negative. Again, PFS was 17.2 months. The median duration of response was not reached. And one thing where it stands out is that beyond a certain point, beyond the 24-month point, we can make it once in 2 weeks. So financially, a little less burdensome for the patient. That's it. Thank you.
Excellent talk. So I'll ask just one question, that where do you want to place this drug in the era of this monoclonal antibody in the relapsed refractory cases?
Ma'am, once we have exhausted the options of, our IMiD, our proteasome inhibitor, and our daratumumab, that is where I think the role of, and also the patient has undergone a transplant prior to this, that is where I would bring in the BCMA-directed bispecifics. However, I think if the option of a CAR-T cell therapy is available, in that case, that should be preferred, because we didn't really discuss it here, but patients who respond, who've undergone a CAR-T cell therapy prior to receiving elranatamab, can still achieve some amount of responses on elranatamab, whereas the reverse would be less likely.
Any complications related, have you handled this?
We have some limited experience with elranatamab, and again, from the very first dose, the patient did develop CRS and hypotension, which was very easily manageable with just steroids. But that's all. I mean, I think we've yet to reach the infections and all of that.
Thank you. Thank you. Any question from the audience? If no, then thank you. Thank you.
Thank you.
So the next speaker is Dr. Rohan Halda. He's going to speak about the role of anti-BCMA therapy in the management of multiple myeloma. He is a consultant, hemato-oncology, bone marrow transplant, RGCI Delhi.
Good evening, everyone. Thank you for that introduction. While my slides are being loaded, I'd like to thank the organizers for having me here. So I'll be speaking on the role of anti-BCMA therapies in the management of multiple myeloma, especially the role of belantamab mafodotin. I'll be just covering. Yep. So I'll be just giving you an overview of multiple myeloma. What is the current unmet need in the relapse setting? What are the treatment options that we have at present? And what is how one should assess the role of anti-BCMA based therapies in the treatment of multiple myeloma. So this is a GSK non-promotional meeting, and the slides have been provided to me by GSK. So as we know that multiple myeloma is a clonal malignancy of the plasma cells, which results in bone marrow infiltration and secretion of a paraprotein in the urine and serum, and a combination of both of these leads to end organ damage. And despite the fact that there have been newer therapies, most of the patients will relapse, and progressively they will become refractory to subsequent lines of therapies, and hence at present it is incurable. And multiple myeloma is one of the second most common hematologic malignancies. As per the WHO, there were about 16,000 new cases reported in India in 2022, with about 14,000 deaths in the same year. The estimated five-year prevalence is about 40,000 cases. Now, what is interesting is, despite the fact that there have been new therapies that have been available, we can see from this Kaplan-Meier graph that with subsequent lines of therapy, the time to progression keeps on decreasing. So at first line, probably the time to next progression would be about 18 months, and by the time you are on the, say, 4th or 5th line, it goes down to as low as maybe 5 months or 3 months. So despite the fact that there have been improvement in the therapies that have come off late, but the overall survival and the time to progression has not increased significantly. So when we start treating a patient with multiple myeloma, we use a combination of either a proteasome inhibitor, anti-CD38 molecular antibody, or an IMiD in combination. And depending on how you classify your patient, either as transplant eligible or an ineligible, you would use a triplet or a quadruplet based induction. But with increasing use of daratumumab in the first line, what happens is once your patient relapses, you have the option, as of now, if you bar other BCMA-based therapies, you have the option to use pomalidomide-based treatment, or you have the option to retreat with daratumumab and lenalidomide if they have been off therapy for some time. Retreatment will give you a progression-free survival of about 5 months, and if you go the optimism trial way, you have the option, you might get a progression-free survival of about 9 months with pomalidomide, bortezomib, and dexamethasone. Now, with the increasing use of IMiD and proteasome inhibitor, that is bortezomib in first line, so most of your patients will become lenalidomide refractory, and subsequently, once they are refractory, they have a very poor survival, and with subsequent lines of therapy, and the time to next treatment keeps on decreasing. They become refractory, and similarly, as we are increasingly using daratumumab in first line, these patients also become refractory to daratumumab-based treatments. To make things worse, if the patients have high-risk cytotoxic abnormalities, they don't do well. They don't do that well, and obviously, if they have associated renal impairment, they are at risk of higher toxicities and poor outcomes. So BCMA is likely to be the target that may help address this unmet need. So what happens in a newly diagnosed myeloma is we use a combination of these 3 drugs. In second line, we have BCMA as a target that can be, that can help improve outcomes. So BCMA targeted therapies, we have the option now one is CAR T cell, though commercially not available. Probably it will be available in the near future. Belantamab mafodotin, which is an antibody drug conjugate, it will be probably, again, it is an option in second line. Bispecifics have been currently approved in third line and beyond, and again, in the near future, probably we'll be seeing more second line use. What makes BCMA a very attractive target? That it is almost exclusively expressed on the plasma cells, and especially overexpressed in the malignant plasma cells. It has minimal expression on other cells, so it has very less off-target side effects. The expression is very high and uniform in multiple myeloma cases, which correlates with the disease progression, and it makes it a reliable marker for targeting the plasma cells. So you can target BCMA by using either antibody drug conjugate, that is belantamab, which is given intravenously. It is a monoclonal drug conjugate with a cytotoxic agent. Biospecifics, we know again are humanized IgG4 antibodies which bind the CD3 and the BCMA. And CAR T cells, as we know, are again modified T cells are directed against BCMA. And we know that the side effects of CAR T and bispecifics are somewhat similar in the form of CRS, ICANS, and hematologic toxicities. Discussing the results of Majestic 1 and Magnetism 3, both these drugs have shown an overall response rate of about 60% with a progression-free survival ranging from 12 to 18 months. However, these are approved only in 3 lines and beyond. With coming to the adverse events, cytokine release syndrome is quite common. Hematologic toxicities also are seen in about 50 to 70% of the cases, and infections are seen in about 70 to 80% cases, which limits their use in our routine practice. So I'll be discussing the role of antibody drug conjugates, that is belantamab. I'll be discussing the DREAM7 and the DREAM8 trials. So belantamab again is a BCMA targeted antibody drug conjugate. It has multimodal mechanisms of action. One is payload dependent, in which it delivers an intracellular cytotoxic payload, that is monomethyl auristatin F, that disrupts the microtubule networks and induces an immune-related cell death and helps priming the immune system. It also enhances the anti-tumor immunity by having antibody-dependent cellular toxicity and cellular phagocytosis without causing any immune exhaustion. Now coming to both the trials, in the DREAM7 trial, belantamab was combined with bortezomib and dexamethasone in the experimental arm. The comparator arm was daratumumab, bortezomib and dexamethasone. In the DREAM8 trial, it was belantamab, pomalidomide with dexamethasone, and the comparator was pomalidomide, bortezomib and dexamethasone. Coming to the dosing, belantamab was given in DREAM7 at 2.5 milligram per kilo every 3 weeks. In the DREAM8, it was 2.5 milligram per kilo administered on cycle 1, followed by 1.9 milligram per kilo from cycle 2 onwards, given every 4 weeks. With regards to the patient population, the only significant difference was the DREAM7 trials did not allow any anti-CD38 refractory patients on its trial. Anti-BCMA based therapies were not allowed in either of the trials. With regards to the primary endpoint, both the trials had the primary endpoint as progression-free survival, and the secondary endpoints were overall survival, MRD negativity, and duration of response. Coming to the DREAM7 trial, again, with regards to the baseline disease characteristics in both the groups, it was well balanced. About 51% had received at least one prior line of therapy, 28% were high risk, 33% were lenalidomide refractory, and about 90% of them had received a prior proteasome inhibitors. In the DREAM8 trial, again, in both the groups, they were quite balanced. About 53% had received prior one line of therapy, 81% were lenalidomide refractory, and about 23% were anti-CD38 refractory. Coming to the progression-free survival, again, the belantamab arm demonstrated a 23-month extended median progression-free survival benefit over the daratumumab bortezomib arm. In the belantamab arm, it was at about 36 months versus 13 months in the daratumumab arm, with a 59% reduction in progression or death. In the DREAM8 trial, the belantamab arm showed a progression-free survival of about 32 months versus 12 months in the pomalidomide bortezomib arm, with a 51% reduction in the risk of progression or death. Now coming to the subgroup analysis, again, patients who were refractory to lenalidomide or had high-risk cytometric abnormalities benefited from the experimental arm. And again, in the DREAM8 trial, what is seen that patients who were anti-CD38 refractory, who were lenalidomide refractory, or who had high-risk cytotics, they benefited with the use of belantamab. Coming to the overall survival, the data is still not mature yet, but in both the trials, the median overall survival has not been reached. However, the initial and the preliminary results are quite encouraging, suggesting that belantamab has a survival benefit. Now coming to the response rates, which we are really interested in, the belantamab arm was associated with better CRs at 35% when compared to the daratumumab arm, which was at 17%. The MRD negativity rates were about 25% with belantamab versus 10% in the daratumumab arm. In the DREAM8 trial, the belantamab arm showed a CR rate or better about 40%, and in the control arm, it was about 16%. Again, the MRD negativity rates were about 24% with belantamab compared to 5% in the control arm. So, to summarize, in both the DREAM7 and the DREAM8 trials, the efficacy benefits of belantamab were seen in patients who were lenalidomide refractory, who were anti-CD38 refractory, who had high-risk cytotoxic abnormalities, and who had some kind of mild to moderate impairment. With regards to exposure-adjusted rates of non-ocular adverse events in both the trials, the exposure-adjusted adverse events were generally similar or lower in the DREAM7 or the DREAM8 trials, and the overall rates of adverse events which led to treatment discontinuation were well balanced in the experimental and the treatment arms. With regards to the rates of CRS, neurotoxicity, and fatal infections and IVIG use, 7 deaths due to infections were seen in both the trials, each and there were no rates of CRS. Neurotoxicity was seen in about 46 patients out of 242, which was mainly due to botulism. IVIG use was seen in about 8% patients who were receiving the belantamab botulism based therapy in the DREAM-7, and about 18% patients with belantamab and pomalidomide. An important adverse event is the corneal toxicities and the visual changes, and we should be cognizant, and we should manage the patients appropriately. As per the DREAM-7 and the DREAM-8 trials, the best corrected visual acuity changes were reversible in most of the patients. We can see in both the DREAM-7 and the DREAM-8 trials, about 35% of patients reported that they had worsening of the visual acuity of 20/50 or lower. What is important to know that on stopping the drug, about 84 to 93% of the patients said that the ocular side effect improved, and about 92 to 96% of the patients reported that the ocular side effects completely resolved on stopping the drug. The rate of discontinuation because of belantamab ocular toxicities was to the tune of about 9 to 10%. It is important to get a help from ophthalmologist when you are enrolling a patient on belantamab. So you need a baseline eye examination prior to starting the drug. Also, one should note for any pre-existing ocular conditions that may hamper its use. However, there was any pre-existing conditions did not exclude any of the patients from receiving belantamab. And also, it is important to take help from our ophthalmologist if additional medications are needed to manage the ocular side effects. They have to undergo a slit lamp examination at baseline, followed by best corrected visual acuity at baseline, as well as prior to each of the first 4 cycles, and following which based on an as per need basis. Some of the recommended supportive care is to use a preservative-free lubricant eye drops at least 4 times a day. For dry eye, you might require some additional therapies. Try to avoid any contact lenses. If you notice any corneal findings like any superficial punctate keratopathy or any microcysts like inclusions, with or without any visual changes, stop the drug and wait till the visual and the corneal changes improve. In case the patients have a corneal ulcer, it is suggested to manage like any other corneal ulcer and then resume the drug once there is improvement. Also, it is advised to caution the patients to avoid driving and to use machinery because it can hamper your vision, and to report early if there is any adverse events. With regards to the ocular adverse events, what we can do is we can manage by dose modifications. So you do a baseline eye examination. We start at 2.5 milligram per kilo of belantamab. Get an eye examination, say prior to the next dose. If there is a grade 2 or higher ocular event, we stop the dose or hold the dose and wait till the ocular event has recovered, and then we can redose as per the manufacturer's recommendation. And if there is worsening of the eye symptoms, then we can consider stopping it permanently. An important thought that comes to our mind is if we have to hold or delay the dose, what will happen to the response rates? What is interesting to note that once from both the DREAM-7 and the DREAM-8 trials, if there is any delay and even in patients who go on to receive the extended period of dosing, the responses were not lost, or rather it was maintained in about 92 to 95% of the patients, despite delay or extended period of dosing. We had the experience, we were fortunate enough to use belantamab in about 4 of our patients. These are the patient profiles that we have. So we can see that at least there were 3 patients who were having some kind of high risk abnormalities or who would fit into a functional high risk. 3 of them were transplant eligible, underwent a transplant and were on maintenance. At relapse, about 1 of them had a high risk abnormality, and we were able to treat 3 of these patients as per the DREAM-8 trial. What is interesting is even after the first cycle, the responses was quite encouraging. You can see in the second patient where the difference in the free light chain came down from 300s to double digits. And with regards to the infection, we had only one patient who had recurrent UTI. She required IVIG, otherwise none of the patients required any IVIG. There was no CRS, no ICANS. 2 patients had grade 2 ocular toxicities, which completely resolved on holding the drug, and the patients have gone on to receive subsequent cycles. So to summarize how we place an ADC with regards to the available CAR-T and say bispecifics, the IVIG infection prophylaxis requirement is very low at less than 20% with belantamab. CAR-T-cell, it will be about 60% and about 90% with bispecifics. Again, belantamab will require annually about 13 to 17 visits to the hospital. CAR-T, we know that it will have multiple visits in the sense that it will have leukapheresis, bridging therapy, and then inpatient administration and for lymphodepletion and for infusion. Bispecifics will have about 40 to 50 visits to the hospital. The only other infrastructure that will require is that you'll need ophthalmologist in close coordination to manage these patients. And obviously, belantamab can be done in an outpatient setting. Bispecifics also have that advantage, but you'll need the hospitalization in the step-up dosing. Some of the key takeaways from the DREAM-7 and the DREAM-8 trials are that belantamab in combination have shown that they can extend survival when compared to the standard of care triplet therapies. Both of them have shown that the responses can be deeper than the standard of care and they can be more durable. Again, both the DREAM-7 and the DREAM-8 trials have shown that belantamab has an acceptable safety profile, and with those modifications and appropriate supportive care, it has a good tolerability profile. However, we'll have to learn more regarding how we manage the eye toxicity in real life. We have seen out of the 4, about 2 patients have got eye toxicities. I think it will be quite manageable. I think we'll have to get more experience regarding that. As of now, the European Hematology Association and the European Myeloma Network recommend that belantamab is an option for patients who are daratumumab naive and they are sensitive, or even if they are refractory to daratumumab based therapies in the second line as well as in the subsequent lines. So belantamab is depending on which trial you look at are one of the options that are available regardless of previous exposure or refractoriness to therapies in the first line. And I think with that I'll call it a day. Thank you.
Thank you, Doctor. Just a question again, where do you want to place belantamab? Because I have seen that 50% of your patient had some kind of toxicity, ocular toxicity, because one of my patients had refused to take this drug because of the ocular toxicity. So how did you manage that?
So we had to hold the drug till till the toxicity resolved completely. And what was interesting that we encouraged the patients to use their lubrication eye drops, irrespective. What happens is many times the patients, once they go home, they forget. Okay, because suppose your discharge summary doesn't mention for how long to take the eye drops. They just think that it's probably for the next 4 days, 5 days, and they'll stop it. So they have been strictly told that whenever you go back home, you please continue. We reiterate that please continue using the eye drops. Of course, it is a problem. There will be some discontinuation. I agree. It's not going to be the same. But again, it is a good option to have in second line. I don't know how many of us will be able to offer, say, bispecific or even CAR-T in second line. So this is good to have an options. The more options we have, it's good for the patient. It may not be applicable for everyone. I agree with that.
Thank you. Any question from the audience? If no, then thank you, Dr. Rohan.
In the trial, you mentioned about 10% patients did not recover the eye toxicity. Is that?
So they basically did not want to continue. Like Madam said, the patient did not want to take the drug. Please, I'm done with it. So there were about 10% discontinuation rate. So they didn't continue. It was not that it didn't recover. Most of them recovered. It was, I think, only patients who had a very bad vision where the visual acuity went down by say 20 by 200. It was only one patient in the DREAM-8 trial who did not recover their vision. Otherwise, about 96% of the patients recovered from the eye toxicities. So there will be patients who will drop down. I don't disagree with that. But again, most of the patients will recover.
And you mentioned that if there was a baseline reduced vision, it is still okay to use this drug, right?
Yes, you will have to evaluate. So if at baseline, if your visual acuity is poor at baseline, you'll have to use that as a baseline and then check the visual acuity when the patient comes at subsequent follow-up, if that has worsened from the baseline.
But that's not an exclusion.
No, that's not an exclusion. None of the eye conditions were an exclusion for administering belantamab.
But you did not have faced blindness, complete
No,
blindness?
nothing of that sort. Nothing of that sort.
And the European guidelines you say mentioned in both anti-CD38 refractory and naive
yes.
both. So do they specify preference for bites? I mean, over the say teclistamab?
Not in this.
Not
in this. I think in this, if I can show you.
Where
I think
do you
because they
place
have
this?
the option to CAR-T. So that is one thing. I think as of now, I don't see the bites in second line because still the approval is for a third line.
So
But probably
this
we'll be
is
seeing.
Before you're saying this is even earlier lines, this is recommended.
Yeah, that's a first relapse.
That's the first.
First relapse. So probably in second lines. Now we will be seeing more bites in second line from the Majestic 3, and we have seen now, I think we had in EHA the talquetamab trial as well. So I think we'll be seeing second line, a lot of bites coming in, that is expected. So we'll have to see how to choose. That sequencing will be probably an issue we'll have to
Has this been
debate.
tried after failure of teclistamab?
No. Rather, it's the other way around. Real world studies have shown that teclistamab works even in patients who have received an ADC.
Thank you, Dr. Rohan.
Sure. Thank you.
So I'll invite Dr. Isha Kaul for the latest update on NHL with NextCar 19.
Hello again, and I'll just quickly take you through the data and just sort of teasing out really the data of use of NextCar 19 in non-Hodgkin lymphoma, CD19 non-Hodgkin lymphomas. So, this is the problem statement, and I think this audience very well knows what the problem statement is. Then when treating large B-cell lymphoma, limited stage or advanced stage large B-cell lymphoma, it's a good prognosis disease, right? That's how we counsel our patients. But if you look at primary refractory, early relapse, late relapse, from about 30% of patients will eventually, despite best upfront treatment, be either primary refractory or relapse after frontline therapy. So the patients whose needs we are trying to meet are these 30% of the patients who are either can be limited stage, advanced stage, primary refractory, or early relapses, because they are the ones who typically don't do well with other, so-called standard of care therapies. And unfortunately, in diffuse large B-cell lymphoma, most of the relapses are in fact early relapses. Every once in a while, we will see a late relapse, month 19, month 20, 22, but most of the relapses tend to be within the first 12 to 18 months, about 70% of them. And if you look at, the pre-CAR outcomes in these patients, the so-called relapsed refractory large B cells, it's poor, right? I mean, so the response rates from some pooled analysis that have been done in this population, whether it's Scholar 1, Coral, third line treatments, the objective response rates are in the 20 to 30%. Because in general, these are refractory patients. There are chemo refractory patients. Usually they are getting some kind of platinum-based salvage along with the CD20. That is, usually what has been happening. But the responses are very poor, and CRs are extremely low. Less than 10% of patients actually achieve CR. And obviously, a patient with active lymphoma, the likely survival is not very high. So not surprisingly, the median overall survival is 6 months in this difficult to treat population. So, this is just a breakdown of, how these patients have been treated and what the problems have been with those treatments before CAR T cell therapy came around. So of the patients who are treated, and even if you intend to transplant them, right? I mean, because that was our standard of care for all relapsed refractory large B-cell lymphomas for a number of years. For some reason or the other, the patients may not even reach that point. About 50% of the patients may have some kind of organ dysfunction, whether it's chronic kidney disease, chronic liver disease, some kind of cardiac comorbidity, which makes them ineligible. Generally, we know that in order to derive benefit from autologous transplant, you have to demonstrate some kind of chemosensitivity. And for patients who are completely refractory, so they're progressing through your platinum-based salvages, they are unlikely to benefit from transplant, so they may not be taken for transplant because of that. And a problem which we used to face a lot earlier, it is somewhat reduced, but still once in a while we see it, is cell collection, mobilization failure. So every once in a while we'll get patients who are coming to us after 6 cycles of ICE, bendamustine, a lot of other things, and when you try to mobilize them, there is a mobilization failure, and that happens about 20% of the times, and which is unfortunate. So altogether, even if transplant, we say it has some benefit, the number of patients who can actually reach that intended treatment is a small percentage. So in this landscape came, Zuma 1, which was the first study that showed some response CAR T cell therapy in refractory B-NHL. The median overall survival in Zuma 1 was 25.8 months. And this is not a head-to-head comparison. This is just a historical comparison with Scholar 1, in which chemo followed by transplant was used, in which the survival was 6 months. So this was a very, very big milestone in treatment of relapsed refractory lymphomas. The response rates was very high at 83%, and 2/3 of those responses were actually CRs. And so about half of these patients were alive at 2 years as compared to only 20% of those in the pre-CAR era. So, the technology was established clearly by Zuma 1. So now we are talking about NextCAR19, which is the world's first humanized CAR T, also known as Tali-cell. It has a 4-1BB co-stimulatory domain. And the fact that this, it shows that there is a lot of CAR persistence. So if you look at, data of CAR Ts, different formulations around the world, CAR T persistence can be an issue, but the 4-1BB domain does make for a better, longer CAR T persistence. And the fact that it is completely humanized makes the fact that the safety profile is better. So you're getting a relatively good response, relatively good efficacy with a reasonable safety profile with this kind of structure. So this is the data of the lymphoma patients. So this is not all patients treating on NextCAR19. This is just the lymphoma ones, and I think the data cutoff on this is 31st May 2025. So a total of 194 patients were leukapheresed, out of which 169 were infused. I'll just pause here and take you through the reasons why some of these patients were not infused. So 3 is manufacturing failure, which is understandable, that is pretty much standard everywhere. But 14 patients were dead before infusion. So I think this really highlights a very poor patient selection. So these are essentially patients who were possibly in an ICU or literally, with expected life expectancy of 2 months, who were leukapheresed. We understand that sometimes there are desperate situations, but if we start doing a lot of these patients, then that is also, not a good practice in general. So I think with more learning curve for everybody who's been using this and a better understanding of patient selection, hopefully this percentage of patients who are not able to get infused because they die between leukapheresis and infusion can come down. I think in leukemia, it is still somewhat acceptable because that's more of a rapidly proliferating disease. But in lymphoma, these numbers should really be very small if we are selecting patients better. So the numbers that were evaluable were actually 140. The median age is 53, the oldest patient being 83. So this is also important. So because typically an 83-year-old would not be considered transplant eligible. So the fact that a good number of patients in 70s and 80s were also in this real world shows that you can expand access to patients who are having the disease but are not transplant eligible or have some organ dysfunction, making them the predicted TRM with an auto transplant higher. Majority patients were male. And you can see that almost half of the patients had 3 or more lines of therapy before getting NextCar19, and 8% of the patients had had a transplant before. Majority of the patients were not bulky. Some 76% patients were in fact non-bulky, and this gets a little tricky, but this is the best that we have. Now, if we look at, the utilization across India, you can see that there is a big domination from the West Zone, which is 43%. And I suspect this is largely because of the cohort at TMH, where the original study was conducted. So that contributes to the large percentage. But a good numbers in South Zone and North Zone. East Zone, there has been some lag, but I was just hearing that those numbers are also starting to pick up now. Making the fact, it's encouraging for us as a country that car utilization is expanding across all parts of India. So access and reaching more and more lymphoma patients, throughout the geography, that is a plus. And if you look at the distribution of lymphomas, because it was approved not for large B cell, it was approved for CD19 positive lymphomas. So even though majority of patients are high-grade lymphomas or large B cell lymphoma, we do have, some smaller numbers, interesting numbers that, we can individually tease out at some point. Primary mediastinal B cell, transformed follicular, and mantle cell. So I think individually also centers will have experience with these kinds of lymphomas as well. Becomes important when we see these patients to see that yes, the product has been used in a wide variety of lymphomas. Still the numbers from the non-large B cell and high grade are small. So as those numbers mature, I think we can derive more information about their meaningful representation from those as well. Now, if you look at, the remission rates, CR/PR, the overall response rate is 75% at day 28 and 61% at month 3. So my reading of this is that when we are looking at a lymphoma response, overall response rate is not as meaningful. What we are really looking for is a CR. Because most of the patients who are in CR are the ones who will have sustained responses. Our own center analysis also showed that patients who were in CR at day 30 were more likely to stay in CR. In some of the products, you will see that a PR at day 30 can convert to a CR at day 60 or 90, but that does not seem to be the case. So my sense of reading this is that CR at day 30 is, our most early predictable, predictor of that, how this is going to be. Overall response is fine, but a PR is very likely, or a stable disease is very likely to just progress by the time you scan them again at day 60 or day 90. So if you want to plan an intervention based on the day 30 scan, it might be the right time to do it rather than wait for day 60 or day 90. So but overall, if you see that the CR at month 3 was 57%. So I think that is a good number that really tells you the story of what is happening. That is still a good number, 57% CR at month 3. And if you look at how these numbers compare to globally approved similar products, Axicell, Tisacell, Lisocell, the numbers are now getting comparable, right? So 140 comparing to 200 something. This is published data from these products. Obviously, they're being used very, very widely now. Our median age is lower. India is a younger country in general. The line of therapy is higher. Axicell, Tisacell is mostly median lines 2. Talicell is at 3. The progression-free survival at 6 months is 58%, which is again, broadly you can see that the numbers are somewhere in the 40 to 60%. And if you look at the overall survival at 12 months is 60%, and progression-free survival again, so this is, when the patient asks you, can I be cured? This is what they are asking, that's the number they are looking for, that what are the chances that I will be cured from this? And I think the best surrogate for that is progression-free survival at 12 months, which the real-world data showed was 40%. So I think if we are giving an honest answer to the patient, that's not a bad number. This is a very, very difficult to treat patient population with heavily pre-treated. So getting a 40% progression-free survival at 12 months is quite comparable to similar products worldwide. So that, to me, is the single most important number. So this is again, just teasing it out further, comparing PFS, OFS at 3 months, 6 months between different products. But I've given you, I think, what is the most important numbers. So now if we look at the safety data, we were very, very concerned when we initially started using CAR-T. Obviously, everybody, it was a new experience of how this was going to pan out. And I think that is a very good story for CAR-T use in India. It's a big positive that in general, across all centers, our ability to, preempt or manage toxicities has been pretty good. The CRS rates, if you look at grade 3, 4 CRS is not very high. I think for an Indian product, that is very important, because if we see that there is a lot of toxicity, if it is a product which is efficacious but has a lot of toxicity, it's likely that its use will be limited to very few centers that are capable of managing those kinds of toxicities, and wider application might get difficult. But the fact that grade 3, 4 CRS percentages are low, and the even more important fact that grade 3, 4 ICANS is extremely low. I think the fact that it is completely humanized really reduces the ICANS rate. It's not zero, so I think it's low, but we still need to be vigilant. We've seen some mild ICANS in a couple of our patients. A patient with secondary CNS lymphoma was the one that we saw about grade 1, 2 ICANS. He responded well, but it was important to recognize it. But I think the fact that very severe toxicities, early toxicities we are not seeing, makes it easier to adopt across India. Hypogamma is, very high, and our experience also is comparable to the world, that it corresponds to response. So patients who actually, we get worried about patients who do not have significant hypogamma, because you can almost predict that they will relapse within 6 months. So it kind of goes hand in hand with the efficacy. And the HLH kind of symptoms, the IEC, HS, that has been, something that we have really had to have a learning curve with a 16% rate of HS, because this can really start bothering you even in month 2, month 3, when the patient may be going back to their native place or hometown where they've come from. It may not be the toxicity that you are managing when the patient is inpatient on day 7, 8, 9. So I think centers are getting better at predicting this, at prognostication patients about this, and using whether anakinra or Jakavi and all of these products to manage this better. So I think I'll skip all of this. I've already said that. So this is the PFS 44%. Long-term persistence, we all know how it goes. There is one important slide that I do want to take you through. The bridging is important. This is not tally cell data, this is just worldwide data showing that people who have less metabolically active tumor volume do better. But is it the bridging or is it the biology of the disease that predicts for better responses? We really don't know. There is one study, which is here somewhere, which does show that when we say high volume disease, the time point at which we call it matters. So if you have high burden of disease at leukapheresis, but you are able to get it down to a low tumor burden before infusion, then the prognosis is not so bad. But if the burden of disease, the metabolically active tumor volume is high at the time of infusion, those are the patients who tend to do worse. Again, you might be able to control it to some extent with some bridging, But too much bridging also, then you might just lose the patient because you are now giving them cycle after cycle of toxic therapy, trying to bring the tumor volume low. So that again, I think has been a learning curve of how much bridging is enough bridging, how much bridging is too much bridging. At some point, you just have to accept that, this is the biology of the disease and just give the cells. So this one, if you just spend 2 minutes on this slide, these are again small numbers, but trying to analyze the subsets of patients, predicting how to select them. So the parameters that have been included are bulk of the disease, IPI, and whether they are primary refractory, early relapsers or late relapsers. And the numbers with green are the ones who are doing the best. So in general, as you can predict, patients who had low IPI disease, who had non-bulky, were the ones in whom the PFS was the best. So if you look at 86%, this is a small number, just 10 patients. This is low IPI, late relapser, non-bulky disease. So these are patients who are having excellent outcomes. And then but still in patients who have bulky disease, high IPI disease, who are primary refractory, there is a 25% PFS. So the number is low, but it's better than nothing. So I think again we can use, these are again small numbers, this is n single digits, n of 6, 7 like that, so you can't really drive a lot out of it, but it does tell you that maybe taking patients in earlier lines of therapy is better because you're likely to have patients with less bulky disease and some amount of chemosensitivity at that time. But just because somebody has bulky disease does not mean that you do not offer them the therapy at all, because some of them, about 30-40%, depending on the numbers, how you look at them, will still have a progression-free survival at 1 year. So, but whenever possible, you select based on this, but this is not always in our hands. I think with that, I conclude. I'll leave the slide here in case somebody wants to take a look at it. Thank you so much.
Thank you, Dr. Isha. So, any question? Yeah, you can go ahead.
In the initial slide, you showed that how many were, not infused.
Not infused.
But then from how many infused to how many evaluated, there was a 30 patient less.
I think it is just that at the time that the data was evaluated, they had to have a minimum of 3-month follow-up. So if the patient who's been infused but has not had like 2-3 scans by the time the data is evaluated, they've not been included in this data.
I just want to make sure that's the...
Yeah, so there's probably some patient who was like 20 days post-infusion or 40 days post-infusion. So those are the ones who are in that drop.
That was excellent presentation, ma'am. Just one question. Immunoact, we give the whole product in 1 day. And with Immunul, we are giving it in 3 divided doses. So what's your opinion regarding this? Does it affect the efficacy of the CAR-T?
I don't think it affects the efficacy at all. I think the question is more of toxicity management. And again, I don't think it matters so much in lymphoma, but in leukemia, it can be an issue. Because if the the doctor had the choice of giving a single dose or giving a fractionated dose, it would be great. Because if I'm taking a patient with ALL with 80% blasts, if I'm giving them the full dose in one go, I know that the cytopenias and CRS is going to be, very, very high. So if I give it fractionated, then you can manage the toxicity, like you sort of give a debulking chemo before giving the full dose. It's like that. So I don't think the efficacy is an issue, but in certain subset of patients, if we had the ability to give fractionated dosing, I think the biggest need here is the patients with high burden leukemia, where you just who have very high blast count at the time of infusion. They do very poorly with a very large cell dose infusion in one go. But I understand that the companies are not able to change, because this is how we had discussed this. The way it has been approved, it has to be issued in exactly the same way. The only thing you can do is you can decide to infuse half the dose and throw away half the dose, but there's nothing else you can do about it. Unless the labeling changes, which for regulators is a very big issue.
Yeah, this is to generate the data as well from our country, so it is important to maintain the doses. So thank you, Dr. Isha.
Thank you.
Thank you. So next, Dr. Nitin Sood, who doesn't require any introduction. So he's going to talk about the latest update on VALL with Nexca 19.
Good evening, everyone. I think I'm a replacement speaker, so I'll try to be quick about this. So this is B-cell management with CAR T-cell treatment, and Dr. Isha has spoken very well about the CAR T, so I don't need to repeat that. But ALL and CAR T is a slightly different game than lymphomas and CAR Ts. Now ALLs, as BALLs, we know once they relapse, it's a very dismal outcome. The pre-CAR T era was very dismal. You can see you give Innovate, Blina, they're eventually going to relapse and then unfortunately die. Is transplant enough? Data suggests otherwise. Transplant wasn't enough to salvage them. So this was a huge area of need, and CAR Ts solved that problem. The original Zuma 3 trial, which got in Brexucell, and the Felix, which got in Obicell, proved that we could get survival which was better than Blina and Ino. And there was unprecedented success. Survivals were getting better with CAR Ts, so we had to get in our own indigenous CAR T. And this was the multi-center, non-randomized, single-arm phase 1 and 2 study which was conducted, which was pivotal in getting license for this CAR T. So here it compares Talicel, the CAR T that we are talking about, to Tisacel and Brexucell, and the disease characteristics were roughly balanced across trials. Although the Talicel used patients which were slightly more unwell than the other trials, where ECOG2 was included as well, and prior lines of therapy was 1 to 4 as compared to 3 and 2 to 3. So, but despite that, we got clinically comparable results. So it's a CAR T that has given roughly comparable results. You see overall response rates, the blue bar, the progression-free survival, the orange bar, and the green bar is overall survival. And so response rates, progression-free survival, overall survival between the 3 trials, and you can see the results are comparable. In fact, Talicel, the bar here shows that if you have less than 25% blasts, then your overall response rates are going to be 100%. So it's going to do very well. This is the long-term persistence study. And because this is the 4-1BB CAR T, it expands very quickly or not very quickly. So the expansion phase is roughly in the 2nd week. The peak expansion is at the end of the 2nd week, and then starts the contraction. But the persistent studies that Dr. Isha as well showed that the CAR T cells will last in the system for about 3 years. Now that's the trial. What about the real world data? So infused in 145 patients, leukapheresed 145, infused 133, and the evaluable cohort was 118. So the slight gap again between infused, between the ones that were infused and the evaluable is the slight gap that Dr. Isha explained already. So here's the split between the regions. The west zone predominates again, as it did with the lymphoma ones. The leukemia cohort, there were rapid and deep remissions, about 89% at day 28, and there was sustained clinical benefit of 76% at month 3. So these are the 3 trials or 3 real-world efficacy comparisons for CAR Ts in relapsed refractory ALLs, and I want you to focus on this area where the 6-month progression-free survival, the 9-month and the 12-month are roughly comparable between 3 trials. So our CAR T is roughly as effective as the global CAR Ts are, which is very good for us and gives confidence to the clinicians that the CAR T works. We get durable cancer-free survival compared to global CAR Ts. So the top curve is Tisacel and Brexucell superimposed on each other, Although these are cross-trial comparisons, but that gives us a roughly similar curve as far as progression-free survival is concerned. This is durability or overall survival, and again curves are superimposed on each other, giving us good overall survival. So comparable overall survival between Tisacel and Brexucel, the similar ones. So what about the safety? Now we've looked at the efficacy in the real world. What about the safety in the real world? Now this is again 4-1BB, so you get slightly delayed expansion phase. So the CRS is less, the ICANS is less, and you can see CRS happens, or at least grade 3-4 CRS happens in about 7% of patients. Although some amount of fever or hypertension can happen in about 77%, ICANS happens, or grade 3 or 4 happens in only 5%. Hypogammaglobulinemia happens in most patients. As we know, CAR-T really knocks off your B cells and reduces your IgG levels or all immunoglobulin levels, so that will happen. Low rates of grade 3, grade 4 CRS and low rates of ICANS. So comparable efficacy and better safety outcomes, at least in relapsed refractory ALLs. Again, these are the safety outcomes. The CRS and ICANS are comparable, if not less than other CAR-Ts. So CRS about 7% and ICANS about 5%. That's comparatively less, but it's comparable, to say the least. Again, long-term persistence in the real world data also shows that the CAR-T cells will persist for about 3 years. I'm going to skip the predictors of outcome. These are Chinese studies which show that heavy burden disease is not going to do very well, but we pretty much know that. And the ones who are being exposed to blinatumomab are not going to do well, because again CD19 is the target for both of these products. So this study shows that if you use it early, it's going to be better, but that's intuitively everybody knows that you're going to, if you're going to use a good product early on, you're going to do better. Right patient selection, meaning the patients who have low burden on board and have no infections, is going to lead to less toxicity, less vasopressors, less steroids for management of ICANS or management of CRS, less ICU admissions, of course less cost and less infections, and better survival. So this is survival by blast percentage, showing that at the infusion, if you have low disease burden, then you're going to do better, not only in terms of progression, also in terms of overall survival. So this is the approach to risk stratification, and again very quickly, the high risk disease, consider a transplant after high risk diseases. Standard risk diseases, we do the standard CAR-T and then do persistent studies to check for disease persistence. So this is the last slide, and this is just the HOPE initiative. This says that the ImmunoAct is going to support the physicians as far as from vein to vein. So basically from collection, they will pick up the product, they will process the product and then reinfuse the product, at the same time helping out with toxicity and cost if they can manage it. So that is all I have. I'm happy to answer any questions.
Yeah, thank you, Dr. Nitin. So anyone who has the question from audience, I think next CAR will have a definitely better outcome because it has co-stimulatory receptor, and it has more efficacy, it has more sustainability. So what do we think? But let's see.
Sir, a question, sir. With the leukemia CAR, what is your take on the transplant post-CAR? Is any you select criteria for that?
Yeah. Well, one of those slides shows that. So very quickly, if you have very high risk disease, meaning genetically high risk disease, many lines of therapy and a fit patient, then you should definitely try and do a transplant.
And the others, you are okay with not doing anything, just monitoring? In the real
if you
world
have
setting.
low risk disease and you've done the CAR and the CAR persistence is there, then there's no reason to do a transplant. I mean, that's an open question at the moment. But again, we have to consider transplant mortality, fitness of the patient, infection status, fungal infection, stuff like that. But that's an open question. That really will be answered with time, I think.
Sure.
Thank you, Dr. Nitin. Yeah, that finishes.
All right, thank you.
Thanks to the chairperson and thank you, sir. Moving forward for the last session on DLBCL, I would like to invite the chairperson, Dr. S.P. Kataria, Vice Chairman, Medical Oncology, Medanta, Gurugram, for chairing the session. Sir will join us shortly. Till then, I would like to invite the moderator, Dr. Harshit Khurana, to moderate the panel on driving changes in 1L DLBCL and kindly invite the panelists.
Thank you, organizers, Dr. Nitin sir, and the Medanta team. I would request my panelists to come on the dais, please, and Dr. Tejaswini Vaid, and Dr. Anusha Swaminathan, Dr. Abhishek Bansal, and Dr. Akash Khandelwal. So thank you all the panelists for joining me here. We shall begin the panel discussion on driving the change in DLBCL first line treatment. So to begin with, this is a sponsored session by Roche. So we shall begin with our case study. The case study is a 48-year-old male patient with abdominal pain, lower back pain and weight loss for 3 months. Physical examination revealed palpable abdominal mass and flank tenderness. Lab investigations showed elevated LDH with a CT abdomen showing thickening of stomach wall, multiple enlarged lymph nodes and a mass in right kidney. Upper GI endoscopy revealed a large gastric mass. Biopsy of this mass revealed diffuse large B-cell lymphoma, and immunohistochemistry revealed a non-GCB subtype with c-MYC and BCL2 positive on immunohistochemistry. So a FISH test was done which was negative. This patient was ECOG performance status 1 and the modified Ann Arbor staging or the Lugano system staging was stage 4 disease with an IPI score of 3. So the first question I would like to put to maybe Dr. Anusha can take this. What are the clinical challenges in treating such patients?
Yeah, I think the patient has a couple of extranodal sites, including an stomach wall involvement. So I would be very cautious in the initial cycles and I would watch for any perforation signs. I would also counsel the patient about this. And maybe I would even start slow. I would not be too surprised if somebody chooses an RCVP, debulk the disease, and then go in for a full this thing.
Okay, anything to add? It's a 48-year-old young patient, so please, Dr. Tejaswini.
I would like to see the PET scan for whether the gastric involvement is a full thickness involvement or whether it's only a part of the wall. Because as Anusha mentioned, that we can have a perforation on our hands just in a few days after starting the treatment. And I would also get a surgical opinion whether a partial gastrectomy in any way could help us prevent a perforation in case there is a significant full thickness involvement.
Okay, so let us put it that this gastric mass is not invading the all the 3 layers and is not likely to perforate. So overall, this is a stage 4 disease with extranodal involvement. So I mean, and a young male patient with an advanced stage DLBCL lymphoma with a IPI of 3. So essentially, yeah, Dr. Abhishek, what would your comments be?
Sir, actually, I think we can start with the therapy, but we can start with some pre-phase sort of thing, or we should go slow in this and first try to debulk the disease, then go with first cycle. And we can start with, in this ideal scenario for polatuzumab, so we can start with this, and we can avoid vincristine because vincristine can cause GI disturbances and autonomic dysfunction, which might be harmful in this case because of the GI involvement.
Okay. Any additional inputs, Dr. Akash?
Well, sir, I think the points are already discussed, but yeah, we should be looking into treatment. We can go for a pre-phase, and after 2 weeks, maybe repeat imaging and go for the next cycle. It's a non-GCB type, and they have best studied with polar RCHP as an outcome wise, so we should be going for that. In case it's not a possibility, then R-CHOP can be go ahead with.
Yeah, so essentially we've understood that this is a double expressor aggressive DLBCL, and they are a heterogeneous disease. DLBCL in itself is a large spectrum with multiple subtypes and a heterogeneity. And though it's a higher IPI patient with a ABC subtype, so it's an aggressive disease with no features of gastric outlet obstruction or likely to perforate as far as the summary that has been given. So, and if you differentiate the treatment outcomes based on the IPI, the PFS and the OS of these patients differ by the IPI grading. So, how often or how regular, do you calculate your IPI score for all the patients of DLBCL? Is it relevant upfront?
Yes, for all patients, it's both relevant from a therapeutic standpoint, prognostication, as well as deciding CNS prophylaxis.
Yeah, okay. So there is definitely an unmet need since the standard R-CHOP chemotherapy here may at times, as already discussed, there will be 30% primary refractory and there will be failures or early relapses in such an aggressive disease patient being a heterogeneous disease. So IPI calculation based on the parameters as shown differentiates the disease into the earlier stratification of low risk, intermediate low and high intermediate and then high risk. And the outcomes or PFS and OS were statistically significantly different. So outcomes based on the IPI score in the Polarix trial subgroup analysis, they favored the comparison of the two arms like you discussed, whether it will be Pola or CHP would be the preferred choice of therapy or someone would still prefer an R-CHOP therapy. Any one of you would prefer R-CHOP here? Apart from the financial issue, I think, yeah, apart from the cost issue, most of us would now with the current data tilt towards Pola RCHP. Otherwise, R-CHOP has been a standard backbone for last 30 years. So, any opinion on your significance and treatment implication on the differentiation between the two major subtypes, that is the ABC or the germinal center B cell subtype? Dr. Anusha, yeah, okay, please take.
Yeah, in my practice, I do routinely ask for it, and I think now it's standard of care that all histopath reports release it out. Yeah, it's an incomplete form of prognostication. We know more now, but what we are doing with the information of knowing more is still evolving. So I do ask for these tests, I look at it, I definitely do see an ABC type and push more for a polar-based regimen if the patient is on the fence, because I know those patients benefit better. But in my practice, I'm also advocating for lymphoma NGS to know more about the disease biology.
Yeah. So NGS is not routinely being in use as of now for lymphoma, but yes, differentiation between GCB and the activated B cell subtype is important. However, there will be 10 to 20% patients whom we may not be able to subtype because of the limitations of the techniques used. So, as we all know that standard, the activated B cell subtype of DLBCL will not be performing as well, where the role of more intensive therapy comes in more so, and the choice to choose between polar RCHP vis-a-vis R-CHOP goes in favor of polar RCHP. So these three trials, the robust and the Phoenix and the remodel trials, they all did not show any significant improvement in PFS or OFS with the combination of different approaches to treatment addition with R-CHOP. So DLBCL, as we were discussing that the ABC and GCB subtype differentiation, the standard used is the Hans algorithm to differentiate between the ABC and GCB. However, there are different tests. Anybody can elaborate on the different tests, and are they available in our setup in any of your working places? Are you subtyping them further using any of the additional techniques?
Yes, sir. We have an in-house lymphoma NGS, and the report is given out based on the LymphGen classifier. Most patients may not directly fall into one of these categories, but it's a probabilistic classifier, so it gives you the most probable category. We are also picking up quite a few P53s in surprising patients. It is a bit of a head scratcher because then you have to decide on what you want to do about it, but that is still not stopping us from doing the test as of now, with the confidence that we'll know more in the future. Dark zone signature is not available as of now in my setup.
So, yeah, Dr. Tejaswini, other than the cell of origin, IHC and molecular, LymphGen, as Dr. Anusha said, is available. Do you have a LymphGen?
We're not
facility?
routinely doing it, so no.
Dr. Akash and Dr. Abhishek, no? Is it available?
Sir, it is available. I also work in Fortis Shalimar Bagh, but we tend to use it only in selective patients, not all. It's not very widely accepted in my practice yet, but yeah, in a high risk diseases, we tend to look into it upfront, or even in a relapse setting.
So as far as I am available, the dark zone signature and the gene expression profiling is not routinely commercially available to any of us.
I don't think so it's available in India. Is it available, sir?
No, so I don't think so.
Yeah.
Not in my setup, please.
In general, sir.
No, so I don't think so. Yeah, but so basically we all end up doing by the cell of origin, and some of you are now maybe using the LymphGen wala. The cluster, even it is difficult to understand. Okay. So using these different techniques vis-a-vis the gene expression profiling, as you can see on the slide, the concordance of different methodology for the non-GCB is about 82.7% and the GCB is about 71.1%. And overall concordance of these, using different profiling with gene expression is roughly about 80.6%. So we are still not able to further classify these subtypes of DLBCL into the ABC or the GCB, and we call them others, non-GCB. So by the cell of origin molecular subgroup, the ABC, as we all know, is aggressive disease subtype and has shown better responses in the POLARIX study to the polar RCHP arm. Similarly, if we go by the LymphGen subtype analysis, again of these only the MCD and the EZB subtypes by the LymphGen analysis has shown, which is a more aggressive subtype, and have shown better responses with polar RCHP, both even showing the hazard ratio tilting towards polar RCHP. Coming to the cluster analysis from that is from C0 to C5. Similarly, the polar RCHP has shown benefits in the C5 subtype of this, probably ABC type of DLBCL. So to conclude, as far as the cell of origin analysis or the differentiation between the activated B cell type or germinal center B cell type, the LymphGen classification identified the EZB and the MCD subtypes and undetermined subtypes to have more favorable outcomes with polar RCHP arm versus the R-CHOP. These findings further suggest that the polar RCHP provides favorable outcomes to distinct molecular subsets within the ABC and GCB subtypes, including the dark zone signature positive, which presently we are not able to do here in our country. And the molecular profiling tools beyond cell of origin are necessary to apply precision medicine. So probably in next few years, we will be seeing all these newer diagnostic techniques coming in to identify further subtype the ABC or GCB subtypes of DLBCL. So how do specific extranodal sites influence treatment decisions? Any idea, Dr. Akash?
Well, sir, specific extranodal sites, supposedly if it's in the brain, and so that becomes a difference, and skin lymphomas can be a thing, bone lymphomas. These are very peculiar settings where one doesn't have a differential to begin with, that is it really a lymphoma, unlike the lymph nodes which are commonly seen with. So yeah, that has an impact, because as if it's in the brain, it's a total different disease and has to be treated aggressively. The skin one is also different, and so yeah, it is pretty heterogeneous in the approach and identification also, depending on the node, the extranodal part.
Like extranodal, like the testes or the breast is considered an poor prognosis, I suppose. And so basically, and also so as the brain he suggested, and
so Dr. Tejaswini, would you like to?
So looking at the IPI score first of all, which has the strongest predictors in terms of extranodal disease having prognostic implication. Multiple sites has poorer outcomes. Involvement of kidneys and adrenals has poorer outcome.
Yes.
And then again, while some other sites did not make it into the IPI, probably because of the hazard ratio, but conventionally paraspinal, paranasal, breast, testicular involvement are all associated with usually higher chance.
So if we go into the details of IPI and subtype further prognostic classification, there is something called a CNS IPI. So all these things that you laid out are high risk for CNS disease, and these are also require CNS prophylaxis or a high dose methotrexate to be added later into the course of the regimen. However, if you go by these graphs and the polaric study subgroup analysis, patients with 2 or more extranodal sites had poor performances. In these subgroups, polar RCHP showed a better performance as compared to R-CHOP. Similarly, if you see the involvement of skin, soft tissue or serosal, that involvements, the overall survival otherwise dips, and polar RCHP shows better responses with certain tissue areas involvement. So I think we can skip this. This is one study showing which part of breast and testes will have the more aggressive types, the ABC subtypes, and thyroid and GI will have more of GCB subtypes. Yeah, so extranodal disease, polar RCHP tends to show a better PFS and OS when there are more than 2 extranodal sites. So similarly, if you see the only probably thorax and gastrointestinal and bone involvement, a hazard ratio favors the R-CHOP, otherwise all organ systems involvement favor polar RCHP. However, I think this is a very minuscule subtype analysis data, though favoring polar RCHP for most of the extranodal site involvements. So assuming no access barriers, how would you treat such clinically high risk patients? So I think we've already discussed this. Anybody other than the option 2, anyone of the panelists?
DA-EPOCH-R.
Yeah, so you would choose DA-EPOCH-R over polar R-CHOP or R-CHOP?
DA-EPOCH-R only in double hit or triple hit, that's it. Not in the conventional setting or other high risk features.
Okay. So any other opinion, Dr. Tejaswini, anything to add?
In this specific case, if there's no financial barrier, I would choose Pola RCHP.
Yeah, so the data favors Pola RCHP more than any other arm here. Till Pola was available, prior to this, aggressive DLBCLs with the high CNS IPIs, young patients, DA Epoch R could have been chosen as a better result giving regimen. So with these newer regimens, is overall survival still a realistic endpoint in first line DLBCL trials, or do we have another endpoints? Survivals will improve with this vis-a-vis R-CHOP, PFS OS better in certain high risk groups. So do we look at OS or there are further endpoints?
So fortunately we have good salvage regimens, so hopefully OS will not be reflected in our studies, and that's a good thing. So I think I would look at progression-free survival, time to next treatment, quality of life in between this.
Right. And maybe on a long-term basis, the reduction in the number of deaths, that is what this study subgroup further analyzed.
I have a slightly different opinion, sir. While because of second line, third line good options, OS may be not the most important parameter. PFS might be something that we're looking at. I don't think OS loses its relevance entirely, because this is an aggressive disease, and second, third line, at least in India, it's not like everyone is going to achieve a remission.
True.
So, and also, while it's still very early, there are newer molecules that are coming up. There are combinations, very early studies of, glofitamab, epcoritamab, combinations, all sorts of things are coming up, which have phenomenal response rates.
Yes.
Maybe they have phenomenal overall survivals as well. And if that happens, we would look at it very differently.
So very, very rightly brought out. So newer, as of now, with the current data, Pola RCHP definitely shows a better PFS and OS rates, more PFS than OS. And the newer data or newer drugs coming in might change the scenario even better. But a point well taken that the OS still has its own relevance. We should not really write it away. But the point to convey here is that sometimes the regimen that they are comparing is that at 5-year follow-up, the Pola RCHP had a sustained and significant PFS benefit, confirming results from the primary analysis. So 5-year data, a sustained PFS benefit is definitely there. Similarly, non-significant OS. So though the OS differences may not be significant most of the times, but the fewer lymphoma-related deaths were seen in the Pola RCHP arm. Now, how do you interpret this data?
So this is just, I think we are following this data. Maybe in due course of time, this non-significant OS will become significant after some time, and then we can clearly say that this has an OS benefit, because first we get the PFS, and finally after some time, prolonged time waiting, then we get the OS.
Yes, so maybe longer follow-up may divide the graphs further. Fine. So at 5-year follow-up, the Pola RCHP had a sustained and significant PFS benefits. Patients treated with Pola RCHP required 23% fewer subsequent therapies versus patients treated with R-CHOP. And overall survival, not much significant benefit. However, there was a trend towards overall survival benefit at extended 5-year follow-up. So maybe longer time is required to further assess the overall survival benefit. So in India, a multi-center real-world prospective observational study of 13,365 newly diagnosed DLBCL patients receiving R-CHOP, the best overall response at 6 months was 90%, with a 2-year PFS of 69% and 2-year overall survival of 79%. So Indian R-CHOP data against the Polaric standard, it's only the data comparison. So the two large studies of Indian data of 2022 and 2023 by Dr. Reena Nair group compared to the R-CHOP of Polarix and our CHP of Polarix arms. So if you see the 3-year and 5-year overall survival are better as compared to our standard R-CHOP arm. The differences may be of the tune of 7 to 10% only in different groups, 2-year, 3-year or 5-year OS or PFS. But yes, Pola RCHP is tending to show better results. So how do you perceive the safety profile of Pola RCHP in comparison to R-CHOP? So how many of you have already used polatuzumab? Has anyone of the 4 panelists? Yeah. So how is your experience in using that? How much do you find similar kind of infection profile, side effects profile, or it's different than R-CHOP? Yeah, no problem, sir.
I think we'll need standardized data for me to comment, but in my practice, I've not noticed it being vastly different in terms of, because I think what determines who's coming with infections is more of the anthracycline dose rather than the Pola itself. I'd like to hear what others have seen.
I think administering Pola RCHP and following up the side effects, it's been quite easy. The absence of vincristine related side effects is positive, but otherwise no major problems with the protocol.
Okay. Anyone has a different experience?
Well, sir, the infection profile is little different. I have seen some patients, especially elderly population, having more infections with polatuzumab based treatment. So yeah, in an elderly setup, I'll be a little more careful. In a young population, it's almost similar.
Yeah. So even in elderly, we do not give full dose R-CHOP. As it is, if we prefer to choose, we will choose mini R-CHOP most of the times. Yeah. So between the three, you will say comparative safety profile or a less favorable safety profile?
A shade better maybe.
Shade better, okay. So Pola RCHP, the statement is a favorable benefit to risk profile compared with R-CHOP, though actually the data shows almost similar kind of side effect or adverse events profile, but overall the benefit risk profile ratio favors Pola RCHP arms, but that is a very minuscule difference. So safety profile remained comparable between the treatment arms with no increased risks with long-term follow-up. Okay, peripheral neuropathy. So R-CHOP definitely has more peripheral neuropathy due to the vincristine part of it. So coming to a second case, this is an old patient with newly diagnosed high-grade B-cell lymphoma, and she's a widow. Clinical presentations are bilateral neck swelling, fever and moderate weight loss over 4 weeks. Performance status 2, comorbidities, hypertension and diabetes controlled on medications. PET CT, hypermetabolic diffuse lymphadenopathy with bulky disease, both sides of diaphragm. Bone marrow involvement, elevated LDH, IPI score 5, CNS IPI 5, biopsy aggressive CD plus 20 plus B cell lymphoma, immunophenotype CD10 plus, BCL2 60%, MYC more than 90% and KI67 more than 90%, highly proliferative. But the cell of origin here is a GCB subtype. And since this is on immunohistochemistry, the MYC and BCL2 positive, this form falls into a double-hit lymphoma. The previous one was I think the fish was
double expressor.
Yeah, double expressor.
Actually,
so basically the question is, how are you going to diagnose the double-hit lymphoma? A fish in all the patients or a selected few?
So all the patients.
All the patients. So most of us will send a fish for all the patients. Okay. So what are the clinical challenges in managing such a patient? She is a 72-year-old with comorbidities. Yeah.
So we can't aim at curative treatment for this.
Okay. So the intent has to be, Dr. Tejaswini?
I would look at her frailty. I would look at her how badly or well managed are the comorbidities, and then take a call.
Okay. So high-grade B-cell lymphomas are a therapeutic challenge and their optimal management remains undefined. Tolerance of intensive regimens in old patients is always a challenge. There is, in this patient, as it is CNS IPI was high, so it's a higher risk of CNS relapse. And this patient is, the aim should be to achieve a long-term remission. And usually these patients are not eligible for subsequent treatments, as the first treatment toxicity is enough for them to be able to tolerate further. And double-hit lymphomas now in due course with the dark zone signature, gene expression profiling positivity will carry a further aggressive clinical course and have poor outcomes with standard treatment. So how would you treat your double-hit lymphoma patients with the following profiles? Whether the patient is young or fit elderly or unfit or frail but has a curative intent. So the first part, young or fit elderly, what would you choose? Di-EPOCH. So you prefer di-EPOCH over polar RCHP?
Polar RCHP has not, in the trial, I think specifically for double hit or GCB, it has not shown an advantage. So we can't directly, I think, switch over to that.
Okay. Dr. Akash?
Sir, I think polar RCHP is still good in a young, fit elderly, or a fit elderly. And in a frail setting, well, this is what I was talking about. This is where I'm worried to use what, because as you said, we will try to give a curative intent, but we not achieve it properly. And in getting one, he might have bad complications. So here I'll be maybe using Pola with reduced dosed CHP, like a mini kind of a regimen.
So
Pola
as of now, there is no Polar mini CHP.
Yes, sir.
As of now,
this is what I tend to choose if patient is affording for polatuzumab. I'll reduce the dose of Pola even to not to the ideal dose, reduce to 1.2, and then even the CHP might be reduced.
Okay. Any difference of opinion, Dr. Tejaswini?
I still tend to give R mini chop to a lot of my elderly frail patients.
R
mini chop.
R mini chop, elderly. Okay. What about Dr. Anusha? And
again, I think depends on the finances.
Okay.
If they can afford it, Polar CHP.
Yeah. Yeah, Dr. Anusha?
Young fit stage 4 double hit, definitely I would offer di-EPOCH.
Okay.
In an elderly, 71, many 71s are still fit. I would not rule out a curative intent therapy. I would do it on a case-by-case basis. Even with our mini chop, we tend to only reduce the anthracycline dose. Most of them tolerate the other drugs well, because the full-blown R mini chop outcomes are quite dismal, and it was more than 80 years of age. And this is a particular subgroup. If I'm not looking at a curative intent therapy, I'd be very keen to know what's there on the NGS, if there's anything targetable and there's any maintenance with the BTK possible. I know I'm skipping a few steps here, but maybe, yeah, this is what I would do.
Okay, so all of us have a difference of opinion, fine enough. That is always possible in an academic forum. So though the final word here is not out, but yes, as I will show, the Polarix data extrapolated does favor Pola RCHP in the young or fit elderly, and even for unfit frail, it tends to show better responses. But yes, as of now, this is only an extrapolation of subgroup analysis. So maybe more data is required, but the overall data with the extrapolation subgroup analysis, the hazard ratio favors the Pola RCHP over an R-CHOP arm, as you can see on the graphs as well for high-grade B-cell lymphoma. But yet, it is recommended for DLBCL, not yet fully, I mean, all of us would not yet directly extrapolate. Yes, yes. So, sir, the data of Polaris is showing extrapolation. Double hit, not. It is the ABC subtype which definitely has a favorable profile. GCB. No data. So di-EPOCH for young fit elderly, fine, and for frail, R mini chop is still the way to go. That is the final word. Yes, sir. No, so there is the only thing is the subgroup analysis. They're extrapolating that elderly also will tolerate Pola as well. That's all. So dark zone signature, I think no point discussing it since the facility is not available. So I think I'll move on with this. Yeah, double hit signature lymphoma, cell of origin. Even I can't see the slides here. Can I increase the? So this is based on the cell of origin analysis. Can I increase the contrast on the screen here? It's becoming darker now. Contrast. उधर से कर रहा इतनी वाले छोटे ग्राफ तो I can't see it and read here. उधर ही देखना पड़ेगा. चलो कोई बात नहीं. ठीक. Yeah, so double hit signature lymphoma, as we can see, this is cell of origin and refined cell of origin analysis for the freedom from progression. The GCB subtype has a better freedom from progression as per the graphs here. And patients with dark zone signature positive DLBCL who were almost exclusively germinal center B DLBCL and represented the majority of high risk double hit or triple hit had a potentially better outcome when receiving pola RCHP versus RCHOP. So Rajan sir, this was the probable point of discussion here. No, it's not significant. It is non-significant. It's an extrapolation, that's all. So management of older DLBCL patients, the DLBCL in elderly, you have to, as Dr. Tejaswini brought out, a comprehensive geriatric assessment with frailty assessment and supportive care with a prephase, maybe a corticosteroid, and then if they are fit enough, less than 80 years old, R-CHOP with GCSF, and more than 80 years old, R-mini-CHOP. This is the recommendation. And for the unfit, anthracyclines are contraindicated, so you may choose any of the other chemotherapy combination regimens with R-CEOP, R-GEMOX, R-CGVP, or other impairments, R-mini-CHOP or R-mini-COP. And sometimes we only may need to give a symptom control with radiotherapy in the background of R-mini-CHOP. So challenges in elderly DLBCL patients are prognosis for older patients has improved with rituximab, but still lags behind younger patients, and they have several comorbidities with limited organ reserves, fear of toxicity, and altered drug pharmacokinetic and pharmacodynamics. So impaired physical and cognitive functions can further compromise and lead to increased hospital visits. So frontline treatment in older DLBCL patients, if you see with different regimens with R-mini-CHOP, R-GEMOX, R-CHOP21, CEOP21, Benda-R, Pola RCHP, only the 2-year and 2-year PFS and OS tends to be better with Pola RCHP. So again, progression-free survival and overall survival for Pola RCHP, the analysis included 284 elderly patients with a median age of 74 years, where IPI was high. So Pola RCHP shows significant clinically meaningful improvement in progression-free survival, and there is a trend for improved overall survival in favor of Pola RCHP.
So the median was 75 years?
74. Yeah.
And what was the maximum age, sir?
Maximum. So is there an age given?
70 to 80 is the range.
Yeah,
so, yeah.
70 to 80. Yeah. So median age of 74. Yeah. So Polarix older patient analysis efficacy endpoints favored Pola RCHP. Again, the benefit risk profile favored Pola RCHP in older patients with previously untreated, first line. So to conclude, there was a significant and clinically meaningful improvement in progression-free survival and a trend for improved overall survival in favor of Pola RCHP with a 36% reduction in the risk of disease progression, relapse or death with Pola RCHP versus R-CHOP in patients aged more than 70 years. The safety profile of Pola RCHP in patients aged more than 70 years with previously untreated DLBCL was generally similar to that of R-CHOP and consistent with that reported for the overall population. So the risk benefit profile observed in the intention to treat analysis were marginally better in the elderly population. So further, this is a theory further of the DLBCL patients. Likelihood of cure is highest with treatment in the first line setting. After diagnosis, first line treatment, only 60% patients could be cured by first line R-CHOP. Further, there is disease progression or relapse. 30 to 45% of patients have relapsed refractory DLBCL after receiving first line. Further, they go on to second line treatment with CAR T cell therapy or multi-agent induction chemo with or without high dose chemotherapy and autologous transplant, and further disease progression, and then further they may need a third line treatment or beyond. No standard of therapy. Median survival is about 7 months. As we all know, one of the commonest non-Hodgkin's lymphoma. So I think I'll move on with this. Again, it's a heterogeneous disease with multiple subtypes based on different analysis of cell of origin, the lymph gen analysis, the dark zone signature analysis, the ABC GCP standard immunohistochemistry or flow cytometry. Very, very confusing here. I think I'll skip this repetition again. So R-CHOP has been a standard of care for about more than 20-25 years now, which shows a good progression-free survival and overall survival. So there was an unmet need with R-CHOP. With low IPI, early disease stage and GCP phenotype, R-CHOP high curability results. But with high IPI, higher age, non-GCP phenotype, dual protein expression and MYC BCL2 rearrangement, there was low curability. So in between these periods, different regimes were tried with the combinations of Gazyva or lenalidomide or bortezomib, ibrutinib, bevacizumab, gemcitabine. Practically, none of them showed better responses as compared to R-CHOP, and this unmet need is partially met with Pola RCHP in certain subgroups of DLBCL, especially the ABC subtype. So it is the only newer regime which has improved survivals or treatment outcomes in first line DLBCL and now is FDA approved. So the current recommendation for, I will come directly to the final slides. So adverse event profile practically similar to R-CHOP with relatively lesser deaths in the study group. So newly released guidelines, first line DLBCL, 0 risk factor, 1 risk factor, more than 2 risk factor, Pola RCHP in high grade lymphomas for 6 cycles. And NCCN guidelines now give category 1 recommendations for especially the stage 3 or 4 disease vis-a-vis R-CHOP. None of these, both are still recommended as first line. One has to choose based on finances. And as Dr. Abhishek chooses, DA-EPOCH-R also still is considered as first line therapy. So there is a trend towards Pola RCHP giving better responses in certain subgroups, especially the ABC subtype. However, the R-CHOP still remains the standard of care, and those adjusted EPOCH for young patients with higher risk stratification, one may still end up choosing DA-EPOCH-R if finances are a concern. So to come to the last word, to maximize each patient's chance of cure, delivering the most effective frontline treatment with comparable safety is essential, as this approach reduces the risk of relapse and subsequent need for additional treatments. Polarix is the first trial in over 20 years to show a meaningful improvement in the benefit risk profile over R-CHOP in an international phase 3 double-blind randomized controlled trial. So long-term follow-up analysis confirms an ongoing and encouraging progression-free survival benefit and indicates a positive trend in overall survival in favor of Pola RCHP. The benefit of this regimen holds even more importance in India with limited availability and access to efficacious treatments in relapsed refractory DLBCL. So thank you, audience. Thank you to my panelists. If there are any questions or discussions, please.
I have one question. What is the use of giving 2 additional doses of rituximab as used in this Pola RCHP trial? What are the other takeoff for the other participants in this on this take? And second is what is the role of interim PET in the with use of Pola RCHP? Like it's seen in advanced stage, also there is no role.
Okay. So anybody? Yeah, Dr. Akash or Dr. Dr. Anusha, okay.
I am not giving 2 additional doses of rituximab, and I do an interim PET. I'm always cautious when I do it, but I want to know I'm heading in the right direction. I warn my patient that my treatment decision is most likely not going to change, but I still do an interim PET just to pick up the odd few who are having a progression probably. But you're right, the evidence doesn't suggest interim PET based escalation or de-escalation. But it's a little bit of a head scratcher, but I think it's a little reassuring after 3 cycles to know we are in the right direction. Not the ideal indication for an investigation, but I think most of us are doing it.
Yeah, Dr. Akash, anything you wanted to add?
No, yeah, sir, rightly mentioned, PET CT just can pick up the outliers maybe. That's all we are trying to get. and there's a satisfaction in the head of us and the patient that we are heading towards the right direction. I also, regarding the rituximab, I think it's just a trial design.
Yeah,
like
exactly. The answer is that's a trial
there
design.
is no
So
specific.
It's need not be exactly replicated. So, Dr. Rajan sir, you were nodding. Something to add? Yeah.
What about 2 additional doses of rituximab?
No, so that's a trial design. NCCN protocol, NCCN, that interim assessment still mentions an interim assessment in this arm of treatment, but the additional 2 doses of rituximab is not as a standard recommendation. Though 6 cycles of polar RCHP is recommended, and interim assessment, again, it's objectively not recommended, but some of us end up doing it.
In some European guidelines, they are following 2 doses of rituximab also.
Yeah, okay. Does anyone of us give additional dose of rituximab after polar RCHP or even RCHOP? No, I don't think so. No role of maintenance. Polar RCHP. So no role of maintenance per se, or no, I don't, anything, Dr.
I'm just saying that, but there is an RCHOP trial also which has the 2 additional. I mean, it's
Okay.
like you said,
so it's a trial design. It's a
yeah.
trial design, yeah. It was designed that. So as Dr. Rajan said, the part of the subgroup analysis is only a retrospective subgroup analysis. So it was not part of the assessment, the primary assessment. The primary assessment, and the final word here is that the ABC subtype with young fit patients, the data is definitely promising in favor of polar RCHP. It is being extrapolated to elderly, that it is showing a favorable profile, favorable reduced risks of deaths, and tolerability is as equally efficacious. But as yet there is nothing called a polar R mini CHP.
Anybody doing lenalidomide prophylaxis in elder maintenance in elderly?
DLBCL. In DLBCL, no.
In elderly?
There is no OS benefit. It may delay a relapse in the ABC type, but that's
especially if you're going for a mini chop like regimen.
We have given it occasionally to an ABC, but again with the explanation that there's no OS benefit.
Yeah. So no recommendations, but anecdotal, practice-driven, desperate measures, or I would say some drugs, some combos are tried as a 3rd line, 4th line agent to give something to the patient when we've exhausted the primary lines, or patient is unfit to tolerate any certain course of chemotherapies. Okay. Thank you, panelists. Thank you, audience.
Thank you. Thanks to the moderator, chairperson, and all the panelists. So we are coming to close the session, but before that, an exciting quiz. And for that, I would like to invite the quiz master, Dr. Bharat. Over to you, sir, to explain the rules. And I request all the students to come forward and involved in maximum participation. Students are requested to sit in the front benches. I can't see anyone.
good evening, everyone. I think we have a lot of contestants for this this screening round of this quiz. I can see 1, 2, 3, 4, 6, 7, 8, 9, 10, 11, 12, around 15 contestants for a lot of exciting prize amount. So we have 10 screening questions and we have 4 options for each. Let's come to the rules that we have. I will just keep it like this. So we have 10 questions with 4 options each. The right answer will give you 1 mark, and choose wisely because wrong answer can give you minus 0.25 marks also. And so we have initially decided about selecting 5 students for round 2, but now we are thinking to get 7 students for round 2. And that will give you total 50,000 in cash prize. So before we start the screening round, I will just want to tell you that we'll give you 30 to 45 seconds for each question. You can just mark A, B, C, D, whichever you feel it is right. If you don't know the answer, please skip the question because if you give the wrong answer, it will get you minus 0.25 marks. And I think the questions are not very hard, so every question will matter. So be wise while choosing your answers. So should we start the quiz? Everyone is ready? Can I hear some yes? Everyone is ready? Okay. So let's start the question 1. So if ATRA taught us that AML cells can mature instead of being destroyed, which emerging AML treatment is trying to repeat that idea in NPM1 mutated and KMT2A rearranged AML? So we have 4 options for this, and the options are option A, FLT3 inhibitors, option B, BCL2 inhibitors, option C is menin inhibitors, and option D, IDH1 inhibitor. Do we have timer? Yes. Yeah. Should we go to the next question? Yeah. So this is a hardcore hematology question. So if HBD Punjab is a variant of hemoglobin that is derived from point mutation in beta D globin gene, replacement of 121 codon with GAA to CAA. So in beta globin gene, it is also called as, HBD Punjab is also called as, we have 4 options here: HBD hemoglobin San Diego, hemoglobin D New York, hemoglobin D Ibadan, or hemoglobin D Los Angeles. I think I can see a lot of oncology students also. It must be difficult for you, I can assume that. Now coming to the third question. So which cytogenetic pattern should make you think I should check TP53 mutation? So options are like this: normal cytogenetics, complex karyotype, translocation 1517, and D option is trisomy 8 alone. Nobody is cheating in this quiz. That's good. Okay, coming to the question number 4. This is a difficult question for everyone, I guess. Vex's syndrome. This is new syndrome that is recently being defined in hematology. It is vacuoles X-linked autoinflammatory somatic syndrome. E in Vex's syndrome stands for. We have 4 options here: encephalopathy, eosinophilia, even enzyme, endoplasmic reticular dysfunction. Anyone who reads ASH updates must be knowing this syndrome. Now let's come to CAR T cell therapy, the most important lecture that we had recently. CAR T cell therapy, naming which segment specifically indicates that the product originates from T cell lymphocytes. So we have 4 options: A, TISA, B, Gen, C for Lu, and D for cell. Which part of naming of T cell indicates that it is from T lymphocyte? We have a lot of sessions in CAR T recently. Let's come to question number 6. So we have Indian first CAR T cell therapy. The correct product name is, I think the next CAR people are here. No, they are not here. So the options are Tisagen laclucil, Axicaptagene silolucil, Actacaptagene autolucil, or Brexucaptagene autolucil. Few of them are foreign CAR Ts and one of them is Indian CAR T. So just for information, we have one children book about CAR T cell also. So if you have any kids who are undergoing CAR T cell treatment, you can offer this book, CAR T cell. Yeah. Now coming to question number 7. So a patient with acquired hemophilia A develops severe soft tissue bleeding. Which of the following is recommended dosing strategy for bypass treatment, that is FIBA? The options are like this: FIBA at the dose of 50 to 100 units per kg every 8 to 12 hours, FIBA 10 units per kg, Novo 7 every 24 hours, or factor 8 infusion alone. So we recently had World Hemophilia Day and it was celebrated on 17th of April 2026. The theme for this year's Hemophilia Day was diagnostic first step to the care. Now coming to the 8th question, we are at the end of the quiz now. So this is about history. Which hematological disease was the first in which a consistent acquired chromosomal abnormality was linked to cancer, establishing the foundation of cancer cytogenetics? This was the disease that led to cancer cytogenetics in hematology. The options are like this: APML, CML, ALL, or MDS. So Mr. Walter Fleming is also known as father of cytogenetics. He established the stages of mitosis in 1882. Now coming to the 9th question. A stem cell transplant patient is given letermovir for CMV prophylaxis. What is the key mechanism of its action? You can see inclusion body in the picture in the right side, in the bottom. The options are like this: it inhibits viral DNA polymerase, blocking CMV replication. B, it inhibits CMV terminase, preventing viral DNA packaging allowing prophylaxis without myelosuppression. C, it enhances T cell immunity to recognize CMV infected cells. It blocks CMV entry into host cell. Now coming to the last question of this quiz, I can see a lot of faces. This is the last question. This is a difficult question for everyone, I guess. The recently described CRIB blood group discovered in India stands for. This group was recently discovered in India recently. So the options are like this. Cromer related Indian Bangalore, Cromer India Bangalore, common rare Indian blood, and cross reactive Indian blood. Anyone who answers this question might get the first prize. I think we are finished with the screening round, so we can just submit the all the answer sheets to Avni. You can take the answer sheets. So just one question. How many of you are hematologists? Can just raise your hand. Lot of students. Okay, 70%. Oncologists, I can assume that the quiz was difficult for you people. Okay, let's see. It must be very close quiz. Let's see the answer sheets. We'll be selecting 7 students for round 2. That will make you closer to the prize amount. That is, first prize is 25,000, second is 15, and third is 10,000. So we'll select 7 students for it. We'll do the answers and the results of this quiz tomorrow morning. So be prepared to come tomorrow morning also. Okay? Sure. That's it? Okay. Should we close? So let's go ahead with the dinner, right? Okay, we can go ahead with the dinner. We'll see you tomorrow morning.